Good morning. This is Laura Vesti. I'm the co-chair, and I'll be running it until Kavita gets here today. So welcome to the June 26, 2024 Washington P&T Committee and DUR Board meeting. We will now convene the P&T Committee meeting. I'll read the names off of the participating attendees. Please stay here when I call your name. Peter Burkett.
Here.
Kavita Chawla, I think will be joining us later. Michael Chrysalis will not be here today. Kevin Flynn.
Here.
Gregory Hudson.
You might be running late.
Okay. John McKay.
Here. Good morning.
Morning. Zoe Taylor.
Here.
And Christy Weiland.
Good morning. Here.
Next, I'll move to the Healthcare Authority members. We have Nonya Connor.
Here.
Lita Aveskis.
Here.
Amy Irwin.
She would
Here.
join us late. Oh, sorry, Amy.
Just snacking on you.
Ryan Pistaresi.
Here.
Not sure if I pronounced that correctly. Elizabeth Punsalan. Not here yet. Donna Sullivan.
I don't see her.
Marissa.
Later.
Marissa Tabil.
I'm here.
Okay. Ryan Takatoma.
I'm here.
Joey Zaretti.
Here.
Next, we move to labor and industry members, and we have Jamie Mai. Drug effectiveness review project presenters, Andrea Vintro.
Nonya, she has to be moved over to a panelist. She's in the attendee list.
Oh, thank you.
You're going to keep going and come back.
Yes.
Okay. And we have the Magellan Medicaid Administration presenters, Nina Hun. I thought I saw.
I'm here.
Okay.
Umang Patel.
Hi, everyone.
Then we have the Managed Care Organization representatives, and I'm just going to read their names off. They don't need to say here. Greg Simus, Molina Healthcare. Heidi Goodrich, Molina Healthcare. Petra Eichelsdorfer, United Healthcare. Omar Dowd, Community Health Plan of Washington. And Jeffrey Natividad, Community Health Plan of Washington. Now, Nonya is going to go over the meeting logistics for us.
Yes, good morning. The committee and presenters can mute and unmute themselves at any time, but please mute yourself when not speaking so as to limit background noise. Presenters, please share your webcams when presenting. Committee, please share your webcams during discussions and motion considerations. For stakeholder participation, the chair will read the list of shareholders' names who pre-registered to speak. We will unmute you. After the chair will ask if there are any other shareholders. If there are, please raise your hands. We'll call upon you and unmute you. You can also use the Q&A box. We'll address your questions during the stakeholder time. If you did not fill out the stakeholder conflict of interest form, please answer the questions we'll post on the screen. Your 3 minutes will start after you answer the questions. And lastly, this meeting is being recorded. Please state your name. Not necessarily, I just spoke to our transcriber every time you speak, but you don't have to say your name because they're kind of familiar with us now.
Okay, then at this time, I invite Andrea Vintro to talk to us about antiemetics that we will be archiving.
Me. Do you hear me?
Yes.
Oh, good. Okay. I was trying early on and I was a little anxious, but thank you for moving me over. Okay. So welcome everyone. My name is Andrea Vintro. I'm a research associate at the Center for Evidence-Based Policy. In February of this year, we presented 4 drug classes for this drug archiving project, and today we're finishing up by presenting the final 5 drug classes to be considered for archiving. So for this first presentation today, we have newer antiemetics. So the aim of the work is for the Drug Effectiveness Review Project, better known as DERP, to develop and present information to the Washington State Pharmacy and Therapeutics Committee on 9 drug classes that are candidates to be archived from active review by the committee. So you can see the list of drug classes that are included in this project at the bottom of the slide, and the topic for this presentation, new antiemetics, is highlighted there in green.
Andrea,
Yes.
we're not seeing your slides yet.
Oh my goodness. That would be helpful. Okay, let me go back here. Okay, how about now?
Perfect.
Perfect. Apologies for that. Okay. So here we have the aim of the project. So now the overview for this presentation. So we're going to review the topics in those darker green boxes for antiemetics. So starting on the left there, I will first define the health condition of interest that this drug class intends to address, then summarize the general epidemiology and management for the condition. Then I'll review the key information in the most recent DERP reports for this drug class, including the PICA's key questions, a high-level summary of those key findings of that report, and general findings of any surveillance that was completed after that last systematic review. And then I'll move to new actions, any new actions by the FDA since that last report, including any new approved drugs, serious or boxed warnings, and any new indications. And there I'll also present the current FDA-approved indications for all of the drugs of interest. And then finally, I'll provide a high-level summary of recommendations from relevant clinical practice guidelines for the treatment of the condition, which includes guideline recommendations about how and where these drugs are used along the treatment pathway for that condition. And then we'll answer questions. So the condition of interest for this drug class are nausea and vomiting that are associated with chemotherapy, radiation therapy, anesthesia, and surgery. So nausea is not necessarily defined as pain, but rather an uneasy sensation that comes with the urge to vomit. So basically a symptom which is typically the precursor to vomiting, also known as emesis. So nausea and vomiting are common side effects of chemotherapy for cancer and also for radiation treatment. They can result in complications, some of which are serious. Examples of serious complications can include metabolic imbalances of fluids and electrolytes, resulting in low potassium or high calcium blood levels, and those can lead to life-threatening cardiac events. Patients who are more likely to experience nausea and vomiting with chemotherapy include those who have prior nausea and vomiting with past courses of chemotherapy, individuals with a history of alcohol use, people of advanced age, the female gender, and also in non-smokers, as well as in people with a history of nausea and vomiting due to other causes, such as pregnancy. Tumor invasion in certain tissues can also contribute to the condition, and also some concomitant medications, and the type of chemotherapy, where treatments are rated according to their emetogenicity or their likelihood to cause nausea and vomiting, are also known as the Hesketh scale. Nausea and vomiting are also frequently associated with surgical procedures. So a quarter to a third of all surgical patients experience these symptoms after receiving general anesthesia. And post-op symptoms increase risks for reopening of surgical wounds, esophageal ruptures, aspiration and dehydration, among other symptoms. Individuals who are more at risk for these symptoms after surgery include those who undergo certain procedures, such as ear, nose, and throat surgical procedures, or open abdominal surgeries, for example. Also, if the surgery is prolonged, where individuals might receive additional anesthesia, and certain types of anesthesia are more or less likely to trigger these symptoms, as are certain patient characteristics. And those are similar to those listed for chemotherapy. So the etiology of pregnancy-induced nausea and vomiting is unclear, but researchers think it may follow a similar neurophysiologic pathway as that nausea and vomiting that's triggered with chemotherapy and post-op. However, some additional theories do include changes in hormones associated with pregnancy. The condition is quite common during pregnancy and affects up to 85% of pregnant individuals. Symptoms typically start by 6 to 8 weeks gestation and subside before 20 weeks. The most severe form, known as hyperemesis gravidarum, affects between less than 1% and up to 3% of pregnant individuals. And it's characterized by a debilitating chronic nausea, intractable vomiting, dehydration, electrolyte imbalances, ketosis, nutritional deficiencies, and weight loss. A recent systematic review reported an association between the severe form of condition and preterm delivery, as well as infants who are small for gestational age. Pregnant individuals who are more likely to experience these symptoms include those with a family history of nausea and vomiting, or prior history with pregnancy or other scenarios, multiple gestation, as well as some genetic fetal conditions. So historically, pharmacologic treatments that were commonly used as antiemetics included histamine 1 blockers, dopamine antagonists, metoclopramide, and also droperidol, which actually declined in use for the prevention of post-op nausea and vomiting in the early 2000s because of the new box warning about risks for cardiac complications. And to note, all of these agents are still being prescribed and used. However, drugs for the prevention of nausea and vomiting are becoming more common now, and sometimes they're called anticipatory antiemetic therapies. These agents work more in the central nervous system versus agents that are directed more at modulating the GI motility, also known as prokinetic agents. So for the prevention of nausea and vomiting with chemotherapy, clinicians first look at the emetogenic capacity of the chemotherapy, and then they also consider the likelihood for these symptoms to be classified as acute, delayed, anticipatory, breakthrough, or refractory. For chemotherapy with low to moderate emetogenicity, serotonin agonists alone are commonly prescribed, or in combination with dexamethasone. And the number of doses also is a variable which is adjusted depending on other risks for nausea and vomiting. And then for chemotherapy with higher emetogenic potential, a combination of these drugs are often used. So ginger and acupuncture and acupressure are also commonly recommended, and those are non-pharmacologic interventions, of course. So to prevent these symptoms after surgery, it's first recommended to find ways to use less anesthesia, including using regional versus general anesthesia if possible, and also to provide adequate oxygen and hydration during surgery. And then for pharmacologic prophylaxis, the most common agents that are used include the newer serotonin antagonists, dopamine antagonists, corticosteroids like dexamethasone, and also antihistamines and anticholinergics. So for pregnancy-induced nausea and vomiting, non-pharmacologic treatments are typically recommended for more mild symptoms, which include changes in diet, hydration, also stress reduction techniques. And then for more severe symptoms, these agents listed here are more commonly prescribed. So noting that corticosteroids are considered as third-line treatments and also not recommended for use earlier in pregnancy because of some reported risks for oral clefts in fetuses. Okay, so 4 reports prepared by DERP on this topic. The last DERP systematic review for antiemetics was completed and presented in January of 2009. That's about 14 years ago. The sources were searched through April of 2008 for that report. DERP conducted 8 surveillance reports, or scans as they were called back then, since the last report, with the last surveillance presented in August of 2018. And the sources searched for that surveillance were through May of 2018. So the next 3 slides list the PICOs for the DERP products for antiemetics. The population included adults and children at risk for or with nausea and or vomiting, if they were related to chemotherapy, radiation therapy, surgical procedures, and pregnancy. For comparators, they included another listed intervention, so any head-to-head study. Also, another FDA-approved medication used to treat nausea and vomiting. And also placebo-controlled trials were considered if there was limited or no other evidence for that particular drug. For study designs, they included randomized controlled trials, systematic reviews, and also observational studies only for the purposes of reporting safety outcomes. So this table here lists the newer antiemetics that were included in the last report. They are in alphabetical order. So we have aprepitant at the top, which is a neurokinin 1 receptor agonist. So neurokinin 1, which is also known as substance P, was found to also attenuate that responsiveness of serotonin receptors. So it's sometimes included under the category of serotonin antagonists. The oral formulation was approved in 2003. Then in 2008, a phosphorylated analog of aprepitant called fosaprepitant was developed for injection delivery, and the brand name for both of these formulations is Amend. The next three listed drugs are considered first-generation serotonin receptor agonists, with dilazatron approved in 1997, then granisetron approved both as an oral agent and an injection in 1993, and then as an extended-release transdermal film in 2008. And ondansetron with a brand name Zofran was approved in 1991 and has both oral and injection formulations. The bottom row there we have polanozitron or Aloxi, which is considered a second-generation serotonin receptor agonist, and this drug was approved in 2003, also both as an oral and injection formulation. So outcomes for the most recent report included success at different time points, which is defined as sort of absence of nausea and vomiting episodes. Number of emetic events, the degree of nausea, the number of emesis-free days, time delay until the first emetic event, the need for rescue medications, patient satisfaction and quality of life, the length of hospital stay, and several measures for adverse events. There were 3 key questions in the most recent report. So key questions 1 and 2 asked about the comparative effectiveness and harms evidence of the included agents for treating and preventing nausea and vomiting. And then key question 3 asked about any differences in these outcomes across patient subgroups, including people of different ages, racial groups, gender, or conditions of pregnancy, among other patient characteristics. So to answer these key questions, the most recent report included 185 studies, of which there were 81 head-to-head trials, 77 placebo or active controlled trials, 14 systematic reviews, 12 observational studies, and 1 pooled analysis. For the summary of key findings, as a reminder, these are very general and high level. So overall, they found no differences in effectiveness for dilazatron, granisetron, and ondansetron in adults for prevention of chemotherapy-induced or postoperative nausea and vomiting. And there were no differences between dilazatron and ondansetron for prevention of post-op nausea and vomiting in children. There was some evidence that ondansetron was less likely to reduce the need for rescue therapy compared with dilazatron, but there was no difference in response compared with granisetron. And then finally, at the bottom there, ondansetron may be associated with more frequent specific adverse events compared with granisetron, namely dizziness and abnormal vision. However, there were mixed results compared with dilazatron in adults treated with chemotherapy. Also, ondansetron demonstrated inconsistent results in studies of post-op nausea and vomiting. For aprepitant, they found it was more effective compared with dexamethasone in adults for chemotherapy-induced nausea and vomiting, and non-inferior with ondansetron in patients with for the prevention of post-op nausea and vomiting. But there were no differences in adverse events between these treatments. For pelanozitron, they found it was more effective or non-inferior compared with dilazatron and ondansetron in adults with chemotherapy-induced nausea and vomiting, and may be more effective in children compared with ondansetron. Again, there were no differences in adverse events between these agents. And then they also reported that they had a concern around the lack of evidence for the topics that are listed here. So treatments for or prevention of these symptoms in children, undergoing either chemotherapy or who are post-op. Also, individuals undergoing radiation therapy, some quality of life measures, studies for pregnancy-induced vomiting, nausea and vomiting, as well as these outcomes of serious adverse events across all of these drugs. Surveillance after the most recent DERP report was through May of 2018, and within that time period, 3 newly approved antiemetic agents were identified. So doxylamine succinate plus pyridoxine hydrochloride was approved as 2 different dose oral tablets by 2 different manufacturers in 2013 and 2016. This drug is a fixed dose combination product of an antihistamine plus a vitamin B6 analog. Nitupetant plus palonazitron with the brand name Akynzeo was approved as both an oral capsule and intravenous infusion in 2018. This drug is a combination agent of neurokinin-1 receptor antagonist plus a 5-HT3 serotonin receptor agonist. And then finally, we have rolapitant with brand name Verubi, available as both an oral tablet and an intervention infusion solution, with that oral agent first approved in 2015. And that agent is a neurokinin-1 receptor agonist. So this period of surveillance also found 8 new formulations or generic approvals. No new boxed or serious warnings were identified, and 76 new eligible studies were identified, of which 34 were head-to-head trials. 22 trials compared the addition of a neurokinin-1 agonist with standard therapy, and then there were also 20 potentially eligible placebo-controlled trials. Now we'll switch over to the new FDA actions since the most recent DERP report. So the first agent listed at the top is amilsapride with brand name Barhemis. This agent was approved in 2020 for the prevention of post-op nausea and vomiting in adults. This agent is a dopamine receptor agonist. It's delivered intravenously. And the next 3 listed agents were those that were identified in surveillance. So we have doxylamine succinate plus pyridoxine hydrochloride, which was approved for the pregnancy-associated nausea and vomiting, and then nitupetant or fosnitupetant plus palonzitron, as well as rolapitant, and those were both approved for the prevention of chemotherapy-induced nausea and vomiting in adults. So for new FDA indications since that last report, we found both new and removed or retracted indications for 3 drugs. So the Amend brand's oral capsule of aprepitant was expanded to include pediatric patients at least 12 years of age in 2015 for chemotherapy-induced nausea and vomiting. And then in 2019, the indication for post-op nausea and vomiting in adults was actually removed. For the indication, the injection formulation of Amend, which is fosaprepitant, this agent was approved for expansion to include pediatric patients 6 months of age or older, and that was in 2015. And then for palonazitron, the FDA removed the indication for the pediatric populations in April of 2020, primarily due to the lack of evidence in that group. So here are the FDA-approved indications for the included antiemetic agents in this report as of January of this year. So first you can see that in row 3 of the included agents, dilazatran was discontinued. As we move along the top row of indications to the second column, we see the indication for the prevention of post-op nausea and vomiting in adults. So 3 drugs have been approved for this indication. And you can see as we walk down the column, and these agents are amilsapride, granisetron, and ondansetron. In that next column, we see 6 of the 8 agents currently on the market are approved for the prevention of nausea and vomiting associated with chemotherapy. And do note that that notation with that letter B there indicates that this is a conditional indication, which means that the approval for aprepitant, nitupetant plus palonzitron, and rolapitant is in combination with another antiemetic agent. In other words, these are not indicated to be used as monotherapies. for nausea and vomiting. Next, we go to the indication for nausea and vomiting during pregnancy, and we can see as we scan down this column for number 4, we see only one agent is approved for this indication, and this is the fixed dose combination product of doxylamine succinate plus pyridoxine hydrochloride. And then in the far right column, we see that only ondansetron has been approved for the prevention of nausea and vomiting that's associated with radiation therapy. So since the most recent report, there were no new serious or boxed warnings identified, but there were a few warnings or precautions that might be of interest to you. So those are listed here. So for generic status, in this first of 2 slides, you can see in the bottom row of this table that granisetron was already available as a generic drug in the 2009 report. Since 2009, 2 more agents became available as generics, and those include aprepitant and its injectable formulation, fosaprepitant, and the fixed dose combination product of doxylamine succinate plus pyridoxine hydrochloride as a delayed release tablet. It was estimated that the developer of amilsapride will lose exclusivity status in February of 2024. That information is based on IPD analytics, but there were no applications for generic manufacturing submitted at the time that this report was prepared. And then dolazetron in that row 4, as you can see, was discontinued, as I mentioned earlier. So on this slide, 2 of generic status of the drugs, we see that ondansetron was already available as a generic in the last report. Pelinozotron monotherapy is newly available as a generic since 2009. And then the developer for natividin plus pelinozotron and the developer for rolapitant have exclusivity through 2031 and 2028 respectively. So we likely won't see generic versions of those agents for some time. There were no new pipeline therapies identified for nausea and vomiting for the conditions of interest. I did want to mention these 2 points for completeness of this report. So dronabinol, which is a cannabinoid, it was approved in 1985 for chemotherapy-induced nausea and vomiting. And scopolamine has been approved since 1979 for post-op nausea and vomiting, in addition to motion sickness. Of course, these have not been included in any prior DERP report, so we're not including them as new agents for this archive report. So on the next 4, this is the next 3 slides, we're providing a general summary of clinical practice guideline recommendations for the treatment of these symptoms, including recommendations for how and when to use these agents along the treatment pathway. For this section, we began with the information from the up-to-date clinical decision support online resource, and then cross-referenced that information with key practice guidelines from professional medical associations, which are listed on the last slide of this deck. For chemotherapy-induced nausea and vomiting, so the guidelines recommend treatments based on the expected emetogenicity of the chemotherapy. The 4 categories of drugs recommended to consider include serotonin receptor agonists, neurokinin-1 receptor agonists, glucocorticoids, and olanzapine, either alone or in combination with each other antiemetics. Also, combination therapy is recommended for those chemotherapy treatments that are considered more highly emetogenic. For serotonin receptor agonists, some guidelines don't specify a preferred drug, while others report evidence for pelinozotron as being more effective. They do warn that first-generation agents should be avoided in patients with congenital long QT syndrome, and also to measure potassium and magnesium levels while patients are on these agents and correct those metabolic imbalances as needed. They also mentioned that injected dolazetron is contraindicated in both children and adults, but as I noted earlier, it appears that agent may be discontinued at this time. For neurokinin-1 receptor agonists, they do not call out one drug over the other in that category. So for glucocorticoids, dexamethasone was mostly recommended, and then when olanzapine is indicated, they recommend, the recommendation was to use it in combination with other antiemetics. And they acknowledge that when using olanzapine, it would be considered an off-label use for this drug. So for radiation therapy and surgery, we have those two on this slide. So for radiation therapy, the recommendations are similar to those for chemotherapy, and also like chemotherapy, treatments based on the likelihood of these symptoms with a particular treatment. So location of the radiation and the volume of exposed body surface are considered typically. So for example, if the treatment is a total body radiation, or directed towards the head or abdomen, these may they may be more considered more emetogenic. For lower or minimal risk of nausea and vomiting, prophylactic treatment is typically not recommended. And also of note, the guidelines mention that there was less evidence for treatments attributed to radiation therapy. For post-op nausea and vomiting, the guidelines recommend to include antiemetics as part of the opioid-sparing post-op pain control plan for all patients. Delivery is typically a single intravenous dose after surgery. That was recommended as typical. And the guidelines then mention that treatment plans should be based on risk scores for individual patients, where type and duration of surgery should be considered, as I mentioned earlier, and treatment plans can include 1 to 3 antiemetics from different drug classes. Also, regional anesthesia is preferred over the general anesthesia if possible, and then non-pharmacological techniques of acupuncture was reported as having demonstrated some effectiveness compared to other antiemetic drugs. And just noting that acupuncture is not a common treatment in children. For pregnancy-induced nausea and vomiting, the guidelines mention that treatment goals should include reducing the severity of nausea and vomiting to improve the quality of life during pregnancy, also correcting any fluid and electrolyte imbalances, preventing serious complications of persistent vomiting like weight loss, and then to minimize any risks to the fetus should the individual require pharmacotherapy. First-line recommendation are non-pharmacologic, and those include dietary changes to foods that trigger nausea, taking the prenatal supplement with food or trying one without iron, ginger supplements, acupressure, wristbands. And then if symptoms worsen or are persistent during pregnancy, the guidelines recommend these next steps, and those are in order on this slide as we walk down the bullet points here. So first, vitamin B6, also known as pyridoxine, should be considered alone or in combination with the antihistamine doxylamine. They also mention that if these symptoms are without hypovolemia, other antihistamines can be considered, including diphenhydramine and dimenhydrinate. If those treatments remain unsuccessful and the condition continues to be more serious, other options could include in this order. So we have dopamine antagonists, which are prokinetics, and then lastly, serotonin antagonists can be considered, specifically on ondansetron or granisetron, because of the availability of some evidence for this in this population. However, the guidelines were clear that evidence for safety of serotonin antagonists in pregnancy is very limited. So on this last content slide here, we list the relevant key clinical practice guidelines, which were also referenced in that guidelines section. They're listed in alphabetical order by author or professional association, and the publication or guideline updates date ranges are from 2018 to 2020 for this drug class. So this is that's the presentation. Thank you for your attention, and I'll pass it back to you all.
Thank you very much, Andrea, for that. And Kavita has now rejoined us, so I will pass it on to her as the chair to take over. I did have one question for you, Andrea. So I know that aprepitant, the emulsion formulation, we're now using pre-op for patients that have a high risk of post-op nausea, vomiting. And I believe that it was only the Amend capsule brand that had the indication for post-op nausea, vomiting removed. Would that be an issue for any patient that would need that medication post-op? if we did this update and didn't include the fact that the generic was still available for that indication?
That is a good question. I can look into that and get back to you. I don't know if Rhonda or Beth is on the call and they can comment to that. I can look into that and get back to you.
Sounds good. We just recently approved the IV aprepitant prior to high risk patients for high risk nausea vomiting after post-op. So that's kind of why I knew that.
Great.
Thank you, Laura. I have a very basic question, more from a clinician standpoint. I'm looking at the medications included in this review, and the couple that come to mind that we often use are metoclopramide and promethazine. Are they not considered antiemetics officially to be included in this review?
I believe that we had a list that was given to us to include, but that, what was the other one? Metoclopramide, and the other one was?
Promethazine. And the reason I'm asking the question is because, like, as I'm reviewing the motion, looking ahead, we're going to list all of the medications that you reviewed, and we're going to say that the preferred drug list must include at least one of these medications. And so I'm wondering, and I wonder what the rest of the committee thinks about this as well, that should those medications that we commonly use in clinical practice also be included in this med list, especially for the motion.
So this is Ryan Pistoresi. I can provide a bit of historical context.
Thank
So
you.
for the
Yeah.
metoclopramide and the procarizine, those were also used for other indications. And so this was supposed to be more of newer antiemetic drugs. So for our Washington PDL, which we're making this motion for, we've always just looked at this more narrow list of the newer antiemetic medications, just knowing that there are other medications in other drug classes, that also are used for other indications that can be used clinically.
I see. So they might already be on the preferred drug list, but just under another umbrella.
Right. So
Drug
for
class.
UMP, yeah, exactly. Yeah. So for UMP, they are, covered as preferred alternatives. It's just that these were the newer, the more expensive ones, back in the early 2000s, which is why the states created this as a report. And also over the years, this has changed, and that's why we're no longer getting updates on this report. There are fewer newer drugs coming out in this class. The evidence is pretty stable. We're not seeing a lot of too many changes. I mean, obviously, what was reported today encompasses a lot of changes that we've seen over the last, I think, 6 years or 6 or 7 years. So that's a lot. But again, it's not something that we are updating every year like we are trying to do with some of the other drug classes where we're seeing a lot more new evidence being published, new drugs coming to market, or new safety concerns being discovered.
Great. Thank you, Ryan. Other questions or comments from the committee members? Okay. Seeing none. So Nanya, I'm gonna lean on you here. Do we do the motion any differently if it's for an archive drug class? If we're proposing an archival of the drug class?
No. Excuse me. No, we don't do anything different. Only towards the end you see that we're going to do a motion to archive all the drug class that we're going to go over today.
Oh, got it. Okay, great. Thank you. So committee, are we ready to review the motion then?
I also do not see anyone
Oh,
with their hands
stakeholders.
raised, any
Yes,
stakeholders that
thank
raise
you.
their hands. So
Thank
let
you,
me
thank
go
you.
ahead and share my screen.
And if we can have you blow it up a little bit, like zoom in some, that'd be very helpful. Thank you, Nanya. Okay. Any comments on the motion, committee? And thank you, Nanya. I see that you've already updated the list of medications with the new one that we reviewed today. So yeah, whenever the committee is ready, we'll proceed with the motion if there are no comments or questions.
This is Laura Bestie. I will make a motion that after considering the evidence of safety, efficacy in special populations, I move that emilsapride, aprepitant, phosphoripitant, delanzatron, doxylamine, pyridoxine, fosnatupitant, palenzatron, granisetron, nutapitant, palenzatron, ondansetron, palonzatron and rolapitant are efficacious for the FDA-approved indications. The preferred drug list must include at least one medication, includes alternate routes approved in both adults and children. The antiemetics can be subject to therapeutic interchange within their mechanism of action in the Washington preferred drug list. The preferred drug list must include a neurokinin 1 antagonist for patients receiving highly emetogenic chemotherapy and or radiation therapy.
This is Greg Hudson. I second.
All in favor, please say aye.
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 Any opposed or abstain? All right, with that, the motion carries. Thank you, committee. And so we will go back to Andrea and then to Ryan. First to Andrea for reviewing the asthma controllers, and then the asthma COPD agents with Ryan. So take it away, Andrea.
Great. Let me get organized. Swap out presentation here. Share it with you this time. Okay, we have it up.
That's great.
Great. Okay, thank you. So yes, Andrea Vintra here, research associate at the Center for Evidence-Based Policy. So this is the 5th out of 8 presentation reports for the 9 drug classes of interest today. This is our second presentation. So for those of you who were with me during my previous presentation just a few minutes ago, a reminder that I'll be repeating all the topics for this presentation and those in the upcoming ones because there may be some new audience members. So bear with me. Thank you. So this is the first of 2 drug classes that are included in this archiving project for the condition of asthma. So in this report, we're going to be focusing on the controller medications or long-acting medications for asthma. So the aim of the work is for the Drug Effectiveness Review Project, also known as DERP, to develop and present information to the Washington State Pharmacy and Therapeutics Committee on 9 drug classes that are candidates to be archived from active review by the committee. So you can see the list of the drug classes that are included in this project at the bottom of the slide. And of course, the topic for this presentation, asthma controllers, is highlighted in green. So for this presentation, we're going to review those topics in the darker green boxes on this slide for asthma controllers. So starting on the left, I'll first define the health condition of interest that this drug class intends to address, then summarize the general epidemiology and management, common management for the condition. Then I'll review the key points around in the most recent DERP reports for this drug class. So those the PICOs, the key questions. I'll provide a high-level summary of the key findings on that report, also general findings of any surveillance that was completed after that last systematic review. Then I'll move to new actions by the FDA for this drug class, since that last report, including any new approved drugs, new serious or boxed warnings, any new indications. And then I'll move on to report on any new pipeline drug findings in this class, and then also generic status of existing FDA-approved drugs. And lastly, I'll provide a high-level summary of recommendations in relevant clinical practice guidelines for the treatment of asthma, which include recommendations about how and where these agents are used along the treatment pathway, and then we'll have time for questions. So because of the larger number of agents in this drug class and the large volume of information or text in general in this presentation, we thought it would be best to abbreviate many of the terms in this PowerPoint presentation to improve readability. So these are the terms that are commonly abbreviated in the clinical literature, or they are the abbreviations that were used for the drugs included in the last DERP reports, with the intention of providing some continuity between the report and this presentation. So the slide is here for your reference as the key to those abbreviations. So asthma, the background, is a chronic lung disease characterized by inflammation of the lining of the airways in the lungs. This inflammation causes the airways to narrow and that lining to secrete, that lining tissue to secrete sort of extra mucus, resulting in a reversible airway obstruction. Asthma also increases airway responsiveness, which is often called hyperresponsiveness. This is a predisposition for those airways to narrow excessively in response to stimuli that would produce little or no effect in otherwise healthy individuals. These stimuli are often considered triggers for asthma attacks, and they could include things like tobacco smoke, pet dander, cold air, etc. So symptoms of asthma include wheezing, difficulty breathing, or shortness of breath, also coughing, particularly at night or in the early morning, and then also feelings of tightness in the chest. Asthma symptoms can also interfere with sleep or prevent individuals from exercising or participating in other activities that can affect overall health and increase risk for certain other health conditions. People can die from untreated asthma attacks, but it's very rare. There are long-term risks for people with more severe forms of asthma, and those include worsening lung function over time and side effects that come with those long-term use of certain medications like oral corticosteroids. For example, diabetes and osteoporosis are a couple of those serious side effects of those agents. According to recent CDC statistics, nearly 25 million people in the US are considered to have asthma. 3 to 13% of individuals have the severe form of the condition, and that comes with higher hospital utilization rates and higher medical costs than those with the non-severe form. Asthma is the leading chronic disease in children. Male children are more likely to be diagnosed with asthma compared with female children, but that's reversed in adults. So more female adults are likely to have asthma. There are also racial disparities in prevalence of asthma, with non-Hispanic Black children being twice as likely to have that condition compared to white children. And then exercise-induced asthma is where exercise can trigger symptoms in people with asthma. There are some reports that individuals without a clinical diagnosis of asthma can experience these symptoms, but it's supposedly rare. The exact cause of asthma is unknown. It's thought to be a combination of genes and environmental factors. Common risk factors are listed here in those in the green table at the bottom there, and they include family history of asthma, allergies, viral respiratory infections during childhood, occupational and environmental exposures, including certain dust, chemical fumes or vapors, moles, and air pollution or smog. And then obesity is also listed as a risk factor, but the causal mechanisms appear to be less clear. So for treatment of asthma, the primary goal is to optimize control of the symptoms, also reduce the risk of asthma exacerbations or attacks, and then reduce long-term complications such as loss of lung function and those negative side effects from those asthma medications. Clinically, asthma is typically classified into intermittent or persistent disease, where persistent asthma is when an individual has symptoms more than twice per week. And then with persistent asthma, it's further classified by disease severity. Treatment typically starts with non-pharmacologic interventions, including breathing exercises, more physical activity, and avoiding those environmental triggers like allergens or tobacco smoke. The more common medications used to treat asthma are categorized into two drug classes that we're presenting today. So the first two bullet points in that lower light green box on the right. So quick relief medications for acute symptoms, which are also known as bronchodilators, which all are short-acting beta-2 agonists. And then controller medications, of which is the drug class we're reporting on for this presentation. These are agents that help prevent symptoms and slow the progression of the disease. Those include inhaled corticosteroids and also sometimes oral systemic corticosteroids if treatment continues to be challenging, as well as long-acting beta agonists or LABAs and long-acting muscarinic antagonists or LAMAs. More recently, combination, quick relief, and controller medications have become available. And biologics, in that bottom bullet point there, are even newer, and those are typically indicated for individuals with the more severe forms of asthma. Those biologics are typically taken with other controller medications with the aim of trying to stop that underlying biological response that causes that inflammation of the lungs. So 4 reports prepared by DERP on this topic. So the last systematic review for controller agents for asthma was prepared in June of 2016. Sources for that report were searched through October of 2015, so that's over 8 years ago. There were 2 DERP surveillance reports since that last report, systematic review, with the search dates through May of 2018. The next 3 slides list the PICOs for the DERP products for this drug class and for this condition. So there were some criteria in that most recent DERP report that were not of interest for this archiving report. And those topics and criteria are in red on this and some upcoming slides. The populations of interest for today's archiving report are adults and pediatric patients with persistent or chronic asthma only. So the condition of COPD, which is in that last report, is not of interest for today's report. Comparators included another listed intervention, so any head-to-head trial, including the same drug utilizing 2 different delivery methods or formulations. Also listed were some comparisons that were explicitly excluded, and those are listed here. For study designs, they included randomized controlled trials that were at least 12 weeks in duration and with at least 100 participants. Comparative effectiveness systematic reviews were also eligible, as were observational studies for safety outcomes only. So this and the next 2 slides list the interventions included in the last report. And again, the drugs in red are not included or part of this archive presentation, again, primarily because they're indicated for COPD and not for asthma. So agents on this slide that are included in this report are 2 long-acting beta-2 agonists at the top there, including formoterol fumarate, that was first approved in 2001, and salmeterol zinofoate, which was approved in 1997. At the bottom there, we have the long-acting muscarinic antagonist, tiotropium bromide, and that was originally approved in 2004. For inhaled corticosteroids or ICS agents, we have 7 that are included today. Those are beclomethasone dipropionate, budesonide, cyclizanide, flunizolide, fluticasone furoate, fluticasone propionate, and mometasone furoate. And the included fixed combination agents of corticosteroids plus LABAs are at the bottom there. We have budesonide plus formoterol, mometasone furoate plus formoterol, fluticasone propionate plus salmeterol zinofoate, and at the bottom we have fluticasone furoate plus vilanterol. And the range of for FDA approval for these agents were between 2000 and 2013. So for this final intervention slide for asthma control is none of the fixed combination products of LABAs plus LAMAs nor the phosphodiesterase 4 inhibitor roflumilast were included in this archive report. So 3 leukotriene modifiers are included, and those are montelukast sodium, xoluton, and zarpirlukast. And for those agents, the FDA approval dates range from 1996 to 2007. So overall, there are a total of 17 drugs that are included in this drug archiving report. For outcomes, the last report included measures for asthma control, such as frequency of exacerbations or symptoms, also quality of life, levels of function, as in participation in work or school, also measures for healthcare utilization, mortality, and several measures for adverse events. So the 3 key questions in that most recent report for asthma controllers asked about the comparative efficacy and harms of those agents, and then key question 3 asked about any differences in those outcomes across various patient subgroups. So in the most recent report for these controller agents, there were 87 studies that were included for both asthma and COPD conditions. So 77 were randomized controlled trials, 5 were observational studies, and 5 were systematic reviews. Unfortunately, the number of studies included for asthma alone was very challenging to identify. So we're only able to provide that total number of studies that included that were for both asthma and COPD. But these key findings that I have listed here are only for the condition of asthma. It would likely, if you did a little bit of teasing out, it's possible with some time to sort of identify, but some studies included both of those conditions. So first are the findings for the intra-class comparisons. So comparisons between drugs with the same mechanism of action. So on this slide, we start with the different inhaled corticosteroids. So in adults, in general, there were no differences in effectiveness or harms outcomes between these agents. There's very little evidence for healthcare use and quality of life outcomes. There was some evidence for lower risk of oral candidiasis thrush with cyclizanide compared with fluticasone propionate. In children, results were relatively similar to those seen in adults, but there was less evidence overall. They also found some evidence for better growth velocity with fluticasone propionate compared with beclomethasone dipropionate and with budesonide. And then, of course, poor growth would be considered an adverse event. For the intra-class comparisons of combined fixed products of inhaled corticosteroids plus long-acting beta-2 agonists or LABAs, they found no differences in efficacy or harms between these agents here. So we have budesonide plus formoterol and fluticasone propionate plus salmeterol. And then also between fluticasone propionate and plus salmeterol and mometasone furoate plus formoterol. And there were no differences in quality of life or harms between fluticasone propionate plus salmeterol and the combination agent of fluticasone furoate plus vilanterol. So findings for inter-class comparisons are on this and the next slide. So these are comparisons of agents with different mechanisms. So we begin with inhaled corticosteroids compared with leukotriene modifiers. So the inhaled corticosteroids demonstrated greater effectiveness and quality of life in these studies compared with leukotriene modifiers in adults and children. In children, there were fewer visits to the emergency department, but there were no differences in withdrawals due to adverse events. Then for inhaled corticosteroids compared with phosphodiesterase 4 inhibitors, individuals who received roflumilast were more likely to experience asthma attacks and to withdraw because of an adverse event compared with inhaled corticosteroids. And yes, understanding that just a note that the phosphodiesterase 4 inhibitors or roflumilast is not currently approved for asthma, but the study included that, and that was for the condition of asthma. For the fixed combination product of inhaled corticosteroids plus LABA, compared with different inhaled corticosteroids, they found no differences in effectiveness, quality of life, or harms between fluticasone furoate plus vilanterol, as well as, and So that's one agent, and compared with fluticasone propionate. But there were more asthma exacerbations and more adverse events, and also greater quality of life scores with cyclizanide compared with fluticasone propionate plus salmeterol. Okay, continuing with the findings for interclass comparisons. And I do want to point out that some of these drug combinations are not fixed dose products, but rather add-on therapies to another agent. But this is all for the condition of asthma in this report. So all comparisons on this slide include the fixed dose products of inhaled corticosteroids plus a long-acting beta-2 agonist. So compared with leukotriene modifiers, the corticosteroid plus LABA combination was more effective in adults and children, but there were no differences in withdrawals due to adverse events. Compared with leukotriene modifiers as an add-on therapy to inhaled corticosteroids, the fixed dose products of corticosteroids plus LABAs were more effective, but also were with higher rates of serious adverse events, and there were no differences in quality of life between those groups. So lastly, compared with leukotriene modifiers as an add-on therapy to LABAs, the inhaled corticosteroids plus LABA fixed dose products demonstrated longer time to treatment failure in both adolescents and adults. So in other words, ICS LABA products controlled symptoms for a longer period of time. So this last slide for key findings for the most recent report for controller agents, here they addressed key question 3 regarding differences between population subgroups for these outcomes. So in general, asthma patients who were younger experienced more exacerbations and serious adverse events with the leukotriene modifiers, with the leukotriene modifier montelukast sodium compared with the inhaled steroid of budesonide. In a stratified analysis, African American patients experienced more withdrawals due to adverse events and serious adverse events with a formoterol tartrate compared with formoterol fumarate, while there was no difference in Caucasian patients. And another note here, these two drugs are not indicated for asthma at this time, although this study was done in patients with asthma. That last bullet point here shows that there were no differences in linear growth velocity between genders in children comparing the 3 drugs of montelukast sodium, budesonide, and fluticasone propionate, and this was in one observational study. Okay, for the findings now in surveillance reports for controllers. So this was since the systematic review through May of 2018. So there were no new indications and no new novel drugs in this drug class, but there were 2 new fixed dose combination products that were listed under new formulations in that last surveillance. So although I recognize new formulations are not necessarily of interest, I included the list here for completeness since it was reported in surveillance. That first and last bullet point are for products only indicated for COPD, so likely not of interest. So the other 3 agents that are not in bold there are new formulations of existing agents. However, the drug in bold there is a new fixed dose combination product indicated for asthma and approved in 2017. This is a triple therapy that includes fluticasone fumarate, clidinum bromide, and vilanterol trifenetate. And it's with the brand name Trelegy Ellipta. So while the individual agents of Trelegy Ellipta have not been newly approved, this is the first triple therapy combination agent that's indicated for asthma. Also with surveillance, there were no new boxed warnings. However, one warning was removed from the fixed combination dose products of inhaled corticosteroids plus LABAs, and that was in December of 2017. And that warning that was removed was for an increased risk for asthma-related hospitalizations, intubation, and deaths compared with the steroid alone. They also identified 25 new eligible studies in the surveillance, of which 13 were for asthma. So one of these 13 was a systematic review, and 12 were head-to-head randomized controlled trials. But noting that 4 of those trials were comparisons of the same drug with different formulations or delivery methods. Since the last DRIP report, so this includes, of course, the findings from the surveillance and from the new searches for this archiving report. Other than the new fixed combination triple therapy, Trelegy Ellipta, there were no new asthma controller agents identified, but we did find 7 new indications for these agents, all of which were new since the last surveillance report in 2018. So the first 3 on this are on this slide. So in February 2017, the indication for tiotropium bromide was expanded to include the treatment of asthma in patients 6 and older. Before 2017, it was only indicated for COPD. And as a reminder, that Spiriva inhaler powder for this drug is not indicated for asthma, just this Respimat product, which is this soft mist formulation. Also, a new formulation of the inhaled corticosteroid beclomethasone was developed and came to market in 2017, and it came with an expanded indication to include patients 4 years older, where before it was only for ages 5 and up. In 2018, the FDA also expanded the indication for fluticasone furoate, and that's an inhaled corticosteroid to include children as young as 5 years. So continuing on with new indications, at the top there we see inhaled mometasone furoate with brand name and formulation as Manax HFA that was expanded to include children as young as 5 years. And the next 3 agents listed are fixed dose combination products of inhaled corticosteroids plus LABAs. So we have budesonide plus formoterol and mometasone plus formoterol, both expanded for use in younger patients for asthma in 2018 and 2019, respectively. And then at the bottom, we see fluticasone furoate plus lanterol that was expanded for the maintenance treatment of asthma in patients ages 5 and older. And this agent, this combination drug, was not indicated for asthma prior to 2023. Okay, so this and the next 2 slides list the FDA-approved indications for the 18 controller agents, of which one of those is the new agent identified during surveillance. So for the long-acting beta-2 agonists or LABAs, formoterol, fumarate, and salmeterol are both approved for the treatment of asthma as an add-on to a long-term asthma control agent, and for the prevention of exercise-induced bronchospasm in children and adults. While only formoterol fumarate is also approved for the maintenance treatment of COPD. For LAMAs, we have tiotropium bromide. This is approved for the overall treatment and prevention of asthma. And then in the bottom row, the fixed triple combination product of Trelegy Ellipta is approved for the overall treatment and prevention of asthma, as well as the prevention of exercise-induced bronchospasm. So on this slide, we see we have all of the inhaled corticosteroids, and they are all approved only for the treatment and prevention of asthma. For inhaled corticosteroids plus LABAs at the top here, all 4 agents are approved for the treatment and prevention of asthma, while only 3 of those 4 agents are approved for the maintenance treatment of COPD. Only mometasone furoate plus formoterol is not indicated for COPD. At the bottom here, we see all 3 leukotriene modifiers are approved for the treatment of and prevention of asthma, and only montelukast sodium or Singulair is also approved for the prevention of exercise-induced asthma. For boxed or serious warning, so there was 1 new boxed warning for montelukast sodium, and again, this is a leukotriene modifier. This warning was added to the label in 2020. It's for serious psychiatric events which were reported in patients taking Singulair. And then there were 2 removals of box warnings since that last report. So the first listed here is the removal of the warning that I mentioned earlier for all ICS LABA products, which warned of increased risk for asthma-related hospitalizations, intubations, and deaths compared with using the steroid alone. And then in 2018 and 2019, the box warning for risk of asthma related to asthma-related deaths was demoted for all monotherapy LABAs, and it's now listed as a more general warning and not a box or serious warning when used as monotherapy. We found 4 pipeline therapies for controlling asthma medications. 3 of these, the 4 pipeline therapies are fixed combination products, and all are inhaled products currently in phase 3 trials. So Beztree, Aerosphere, HFA is the triple inhaler therapy of budesonide plus formoterol fumarate plus glycopyrrolate, which is a long-acting muscarinic antagonist, or LAMA. Next, we have Fostair, which is a dual therapy of beclomethasone plus formoterol fumarate. And then we have PT001, which is glycopyrrolate, and this is a long-acting muscarinic antagonist, or LAMA. And then we have QMF149. It's also a fixed combination dual therapy of mometasone fumarate plus indacaterol acetate. So this is an inhaled corticosteroid plus a LABA. So for generic status, this first of 3 slides shows the status of the inhaled corticosteroids. So only budesonide and fluticasone propionate are available as generic agents, and they became newly available since the last report. Next are, at the top here, we have the long-acting beta-2 agonists. So formoterol fumarate became newly available as a generic since the last report. And there appears to be also applications pending for the generic manufacturing of salmeterol zinofoate, but those have not yet been approved. Next, we have tiotropium bromide and the fixed dose triple therapy at the bottom there. And those have exclusivity rights until 2025 and 2030, respectively. So 3 of the 4 fixed combination products of corticosteroids plus LABAs are now available as generics. Those include budesonide plus formoterol, fluticasone propionate plus salmeterol, and fluticasone fumarate plus vilanterol. For mometasone fumarate plus formoterol, which is Dulera, there was some conflicting information between IPD Analytics and the FDA websites. We do know that the estimated generic launch date was in 2023, and there may be litigation holding things up, but it wasn't clear if that was available yet. And then at the bottom, we see that all 3 leukotriene modifiers are available as generic agents, and they were likely available since with the last report in 2016. So on the next 5 slides, we're providing a very, that general summary of clinical practice guideline recommendations for asthma in the populations of interest, including, how and when the drug class of interest is used along the treatment pathway. And please note that the agents in blue there are controller agents, which is the topic for this report. So we can differentiate from the quick relief agents that we'll be presenting in the next report. So in general, the recommendations mention that all patients should receive patient education and an individualized treatment action plan when diagnosed with asthma. Education should be around self-monitoring, how to use all of these prescribed medications, and how to avoid environmental triggers. And then pharmacotherapy was typically described in the recommendations as the cornerstone of asthma treatment. First, here it was recommended that all patients have access to an inhaled bronchodilator, which is that quick relief agent for those asthma symptoms. And then in patients with moderate or severe asthma, or in those who have severe asthma attacks, low-dose corticosteroids were also a recommended option, either as a concomitant agent with the quick-acting agents or via a fixed combination formulation. Regarding all pharmacotherapy, the initial maintenance therapy is based on asthma severity, and then adjustment of therapy is based on asthma control. So regarding maintenance therapy with controller agents, the stepwise approach to asthma treatment appears to be that core foundation in the asthma guidelines, which is basically where medications are escalated until good asthma control is achieved. This approach is based on the levels of severity and persistence of asthma, as I mentioned in the background section earlier. So step 1 is for asthma that is assessed as intermittent and mild. And then step 4 or higher is for asthma considered severe and persistent. So in adults and adolescents, maintenance therapy begins with step 1, which is basically treatment as needed. If pharmacotherapy is indicated, so the National Asthma Education and Prevention Program guidelines recommend only a quick relief bronchodilator. So controller agents are not recommended by that organization, while the Global Initiative for Asthma, or GINA, guidelines recommend combination therapy. So either as 2 agents used together or fixed dose combination products. So corticosteroids plus a short-acting beta agonist, or the newer fixed dose combination product of corticosteroids plus formoterol, which is the LABA, such as Symbicort or Dulera. Step 2 is also treatment as needed, where the National Asthma Education Prevention Program guidelines recommend low-dose inhaled corticosteroids as monotherapy or in combination with short-acting beta-2 agonists, while those GINA guidelines recommend the fixed-dose products of low-dose ICS plus formoterol agents. Leukotriene modifiers are recommended as alternatives when avoidance of inhaled corticosteroids is necessary, because it has a little bit lower efficiency or efficacy. For step 3, maintenance therapy, the guidelines recommend specifically the combination agents of corticosteroids and formoterol as preferred agents, and that they also mentioned that tiotropium is appropriate for any patient intolerant to any LABA, such as formoterol. Step 4 or higher is for patients with severe and persistent asthma. This level of the condition is also called treatment-resistant asthma. Higher doses of inhaled corticosteroids plus formoterol or other LABAs are generally recommended, and they also recommend to consider adding on an additional agent of leukotriene modifiers or utilize that new triple therapy product. It's also mentioned that systemic or oral glucocorticoids may be indicated in rare situations, but that the newer biologic agents may be better alternative for severe asthma. For children, the overarching goals for those diagnosed with asthma are to maintain control of asthma symptoms and reduce exacerbations with the least amount of medication and side effects. In general, the guidelines recommend more intensive management for acute exacerbations in children, which can include oral glucocorticoids in children 2 to 3 years of age if they experience these attacks more than 2 days per week, and in children between 4 and 12 years if they experience those attacks throughout the day. This in quotes. The step care approach for pharmacotherapy is also used in this younger population for maintenance treatment, which is similar to adults. However, the corticosteroid formoterol product is not recommended in the guidelines until step 3. And then step 3 is also where leukotriene modifiers may be added as needed, where they were an option with step 2 in adults. And also I want to mention that the step care approach may include options to step down in addition to stepping up, of course, and the guidelines recommend stepping down a level. It can occur if asthma control has been achieved for at least 3 months. So on this last slide for guidelines here, we have the recommendations for exercise-induced bronchoconstriction. In general, they report that regular exercise actually, improves cardiovascular fitness, which can actually reduce the risk for bronchoconstriction. So in the up-to-date guidelines, these recommendations are from the perspective that exercise-induced asthma is when exercise is a trigger for bronchoconstriction in patients with underlying asthma, and it's not just an independent risk factor. So in patients with well-controlled asthma, the guidelines recommend individuals avoid triggers such as cold air or dry air during exercise. And then if pharmacotherapy is indicated, a quick relief agent like albuterol is recommended, or a combination of inhaled glucocorticoid and formoterol is recommended. And that should be taken about 5 to 20 minutes before exercise. For patients who require daily therapy for exercise-induced asthma with prolonged or recurrent exercise, they suggest regular use of a combined short or quick-acting agent plus a long-acting product rather than a short-acting agent alone. And then they recommend if these pretreatments don't work and symptoms persist, it's likely that the underlying asthma is poorly controlled. So they refer to step-up therapy to be considered. So this is our final content slide for this report for controller agents for asthma. Here we list the relevant clinical practice guidelines for the treatment of asthma that were also referenced in the section for the guidelines in this report. They're also, so they're listed in alphabetical order by author or professional association, and the date of publications or guideline updates for these documents range from 2019 to 2023. So thank you for your attention.
Thank you, Andrea. That was great. Kavita here. Nanya, any stakeholders for this section? I guess while we're waiting for that, sorry. Committee, any questions for Andrea?
This is Peter Barquette. I have a question. Thank you for the presentation, very complete. I wanted to go back to the intra-class comparison of combination ICS-LABA products. And I think what you had presented was that there was no difference between the different ICS-LABA products. But I thought that there was a difference with the formoterol-based products, and that was the basis for smart therapy recommendations. Is that coming up in the rescue inhalers section, or am I mistaken in the evidence?
This is, these were the sort of summary of findings from the last DERP report. So exactly how that was translated, that would, I could go back and look into that, but this was basically sort of extracted from the summary. If you could say that one more time for the intra-class.
Yeah, so basically it's my understanding that between 2016 and 2017, or whenever the last DERP report came out, and now, the big change in asthma therapy is smart therapy, and the basis of that was the quick and long-acting effects of formoterol, and so which is why the formoterol-based ICS-LABAs get preferred treatment in most of the guidelines, and so I didn't hear mention of that in recent evidence, and so I'm wondering if that evidence has been, maybe I'm mistaken and it's kind of overstated, or and the reason I'm bringing this up is because I'm thinking that probably we want to include or require in our motion when we get to it that a formoterol-based ICS-LABA must be on the PDL because of smart therapy. And so I was wondering kind of where that was in the evidence for this report.
It's possible that the newer evidence was not, that there was newer evidence since that has not been included in that last report. I don't know, Ryan, if you have anything else to add.
Hi, good morning. This is Ryan Pistoresi. Yes, I am familiar with the new smart therapy guidelines. I don't recall exactly where those recommendations were published and how that might have been within the scope of this presentation. As you know, this was a long overdue update in this class spanning from 2018, to recently. And yeah, I can just do a little bit of digging and see, kind of where that smart therapy comes in versus what the guidelines were as part of the scope of this presentation.
Kavita here. Thank you, Andrea and Ryan, and thank you, Peter, for asking that question, because I think you are spot on about that. I did just post the last study that I'm aware of as of last year, which compared salmeterol-based combo therapy versus formoterol. And I think you are spot on, Peter, that I too, whenever we review the motion, I too would like to ensure that we have a formoterol-based combo therapy that is listed as a preferred drug on the PDL. Great question. Other questions from the committee? And any stakeholders, Nanya?
No, not that I noticed. I don't see
Lee,
any raised hands.
this is Ryan. So before we would do the stakeholders, I do have the COPD portion to
I
present,
see.
and then yeah, because this is together, the asthma archive and the COPD are kind of one joined report. So let me go ahead and share my screen.
I guess from the documents that we received in preparation for the meeting, I see that there are 3 different motions. There's one for control meds for asthma, there's one for quick relief, and then there's one for COPD. So are we treating them as different motions, but we'll just do them all together after you're done, Ryan? Is that what you'd recommend?
Right. So
Okay.
this is Ryan. So for the Washington PDL, the asthma controllers and COPD controllers have always been treated as one evidence review. And as you saw in the report, all of these COPD drugs were listed in red as being out of scope for the archive report. So in order for us to archive the asthma and COPDs together as one class, we are providing some updated or the most recent evidence that we have on the COPD indications, which happens to be that last scan that we had from 2018. So as you saw from the recent presentation, that was all of the information updated on asthma since this scan. Because we didn't have COPD as part of that, we are including the COPD drugs as part of this. And then that way, when we get to the motion, we can have all of those drugs together, and then we can do the archive together at the end of the P&T today.
Great. Thank you for that, Ryan. All right, take it away.
Okay, so as I mentioned, this is the last scan that we had received for the asthma COPD controllers. This was from 2018. And as you had seen with the previous presentation, that the COPD drugs were excluded. So I'm just going to highlight really the most recent evidence that we've seen for the COPD medications. So the last time that we had a full update for the asthma COPD controllers as a class was in 2016. We had a previous scan in 2017 and a current scan from March of 2017 that looked through studies that were published through May of 2018. For those of you who are wondering about a scan versus a scan was a previous type of report that we received from DERP that looked at what type of evidence was being published to help states understand when to commission a new report. Surveillance documents are very similar, although they do have a bit more in-depth looking at some of those studies that are being published. So if you are curious about the difference between a scan and a surveillance document, just know that these types of scan documents have since evolved into the current surveillance documents that we've been presenting over the last few years at our P&T meetings. The key questions for this scan, we're looking at the comparative efficacy and effectiveness within classes and across classes of the long-acting inhaled and long-acting oral medications used for asthma and COPD. The second key question was around safety. So this was looking at within class and across class tolerability and frequency of adverse events of the long-acting inhaled and long-acting oral medications for asthma and COPD. And the third key question for this scan was around subpopulation. So looking at whether there were groups or subgroups of patients for which asthma or COPD controller medications differed in terms of their efficacy or safety. The populations that were included in the scan were for adults and pediatrics, so greater than or equal to 12 months for patients with persistent or chronic asthma. And for COPD, they had to be 18 years of age or older. The included interventions are listed here on this slide. They were all previously mentioned in the asthma controllers. Just note that since this is from 2018, that the two underlined drugs are new to this scan, but were previously mentioned in the asthma COPD one. So that triple therapy that was bolded on that one slide with the new drugs, that is this one there. That's the Trelegy. And then the formoterol glycopyrrolate, that is a COPD only indication. So that one is new for this scan. Since our last report in 2016, as of 2018, these were the new formulations and indications. So this just highlights what happened mainly between 2016 and 2017. Regarding the regarding the harms reported since the last report, there was a removal of a black box warning for the ICS LABAs around increased asthma-related hospitalizations and deaths. So in light of what Dr. Barquette mentioned around the formoterol being used in SMART therapy, there was that previous black box warning, and just highlighting that that was removed in December of 2017. There was one comparative effectiveness review published by ARC that is part of the scope, but that was done in 2018. And I believe that that has then been evolved into those guideline updates that you had seen in the last presentation. So between the 2016 report and the May 18 timeframe of when this scan was conducted, we had identified 11 trials comparing the same drugs in different delivery devices. And so as we know, during this time, they were changing a lot of the devices and formulations for these medications. In terms of the head-to-head studies that we are most interested in, there were 13, and 10 of them were identified in the period of the scan from 2017 through 2018. And then there were 18 secondary publications of previously included trials, and 16 were new in the scan. So on this slide, as you can see, we have some grayed out ones. The gray ones are new with this scan. So just highlighting that these are the new therapies that were published for asthma and COPD that were later incorporated into the guideline recommendations that you had seen. But just highlighting that for the ones with COPD, that I'll highlight here, the Feldman from 2016, the Ferguson from 2017, the Kalberg from 2016, the Kerwin from 2017 are COPD specific trials. And on this slide, the Lipson from 2017, the Pappy from 2018, the Vespo from 2016, and the Wedviska from 2016 are also COPD specific. And so you did not get those with the Asthma Controller Archive report previously. So the summary since the 2016 report is that there were 6 new formulations. For the existing drugs, 3 were identified in the scan. 1 black box warning was removed for the ICS LABAs in asthma. There was 1 new comparative effectiveness review. That was the ARC review that was completed in 2018. And in terms of new studies that were being published, there were 13 head-to-head trials that were identified. The 10 ones that were shaded were new from this scan, and that there are 11 trials comparing different device types, so the different ways in which the drugs are delivered to the patient, and the 18 secondary publications with 16 that were new in this trial. So any questions on this scan highlighting what we had in terms of evidence around COPD? I'm going to stop sharing because it's a little bit easier for me to see what's going on without the screen share.
Thank you for that, Ryan. Questions from the committee?
Okay, if there are no questions, then I think the next thing is the stakeholders. So thank you for your attention this morning.
Thank you, Ryan. Nanya, any stakeholders for either of these sections?
No, I don't see any stakeholders. No hands raised and no questions.
Okay, thank you.
So I'm going to go ahead and share my screen, and we're going to be going over the motions for both the COPD and the asthma controllers. So let me share my screen. There we go.
Thank you.
Mhm.
Can I have you magnify it a little bit?
Yes, sorry.
Thank you.
There we go.
I guess I'm curious what that last statement means. All delivery systems and indications will be included for all drugs. Is that
So
to say that all delivery systems will be available on the PDO?
And so this is Ryan. So no, this was to say that all the delivery systems for the drugs indicated on the column on the left are included within the purview of this study. So for
Oh,
example,
okay.
as I'd mentioned, we changed from, the CFCs to the HFAs, and now we have things like the, Respiclick or the soft mist or the, dry powder inhalers. So instead of trying to
Sure.
have these new delivery devices be considered new drugs and unstudied, we realize that the ingredient is the same between these different drugs, and that because the ingredient had been studied and reviewed as part of our P&T, that we didn't need to break out all of the different device types in the future. So this is more of a consideration that was made at the last meeting in 2018. As you saw from that scan, we had some emphasis on the different device types. That is just copied forward from the previous motion about that. So that's just saying that we don't need to study all of the different types of devices head to head between each other.
Great. Thank you, Brian. Questions from the committee or comments about the motion? I guess the only thing I would wonder about is, do we need to say for treatment of asthma slash COPD in the motion, or do we have a separate motion where we'll call out COPD?
So this is Ryan, and there's actually going to be 7 of these motions for each
Oh,
of the
okay.
different drug classes.
Okay.
The way that we had designed this is that because there is overlap between the asthma and COPD indications, that we put that block A or that block C next to the drugs to indicate whether they are approved for asthma or COPD. So for the inhaled corticosteroids, these are all asthma only indications.
Right, committee questions or comments?
This is John McKay. I would move that the inhaled corticosteroids, after considering the evidence of safety, efficacy in special populations for the treatment of asthma, I move that beclomethasone, budesonide, cyclosinide, flunisolide, fluticasone furoate, fluticasone propionate, mometasone MDI aerosol, mometasone DPI powder are safe and efficacious for the treatment of their approved indications. Inhaled corticosteroids can be subject to therapeutic interchange in Washington's preferred drug list. All delivery systems and indications will be included for all drugs.
Peter Barquette, I'll second the motion.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Thank you. With that, the motion carries.
Sorry for the scrolling. Next one.
Great, thank you. So this one is for the LABAs. And yes, thank you for the background. The C and A now make sense.
I think this is John McKay. I would kind of second Dr. Barquette's concern that we add call out formoterol in terms of requiring that.
This is Ryan again, and I'm trying to do some research about your question, Dr. Barquette. So looking at the GINA guidelines that were included as slide 2 of 5 on the controllers, it looks like the recommendations are for the ICS SABA, so the short-acting beta agonist, or low-dose ICS formoterol. So it doesn't say ICS LABAs, it looks like that recommendation is for ICS formoterol. So I think that is what you were talking about as it relates to the study that Kavita mentioned. So I think that is included within the context of the report. It's just that it was on the clinical practice guidelines page.
Okay. Yeah, I think the concern would be, well, the theory on smart therapy is that if you give somebody a rescue inhaler and a separate maintenance inhaler, they may not have perfect compliance with one or both, and they're more likely to be more compliant if you give them a single inhaler for both. So somebody with moderate persistent asthma, the evidence suggests that they do better on something like budesonide formoterol as opposed to like a salmeterol fluticasone product. And so the ICS LABA combination products is my my area of concern. And I assume we'll have a separate
Yeah.
motion for the combination products.
That's right. I see that page 7 is where we're going to be addressing the ICS LABA. And I think that's where we can make sure to bring up this concern and word it such that we incorporate the formoterol-based combo inhalers. So I think this one is, so I think we're doing just ICS, we're doing just LABA, we're doing just LAMA, and then we're at the LKA, and then we'll get to the combo.
Yes.
Okay, then I'm comfortable with this motion as is.
Okay, so if no questions, if anybody would like to propose a motion.
This is Kevin Flynn. After considering the evidence of safety, efficacy, and special populations for the treatment of asthma and COPD, I move that a formoterol nebulizer formoterol powder, indracaterol, olodaterol, salmeterol are safe and efficacious for the treatment of COPD when used in combination with inhaled corticosteroids for the treatment of asthma. Long-acting beta agonists can be subject to therapeutic interchange in Washington preferred drug list. The preferred drug is approved for the condition being treated.
This is John McKay, second.
All in favor, please say aye.
Aye. Aye.
Any opposed? Or abstain? Okay, with that, the motion carries. I suppose, committee, the only question I have is, the statement that we had at the very beginning, all delivery systems and indications will be included for all drugs. Do we need that in every motion just to call it out? And maybe Ryan, it's a question for Ryan.
Yeah, so this is Ryan, and for some of these other classes, we are seeing different movement within the devices. So it could be prudent for us to include that statement going forward. I think for this class, we are okay not having that. I can just double check the Washington PDL and see for the individual.
Yeah, also because we are considering archiving these after. And so for future protection, if we, who knows what formulations are going to come out, if we need to include that statement for all of these classes.
Right. So it looks like for this one, there hasn't been any new formulations that have been approved. It looks like most of these are actually nebulizers, like the Brovana, Perfamist.
There's dry powder inhalers with several of these.
Yes, I do see that with the Ceravent Discus and the Striverdi Respimat.
Yeah, like Oladarol has a Respimat. To the point to future proof it because especially for generics, sometimes the device is different. Perhaps we should add that statement just to give the maximum freedom.
I'm seeing head nodding, so does the rest of the committee agree with that?
I agree.
I agree.
Yeah, I agree.
I just add that to my motion.
Yes. Any opposed to that? Kind of reiterating the motion. Sorry, I should have spoken up early on. Okay, cool. Thank you. Okay, great. We can go on to the next class, Nania. Thank you so much. And we'll keep adding it, I think, to each of the motions. That's one statement. Although this one, I don't think it matters. Is Zileuton still a thing on the market?
This is Ryan, and they may not be on the market, but they were included as within the scope of the study. So I think for this one, we'll include it as a drug that is reviewed. But if you want to have it be in the motion that it's not, I'm just looking. It looks like they are all included on the market, but they may just not be, widely used.
Okay, thank you. Okay, comments from the committee members?
I think in the past with drugs like Xyluton, we've in the left-hand column we've sort of indicated that they're not preferred. Does that need to happen on this?
Yes, and this is Ryan. So kind of in the middle of that, it says Xyluton shall not be a preferred drug on the Washington preferred drug list. So that was how we had always, treated it as never being preferred, but to the point that it's still available. It looks like it still is technically available as an extended release form.
Great. Any other comments? And if not, whenever we're ready for the motion.
This is Peter Barquette. I can make the motion. After considering the evidence of safety, efficacy in special populations for the treatment of asthma, I move that montelukast, saferlukast, and Xyluton are efficacious. Montelukast and saferlukast may be associated with a lower incidence of hepatic toxicity than Xyluton. Xyluton shall not be a preferred drug on the Washington preferred drug list. Leukotriene modifiers can be subject to therapeutic interchange on the Washington preferred drug list for the indication of asthma.
Christy Weiler.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Okay, with that the motion carries. And I think the next one is the combo. That's the one we wanted to work on. So should we propose somewhere in there, so after it says safe and efficacious for their approved indication, should we say at least one formulation of ICS/formoterol will be preferred on the PDL?
Yeah, I think that sounds good. Yeah, at least one combination of ICS plus formoterol must be included on the Washington preferred drug list. And then maybe a reference to that in the therapeutic interchange statement. Yeah.
Okay.
So this is Ryan. Is that true for both asthma and COPD?
No, it's just asthma.
Okay, so then I think we would want to include that, just given that we do have COPD
Great
for
point.
one of the Yeah, the budesonide formoterol at the very top is a COPD indication as well.
Okay, great. Yeah, so we can say at least one formulation of ICS slash formoterol, FORMOTEROL, will be included as a preferred drug for asthma on the PDL. It's my first run at it. Committee, go. Is that fair?
I think the only suggestion I would have, Nonya, is to add Washington before PDL.
Oh, yes, thank you. And then I think, Peter, you were starting to say for the therapeutic interchange part, did you want to modify that somehow to protect
Yeah, I
the
think so. So, I mean, if we want to include at least one formoterol product on the preferred drug list, then the formoterol can't be interchanged. So what
Okay.
if we, I don't know if we exempted formoterol from therapeutic interchange, or if we clarified that the interchange was applicable to
Another formidable
non-formoterol
base.
product. Yeah.
Well, you could technically interchange between the two, the mometasone and the budesonide one.
Mm-hmm. Yeah.
Yeah, like
So maybe the additional sentence can be formoterol slash ICS can only be interchanged with another of
sure.
its
Yeah,
kind.
Symbicort or Dulera doesn't matter. They should
Yeah.
be equally efficacious. It's just I wouldn't want to interchange like a Sermeterol product with a formoterol product.
To make
So
it,
for, I guess we would have to say for asthma. Sorry, Laura, go ahead.
oh, I was gonna say to make it less wordy, could you just say
Yes.
formoterol ICS for asthma may not be interchanged?
How's that work, Ryan? What do you think?
Yeah,
And
so
then
this
all
is
other long-acting beta agonists can be.
Yeah.
Yeah, so this is Ryan. So that would be saying that if someone were to be prescribed a non-preferred ICS LABA, that we would have to go to the other preferred. So that would be the fluticasone salmeterol products. So if someone were to be getting the fluticasone vilanterol, we would be switching to the salmeterol because we're excluding it from interchange. So if we are requiring that at least one formulation of an ICS formoterol is preferred for asthma, that means any of the non-preferred drugs could be switched into the ICS formoterol. So I think my recommendation would be to remove that most recent line that says that it may not be interchanged, because if it is preferred, it's not going to be interchanged.
Mm-hmm.
Okay,
Interchange really applies to a non-preferred drug.
what if we change it to a formoterol slash ICS product may only be interchanged with another formoterol slash ICS product. So let's say like Symbicort is on the preferred drug list, but Dulera is not. If someone gets prescribed Dulera, for smart therapy, I wouldn't want that to get swapped to a non-formoterol preferred product, like say Advair. If it were being, does that make sense? Like, could we do like a positive inclusion where we say formoterol slash ICS products may only be interchanged with other formoterol slash ICS products?
Yes, I think that's how you should phrase that, because to your
Okay.
point, Dulera and Symbicort are right now non-preferred. Our preferreds are the fluticasone, salmeterol, and the generic Symbicort. So a potential interchange as of today could be to either of those. If you change it to have that statement, then the Dulera or the Symbicort would be interchanged into the generic Symbicort.
Right. That's helpful. Okay, so Nanya, so where you're at, I think formoterol ICS for asthma may only be interchanged with another formoterol ICS product. How's that look, committee? Fair? Okay. Okay. Other comments? And if not, we'll proceed with the motion.
This is Kevin Flynn. After considering the evidence of safety, efficacy, and special populations for the treatment of asthma and COPD, I move that fluticasone propionate, salmeterol, DPI, and MDI, budesonide, formoterol, fluticasone furoate, elantrol, and mometasone furoate and formoterol are safe and efficacious for the treatment of their approved indications. At least one formulation of ICS formoterol will be included as a preferred drug for asthma on the Washington PDL. Formoterol ICS for asthma may only be interchanged with another formoterol ICS product. Long-acting beta agonist combinations with ICS products can be subject to therapeutic interchange in the Washington preferred drug list if the preferred drug is approved for the condition being treated. All delivery systems and indications will be included for all drugs.
This is Greg Hudson, I second.
Great, thank you. All in favor, please say aye.
Aye.
Hi.
Any opposed or abstain? Great, and with that, the motion carries. Thank you, committee. All right, now for the LABA-LAMA combinations.
Can we add our statement about the
Yes.
formulations?
Yes, please.
Thank you.
Thank you for the reminder, Kevin.
So Ryan, just down below, you'll see that gray means that those were newer drugs that aren't included in that review. So if you remember from the scan that I presented, that formoterol glycopyrrolate was a newly identified one in the scan, meaning that it wasn't in the last report, meaning that we didn't present evidence on it. And that new formoterol aclidinin is also new and has not been reviewed by the committee. So both of those are in gray, and they cannot be included in the motion or be preferred on the PDL without being reviewed.
This is Greg Hudson. Ryan, is there any difference between the bolded and not bolded?
Yes. So the bold means that it was new in this update. So because the formoterol glycopyrrolate was reviewed in the scan in 2018, it would have been bolded back then. And since it's being carried forward in this motion, it's not a newly identified drug. It's just a drug that hasn't been reviewed yet. So that's the difference between the bold and non-bold.
Gotcha.
And just for clarity, if a provider wanted to prescribe those medications, they could still get them. They would just have to use two preferred agents before.
So this is Ryan. It doesn't require two for the Washington preferred drug list. That's for the Apple Health preferred drug list. So when we get to the DUR portion, it's typically two for that. So for the Washington PDL, I believe we only have one preferred drug in this class. So they would have to try that one first, and then any of the non-preferred could be used thereafter.
Okay. This is Laura Bestie. I will make a motion as long as no one else has any comments. No. For llama lava combinations, after considering the evidence of safety, efficacy, and special populations for the treatment of asthma and COPD, I move that indaclorol glycopyrrolate, olodaterol tiotropium, and umeclidinium bilanterol are safe and efficacious for the treatment of approved indications. Long-acting beta agonist combination with LAMA products can be subject to therapeutic interchange in the Washington preferred drug list if the preferred drug is approved for the condition being treated. All delivery systems and indications will be included for all drugs.
Peter Barkat, I second the motion.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Thank you. With that, the motion carries. And with the PDE inhibitors,
Do you need to include the subject to therapeutic interchange when there is no other medications in the class besides meflumalast?
This is Ryan, and technically, no, you don't. I think when they were making the motions in the past for the asthma COPD, they continued to just have that in case that there were other ones. As you know, this drug has been in a class of itself for many, many years. So I don't think having that makes any difference to how we would review and manage this class.
is roflumilast only approved for COPD, or is it also approved for pulmonary hypertension? And does it matter? Like, do we need to include all the FDA approved conditions in the motion, or doesn't matter?
So this is Ryan. So since this class is specific to asthma and COPD indications, we only are reviewing it for asthma COPD.
Okay.
Like I mentioned with the metoclopramide prior, if it does have
Mhm.
other indications, and can be included in managing a patient with that disease state, it doesn't necessarily mean that it's being affected. It's just saying that as part of this motion for this class, we're only focusing on COPD and not some of the other indications that a drug may be used for.
Okay, thank you. Okay, other questions from the committee or comments?
And this is Greg Hudson. I'll motion that after considering the evidence of safety and efficacy and special populations for the treatment of COPD, I move that roflumilast is safe and efficacious for the treatment of COPD. Phosphodiesterase 4 inhibitors can be subject to therapeutic interchange in the Washington State preferred drug list. All delivery systems and indications will be included for all drugs.
This is
John
Kevin.
McKay, second.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Okay, with that, the motion carries. Thank you. The llamas alone. I'm wondering for some of these, since we're saying now all delivery systems will be included, maybe we can clean up the motion a bit where, like, for example, after the tiotropium, it says DPI powder. Maybe we can just remove that. Or tiotropium is basically listed twice because of the different formulations, so maybe we don't need that. Is that okay?
This is Ryan, and I would recommend keeping them separate based
okay.
off of what we see on the left, where the DPI powder is COPD only, where the mist is asthma and COPD.
Hmm.
So just, I guess, for noticing that one device is approved for an indication, that it's different than like we had, prior in 2017, 2018 with the other devices. So I would say because of that indication difference that I would prefer them to be separate.
I appreciate that. Thank you.
This is Peter Barkett. I can make the motion. After considering the evidence of safety, efficacy, and special populations for the treatment of asthma and COPD, I move that clindamycin glycopyrrolate, tiotropium DPI powder, tiotropium SMI mist, and uniclidimum are safe and efficacious for the treatment of their approved indications. LAMAs can be subject to therapeutic interchange in the Washington preferred drug list. All delivery systems and indications will be included for all drugs.
This is Kevin when I second.
All in favor, please say aye.
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 Any opposed or abstain? Great, and with that, the motion carries. Yay, triple therapy. This was such a COPD now. Oh, okay, there's one for asthma.
For this one, the gray one is still in the pipeline, so that's why it's listed there.
Great. Comments or suggestions from the committee or questions?
This is Laura Bestie. I will make a motion that after considering the evidence of safety, efficacy, and special populations for the treatment of asthma and COPD, I move that budesonide glycopyrrolate, formoterol fumarate, and fluticasone umeclidinium elantrol are safe and efficacious for the treatment of their approved indications. Long-acting beta agonist combination with ICS and LAMA products can be subject to therapeutic interchange in the Washington preferred drug list if the preferred drug is approved for the condition being treated. All delivery systems and indications will be included for all drugs.
Christy Wayland, I second.
Great, all in favor, please say aye.
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 Aye. And any opposed or abstain? Thank you. With that, the motion carries.
That's
Ah,
it.
we did it! Yay, good job, committee. And Laura gets the award for pronouncing the most number of drugs quickly at the first go around. Okay, so do we do the short-acting agents for asthma before we take a break? Are we okay with that, committee, or do you want to take a break now? Because technically 11:10 is when we take the break. Take a break?
I say push through.
Push through. Push through.
Be bold.
All right, let's do it. Where's my agenda? So I think that's Andrea again. Do we have her? There she is. Hey.
Me again.
Welcome back. We're ready for you.
Great. Yes, hello, everyone. Again, my name is Andrea Vintra. I'm a research associate at the Center for Evidence-Based Policy. So this is our third presentation today for this drug archiving project. For those of you who were with me during any of my previous presentations, as a reminder, I'll need to repeat all the topics for this presentation because there are likely new audience members, and specifically for this presentation, that does include the background section, the clinical practice guidelines section, because this report or that last report was also for the condition of asthma. So for some of you, thank you for bearing with me. So this report is on the drug class of quick relief or short-acting medications for asthma. So the aim of this work is for the Drug Effectiveness Review Project, or DERP, to develop and present information to the Washington State Pharmacy and Therapeutics Committee on 9 drug classes that are candidates to be archived from active review by the committee. The list of the drug classes that are included in the archiving project are at the bottom of this slide, with the drug class for this presentation highlighted in green, which is asthma quick relief drugs. So for this presentation, we're going to review those topics listed in those darker green boxes on this slide. So starting on the left, I'll first define the health condition of interest for this drug class. Then I'll review the key information in the most recent DERP reports for this drug class, including the PICOS key questions, a high-level summary of the key findings, and then general findings of any surveillance that was completed after that last systematic review. Next, I'll present any new actions by the FDA for this class since the last report, including any new drug approvals, new boxed or serious warnings, and any new indications. Moving on, and then I'll report on any new pipeline drug findings, and then also the generic status of those existing FDA-approved drugs for this class. And then lastly, I'll provide a high-level summary of recommendations in relevant clinical practice guidelines for the treatment of asthma, which includes recommendations about how and where these agents are used along the treatment pathway. And then we'll have time for questions. So asthma is a chronic lung disease characterized by inflammation of the lining of the airway in the lungs, which cause the airways to narrow and the lining tissue to secrete extra mucus that results in this reversible airway obstruction. Asthma also increases airway responsiveness, which is often called hyperresponsiveness. This is this predisposition for the airway to narrow excessively in response to stimuli that will produce little or no effect in otherwise healthy individuals. And these stimuli are often considered triggers for asthma attacks. Those include things like tobacco smoke, pet dander, cold air, etc. Symptoms of asthma include wheezing, difficulty breathing, or shortness of breath. There's also coughing, particularly at night or in the early mornings, and then also feelings of tightness in the chest. Asthma symptoms can also interfere with sleep or prevent individuals from doing activities of daily living that can affect overall health and increase risk for other health conditions. Individuals can die from untreated asthma attacks, but that's rare. But there are long-term risks in individuals with more severe forms of asthma, including worsening lung function over time, and then side effects that come along with those the long-term use of certain medications like oral corticosteroids. So according to the CDC, recent statistics, nearly 25 million individuals in the US have asthma. 3 to 13% of individuals have the severe form of the condition, and those with that severe form have higher hospital utilization rates and higher medical costs, of course, than those with the non-severe form. Asthma is the leading chronic disease in children. Male children are more likely to be diagnosed with asthma compared with female children, but this is reversed in adulthood. So more female adults are likely to have asthma. There's also racial disparities in prevalence, with non-Hispanic Black children being twice as likely to have the condition compared with their white children. And then exercise-induced asthma is where exercise can trigger symptoms in individuals with asthma. There are some reports that people without a clinical diagnosis of asthma can experience exercise-induced asthma symptoms, but it's considered to be more rare. The exact cause of asthma is unknown. It's thought to be a combination of genetic and environmental factors. Common risk factors are in the green boxes at the bottom. So we have a family history of asthma, allergies, viral respiratory infections during childhood, also occupational environmental exposures, including certain dust, chemical fumes, or vapors, among others. And then obesity is also listed as a risk factor, but that the mechanism is, the causal mechanism is less clear in the evidence. So the primary goal for treatment and management of asthma the primary goals are to optimize control of the symptoms, reduce the risk of asthma exacerbations or attacks, and then reduce long-term complications. So clinically, asthma is typically classified into intermittent or persistent disease, where persistent asthma is when an individual has symptoms more than twice a week. And then with persistent asthma, it's further classified by the severity of disease. Treatment typically starts with non-pharmacologic interventions, including breathing exercises, more increased physical activity, and also to recommend avoiding environmental triggers such as allergens or tobacco smoke and cold air. The more common medications used to treat asthma are categorized into first the two drug classes that we're presenting today at the top. Those are the top bullet points in the bottom light green box on the right there. So we have quick relief medications, which is the class of drugs that we're reporting on for this presentation. Those are for acute symptoms and also known as bronchodilators, of which all are short-acting beta-2 agonists or SABAs. And then controller medications, they help to prevent symptoms and slow the progression of the disease. Those include inhaled corticosteroids, also sometimes oral systemic corticosteroids if the treatment continues to be challenging. And then also long-acting beta agonists or LABAs and long-acting muscarinic antagonists or LAMAs are also common maintenance or controller drugs for asthma. And then more recently, we have the combination quick relief and controller medications together have become available. Also, biologics are newer and are typically indicated for individuals with a more severe form of asthma. So 4 reports prepared by DERP on this topic. So the last DERP systematic review for quick relief products for asthma was presented in August of 2008. So that's over 15 years ago. And the search dates for that report were through May of 2008. And then since that last report, DERP prepared 4 surveillance reports, or scans as they were called back then, with the last surveillance presented in 2015. And sources for the surveillance were searched through mid-December of 2014. So the next 3 slides are the PICOs for the DERP products for the quick relief agents. So the population included adults and children with asthma, including those with exercise-induced bronchospasm. The comparators were another listed intervention, so only head-to-head studies. Comparators were included. For study designs, they included randomized controlled trials, non-randomized controlled trials with at least 20 participants, and also observational studies for safety or adverse event outcomes only. So for interventions, only 2 of the 7 agents that were included in the most recent report are of interest for this archiving report, and those are albuterol and levalbuterol, both of which are short-acting beta agonists or SABAs. So those not of interest for this report are listed in red text, but were included in the last report. For outcomes, the last report included symptoms, including cough, wheezing, shortness of breath, also changes in the treatment regimen for exacerbations or asthma attacks, also measures of healthcare use, also exercise tolerance and symptoms, and that's for exercise-induced bronchospasm only, also mortality, and several measures for adverse events. There were 3 key questions in the last report. So key questions 1 and 2 asked about the comparative efficacy and harms of these agents for asthma and for the prevention of exercise-induced bronchospasm. And then key question 3 asked about differences in effectiveness and harms across patient subgroups. So for this summary of findings from the last report on quick relief agents for asthma, again, I only included key findings that were regarding the drugs of interest for this archive report. So only those findings for albuterol and levalbuterol. So cumulatively, since the original report, 10 studies were included comparing albuterol and levalbuterol for asthma. And there were no studies for these agents that were for exercise-induced bronchospasm. 4 studies were in adults and 5 were in children. So for adults with asthma, for the summary of those key findings, they found that so less rescue medication was required with levalbuterol, but there were no statistical analyses done for between group differences. So no tests were done. And in general, there were no differences in number of symptoms between the groups. In the emergency department setting, there were mixed results for hospitalization admission rates. However, there were some evidence for decreased admission with levalbuterol compared with albuterol in patients not using corticosteroids. For safety outcomes, there was no difference in withdrawals due to adverse events. and most specific adverse events, although albuterol might demonstrated some increases in heart rate compared with levalbuterol. They also addressed the limitations of the evidence and reported that outcomes were not stratified by race in studies that actually included mostly African American individuals. And there were no other studies that stratified results by different populations of interest. For children and adolescents, the most recent report, systematic review, found that in general, there were no differences in symptoms, rescue medications, or number of days of inadequate control between these two agents, but that it may depend on the dose given. In the emergency department setting, there were no differences in symptoms and requirements for additional treatment, but there may be some benefit around fewer hospital admissions with levalbuterol. The report also noted that there was poor reporting of safety data across all of the studies, but in general, it appeared that there were no differences in specific adverse events between these agents, but there may be some evidence for higher rates of overall adverse events with albuterol compared with levalbuterol. And then similarly, in studies of adults, outcomes were not stratified by populations of interest, so that key question about differences across populations was a challenge to answer. Remains a challenge to answer. For findings during the surveillance period, so after the most recent report through December of 2014, they found no new FDA-approved drugs, no new boxed or serious warnings, no new comparative effectiveness systematic reviews, but they did find 2 new published head-to-head trials of albuterol versus levalbuterol, which both were in pediatric populations. For FDA activity since the most recent report, so this is including the surveillance and searches through the search dates for this archiving report, we found 1 new drug that was approved in January of 2023. This is a fixed combination drug that includes both a short-acting and long-acting agent, so albuterol plus budesonide, the brand name Airsupra. Albuterol is the short-acting beta agonist, and budesonide is the inhaled corticosteroid, of course. So I included this drug as being in this class of quick relief agents because its FDA-approved indication is for this class, as you'll see on the next slide, but recognizing that it is somewhat of a crossover agent. Regarding the next bullet point, which is also of note, the epinephrine metered dose inhaler Primatene Mist was also reapproved in 2018 for over-the-counter use through a new drug application after it was discontinued in 2011. This was despite, likely as you know, objections from physicians and medical organizations because of its potential to increase heart rate and blood pressure. And also note, it is not listed as a recommended treatment in NIH's guidelines for asthma treatment. So next we have for new indications, 2 brands of albuterol were approved for expanded use in children who are at least 4 years of age. This was in 2008, and the age was reduced from 12 years down to 4 years for this expansion. The FDA-approved indications for albuterol, levalbuterol, and the new agent Airsupra are listed here on this table. All agents are approved for the treatment and prevention of bronchospasm with reversible obstructive airway disease. This is in patients in 4 years and older and 6 and older with albuterol and levalbuterol respectively, and then 18 and older with the newer Airsupra agent. So only albuterol is indicated for the prevention of exercise-induced bronchospasm. And then in the far right column, you can see that only the newer agent, Airsupra, is also approved for reducing the risk of exacerbations because it is that combination drug of both quick relief and controller agents. So since the last report, there were no new boxed warnings or serious harms for quick relief agents. We found 1 new pipeline therapy. This was a combination therapy of albuterol, which is the SABA, plus the the inhaled corticosteroid fluticasone propionate. This is a powder formulation that's inhaled, and it's currently in phase 3 trials. So both albuterol and levalbuterol are available as generic agents and became newly available as generic since the last report. And then the exclusivity patent for Airsupra is expected to expire in 2030. So the next five slides, we're providing a very general summary of clinical practice guideline recommendations for asthma in the populations of interest, including those recommendations for how and when to use these agents along the treatment pathway. And just know that, again, that the agents or the text in blue for this presentation are regarding the quick relief agents. And again, this was done to differentiate from the guideline information for the controller agents for asthma that were presented in the last report. So in general, the recommendations mention that all patients should receive patient education and an individualized treatment action plan when they're diagnosed with asthma. Education should be around self-monitoring and how to use these inhalers and medications, and also how to avoid environmental triggers. And then pharmacotherapy is typically described in the recommendations as the cornerstone of asthma treatment. So first here we have the inhaled bronchodilator or quick relief agents for asthma symptoms, where it's recommended that all patients with asthma should have access to albuterol or levalbuterol. Those are common recommendations. And in general, the guidelines did not recommend one agent over the other. And then in patients with moderate or severe asthma, or in those who have severe asthma attacks, adding low-dose corticosteroids was also a recommended option. Regarding all pharmacotherapy, the initial maintenance therapy is based on asthma severity, and then adjustments of therapy is based on asthma control. And then for maintenance therapy, the stepwise approach to asthma treatment appears to be the core foundation in these guidelines for asthma, which is basically where medications are escalated until good asthma control is achieved. This approach is based on the levels of severity and the persistence of asthma, as I mentioned in that background section. So step 1 is for asthma that is assessed as intermittent and mild, and then step 4 or higher is for asthma considered severe and persistent. So for adults and adolescents, maintenance therapy, begins with step 1, which is basically, treatment as needed. And if pharmacotherapy is indicated, the National Asthma Education and Prevention Program guidelines recommend only a quick relief bronchodilator, so no actual controller agents are recommended in this step. However, the Global Initiative for Asthma, or GINA guidelines, do recommend combination therapy at step 1, so either as 2 agents used together or a fixed dose combination product that includes both a short-acting and a controller agent. Step 2 is also treatment as needed, where the National Asthma Education Prevention Program does recommend low-dose inhaled corticosteroids as monotherapy or in combination with quick relief or short-acting beta-2 agonist. And then GINA recommendations, GINA organization recommends the fixed-dose products of low-dose ICS plus formoterol agents. And then leukotriene modifiers, other controller agents are recommended as alternatives. For step 3 and higher for maintenance therapy in adults and adolescents, the guidelines recommend a few different options for combinations of controller medications, while the quick-acting agents are recommended to always be available as needed for symptom relief. And then for children, the overarching goals for those diagnosed with asthma are to maintain control of asthma symptoms and reduce exacerbations with the least amount of medication and side effects. So in general, the guidelines recommend more intensive management for acute exacerbations in children, which can include oral glucocorticoids in children 2 to 3 years of age if they're experiencing attacks more than twice per week. Or more than 2 days per week, and then in children between 4 and 12 years if they're experiencing these attacks throughout the day. The step care approach for pharmacotherapy is also used in this younger population for maintenance treatment. This is similar to adults. However, there's a more conservative approach to using some of the controller agents. And then it's also important to note that the step care approach can also include a step down. In addition to stepping up, of course, stepping down a level can occur if asthma control has been achieved for at least 3 months. And then this is our last slide for guidelines. We have the recommendations for exercise-induced bronchoconstriction. So in general, they report that regular exercise improves cardiovascular fitness, which can actually reduce the risk of for bronchoconstriction. So in those up-to-date guidelines, these recommendations are from the perspective that exercise-induced asthma is when exercise is that trigger for bronchoconstriction in patients with underlying asthma. So it's not just an independent risk factor. So in patients with well-controlled asthma, the guidelines recommend individuals avoid triggers such as cold or dry air during exercise. And then if pharmacotherapy is indicated, that quick relief agent like albuterol is recommended, or a combination of inhaled glucocorticoid and formoterol can be considered. And these should be taken approximately 5 to 20 minutes prior to exercise. And then for individuals who require daily therapy for exercise-induced asthma, they suggest regular use of combined short or quick-acting agents plus a long-acting product rather than a quick agent alone. And they also recommend that if these pretreatments don't work, if symptoms persist, it's likely that the underlying asthma is poorly controlled. So step-up therapy should then be considered. So this is our final content slide for this report on quick relief agents for asthma. Here we list the relevant clinical practice guidelines for the treatment of asthma that were also referenced in the guidelines section I just presented. These are in alphabetical order by author professional association. The data publications are from 2019 through 2023. Thank you so much. So I take questions maybe of the report, and of course maybe I'll direct the clinical questions to Ryan.
Thank you, Andrea. That was a great comprehensive presentation. Questions for Andrea or Ryan? And yes, if our committee members can also come back on video. Thank you. And if no questions, Nanya, any stakeholders?
No, there are no stakeholders. No hands raised.
Okay. So I suppose with that, if we could share the motion. So I think we have two motions, right?
Oh, just one motion.
Oh, just one motion, just the SABA, and then we also have something for the combination. Oh, no, okay. It's all just included in this one.
Mm-hmm.
Okay.
This is Ryan. So as you see, with the combination drugs in the past, we had previously said that the ipratropium albuterol did not have enough evidence for quick relief of asthma. So if you felt that you had enough information today on the new albuterol budesonide, you would want to change that motion as it's written there. But that's carried forward from the last time this class was reviewed in 2018.
This is Peter. I mean, I'm fine with the statement as it is, but Ryan, were you anticipating putting AirSupra on the Washington preferred drug list? I think there are other options for it. I don't think it's necessary, and I think it only recently got FDA approval here in the United States, right? And my understanding is that it's very expensive. So I'm just curious how you guys are thinking about AirSupra.
So this is Ryan, and obviously, we'd go through the cost analysis and look at whether it can be preferred or non-preferred. But, for the purposes of this P&T committee, it's really just looking at the clinical aspect. So if you felt that there wasn't enough evidence presented here at the meeting today to say that it's on par with the, tried and true to albuterol, rescue inhalers, then that's fine, and we can leave that as is, given that that was the recommendation from the P&T committee back in 2018. But if you felt differently, we wanted to make sure that you knew that you could update that based off of what you saw today.
And do you know when did the FDA approval go through? Because I think that's new since the last time this committee would have reviewed the medication.
Yes, it was really recently. Was it in the slides?
I think it's been in use in Europe, right, for a long time, but we only got it over here very recently.
Yes, I believe you're right. I believe it's used in Europe and elsewhere in the world. But to that point, I'm not sure how long it's been used.
Sorry, I was on mute.
Looks like FDA,
2023.
yep, January
2023.
10th.
Yeah.
Yep. Thank you.
So I suppose it's one thing to have it preferred, and it's another to say we shouldn't have it on the PDL at all for quick relief of asthma. And I'm leaning towards it can still be on the PDL, but the albuterol by itself remains the preferred agent. But I'm open to being convinced otherwise, depending on the thoughts of the committee.
Yeah, I'd agree with you. I think instead of what it says now, where we say there's not enough evidence, I would just change it to there is enough evidence, and I would leave that up to HCA to figure out if they want to have it on the preferred drug list or not. I suspect not because the cost effectiveness is terrible, but I think there's reasonable evidence that it's not inferior.
Other committee members, any thoughts? Thank you for that, Peter.
I would agree with Peter.
Yeah,
So,
I agree that keeping it on is fine.
so then do we need to call out anything about it? Like for, I think, other drug classes, even if it was more expensive, we did not necessarily call it out one way or the other. We just assumed it would not be a preferred agent, and providers would have to meet criteria to be able to approve it, prior auths, etc. So should we just remove that second paragraph?
So,
Oh, go ahead.
I was just going to ask, if we remove it, should we then specify that a single agent should be on formulary as a statement? Just not knowing when we'll reevaluate this.
Sure.
Knowing that we probably want albuterol, leave albuterol as an option, just in case at some point cost analysis did allow the combination therapy, to be a preferred agent. It would be nice to actually spell out that there needs to be at least one mono agent.
Mm-hmm.
This is Ryan. The reason that I would say that you would want to keep that second paragraph is that the first paragraph is specific to just the SABAs and not the SABA combinations. So you could either add in the combinations in that paragraph and make it a bit longer, or to the point that was just made by Christy, if we wanted to have one of those preferred, you could have that be in that first paragraph, and then the second paragraph just say that, after considering the evidence of safety, efficacy, and special populations for the combinations, I move that it's safe and efficacious and, cannot be preferred on the PDL or, to whatever point you want to make for its structure.
I guess the other thought then along those lines, Ryan, is, as we did for the ICS and the LABAs and how we had different motions for each class, should we have separate motions here? Because that's almost what we're doing in this one motion is the first paragraph is a motion for SABAs, and then the second paragraph is a motion for the SABA ICS combo. Do we need that? with the understanding that for every motion, I think we typically say at least one agent will be preferred, and maybe we don't do that. So I guess two questions. Do we need two separate motions? And then secondly, does that then end up requiring that a SABA ICS combo has to become preferred, which of course I don't want either.
Right. So this is Ryan. We don't need to have it be two separate motions like this. I think in the past, that's how the P&T committee approached it, just given that in the past, the ipratropium bromide and albuterol was specifically, that combination one, and they didn't want to have that be added. They wanted to focus more on using the albuterol single agent SABAs. So we could combine it into one motion. We would just have to draft it so that way we're talking about, the SABAs and the combinations, list the drugs as they are, and, say whether it can be preferred or non-preferred, or must be preferred or must not be preferred.
Okay. Thank you, Ryan. Okay, so then coming back to the, let's just start with the first paragraph, if that's okay.
So we could just add the albuterol budesonide to the first paragraph. Or
So what I heard was that Ryan is recommending keeping the two paragraphs separate, if I heard that correctly. And so,
okay, and
Mhm.
so then we don't change the first paragraph. We just, instead of saying that there's not enough evidence in the second paragraph, we change it to there is enough evidence. And then we just make the second one like approving same language as the first one.
This is right.
Maybe
I
just
don't think you
say
need to say
safe and efficacious.
Yeah, I don't think you need to say that there is enough evidence, because that is understood in, every other motion. We don't have that language. It was mainly to say that based off of what the committee saw back then, they did not feel that there was enough evidence, and that was the basis for their reason on why it should not be added.
Mhm. So we'd say, I move that these products be added to the Washington PDL. Does that sound right? Christy, I think you're saying, but you're muted.
If we make that statement, does it need to be preferred? It doesn't, right? If we say I move that it's added.
No, yeah, exactly. It won't mean that it's preferred. It just says
But
that
we
it.
do have
Mhm.
but we do have to put the safe and efficacious thing, right? Because it has to basically be the same as the first paragraph, but about the combo medicine.
Well, so
So we can
my
just copy and paste that, or
Yeah, my recommendation for the motion, in order for it to be clear, is after considering the evidence of safety, efficacy, and special populations of using combination short-acting beta agonists for the quick relief of asthma, I move that albuterol budesonide is safe and efficacious. Um, and that, could be it.
And be added to the PDL.
Yeah.
Okay, so I move that. So I think we'd come down to the fourth sentence there, Nanya. I move that albuterol slash budesonide is safe and efficacious.
Oops, sorry. Oh, sorry.
Yeah, okay.
Then remove this part,
Yeah.
move this all the way to the Washington.
Yeah.
Okay. And I will work on my spelling. Give me a quick second.
Also, while she's working on that, pure isn't available anymore in the market. Is that correct?
Right, and correct, yes, but because it was a reviewed drug in the past, we're carrying it forward, and that's why it's grayed out along with the ipratropium and ipratropium albuterol.
Right.
So
Should
if
we
you
remove it then from the main paragraph?
you could, yeah, from that top paragraph, if you do not feel
Right.
that it is safe and efficacious anymore, you could remove that from that top paragraph.
Okay.
Okay.
Yes.
So I
Yeah.
move. Sorry, go
Mhm.
ahead.
Safe and efficacious and or comma and be added to. Is that fair? Or any edits from the committee? And then we can go up to the top paragraph and remove the perbuterol. Is that is the rest of the committee okay with that, with what Laura suggested, that we remove the perbuterol?
Yeah, so in that case, you do need to have a sentence about the puberterol, just given that it is a reviewed drug. So you may have to say, after that first paragraph or at the end of that first paragraph that it cannot be preferred on the Washington PDL.
Okay. Perbuterol cannot be.
Well, you'd have to do after reviewing the evidence of
Oh,
safety,
got it.
efficacy in special populations. I move that pumeterol is not safe and efficacious for the treatment of quick relief of asthma.
Over here, right?
Yeah, so below that paragraph, no, 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 no. There's a separate paragraph.
Okay. Say that again.
Yeah, so you would
So
copy the
after,
first three sentences? Start with the same first three sentences? Yeah, that the first three lines, I should say. Yeah. All the way through, I moved that.
Right there.
Mhm. Perbuterol. Is not considered.
I guess I'm a little confused. So wouldn't we have to do the same thing with ipratropium and albuterol too? I mean, but we use Duaneb all the time. So no, I guess not for asthma though. Okay. Um, do we have to do the same with those two medications as well?
so this is Ryan. So because the previous motion specifically was saying that puberterol was safe and efficacious, we'll need a statement on why it's changing. Because we had reviewed but didn't make motions on the ipratropium, I don't believe that we need that here.
But
Let me just double check.
Comavent is available.
Right, but you wouldn't use it for asthma for unless it's a combination asthma COPD patient.
Yeah, I guess here we're primarily reviewing for asthma.
We do
So
use
then
the
would we have to, sorry, go ahead, Kevin.
I was just saying we do use the nebs like on inpatients though. Not that it would matter for the PDL.
I know that's what I was struggling with too, but I mean primarily it's our COPD patients with asthma or the combination. You wouldn't normally use it as a first line agent just for a asthma patient or asthma exacerbation.
Yeah, even on the inpatient side, I agree for pure asthma exacerbation.
Yeah, and I think this is Ryan again. So I think that's why we didn't have any inclusion. I think Looking back to the 2016 motion, it didn't mention anything about the ipratropium. So I'm assuming that in the past, the P&T committee decided that even though they reviewed it, that it wouldn't be part of the motion and part of the PDL for quick relief of asthma.
Are these medications listed elsewhere for COPD?
Let me check the Washington PDL on how this class is listed. Give me one moment. Looking at our Washington PDL, these drugs are not listed within the quick relief class, but they would be on the UMP preferred drug list. So for the health plan, uniform medical plan, those drugs would be available. They're just not under the purview of this Washington P&T committee, but they would be available to members.
So maybe for this specific purpose, we just stick with the probuterol and leave the ipratropium alone. Just literally, it's a gray zone, as is the gray lettering. Would that be okay?
Yes, that would be fine because again, in the past, we had not made any motions on those drugs.
How's the committee feel about having this paragraph about the probuterol?
I like the paragraph just because it's not available, so I don't know. I wouldn't list it up above as safe and efficacious when it was removed because it was
Yeah.
the fluorocarbon base.
Okay. So then let's continue. I move that probuterol is not considered safe and efficacious for quick relief of asthma. Okay. Other edits?
In the first paragraph, is it necessary that we say no single short-acting beta agonist is associated with fewer adverse events in special populations?
Great point, Christy. I was wondering about that too. We've not typically called that out. How's the committee feel about that? And Ryan, does it serve any purpose by being there?
This is Ryan. I think older, previous P&T committees, they would make statements like that, kind of about the evidence or about what they saw, and maybe using that as part of the rationale for why they would make a decision. So I think in this case, there was questions about the CFCs going to the HFAs. As you recall, that was many, many years ago, and there may have been questions about the type of adverse events that may have been derived because of the different formulation in the propellants used for the quick relief medications. So this was the P&T committee's way of saying that they did not see any differences between the quick relief products, and that's why they could say that there was therapeutic interchange. So in case that there was a provider that wanted ProAir instead of, Proventil or something to that nature, that the P&T committee reviewed that and said, there is no basis for there being any difference or variation in safety events. So again, it doesn't necessarily add anything, but I think it just helped us know what the P&T committee was thinking at the time when they were reviewing the evidence.
This is Laura. I have a feeling too that originally when levalbuterol was released onto the market, their big push was that they had less tachycardia. And later on, that really wasn't shown to be significant between albuterol and levalbuterol. So I know that we struggled in the hospital P&T with that decision, and there wasn't enough data to support it.
So this is Donna. At the end of the day, your answer, do we need it? The sentence, no, we don't. You can delete it if you want to.
I'm good with that. The more succinct and clear, the better. Does the rest of the committee agree? Yes, I see nodding. Okay. Nanya, we can delete what you've highlighted right there. Great. Any other edits? And if not, we can proceed with the motion.
Just do we need to get so
Oh.
prescriptive about? Oh, I'm sorry. Just because technically ProAir and like Ventolin are different drugs. I guess for the healthcare, it doesn't matter to you, I would imagine.
No, so this is Ryan. So for this, we consider all the ingredients. I think in the past we did make that, and if you look at some of the older motions, we would try to call out some of the different newer formulations that were identified in the reports. But in the last 5, 6 years, we've just been listing the ingredients and helping clean up because we do have some pretty long lists of drugs now in those drug reviewed columns.
And that's a great point, actually. That also reminds me, should we have the statement that we had for the longer acting agents in here too, as in all the formulations are included in this motion?
I agree. I think we should add it to be consistent.
Look at that. She's ready to go, Nanya. Thank you. Okay. Are there questions, edits, or enhancements?
This is Kevin Fun. After considering the evidence of safety, efficacy, and special populations of using short-acting beta agonists for quick relief of asthma, I move that albuterol and levobuterol are safe and efficacious. The Washington preferred drug list must include a nebulizer and metered dose formulation. The short-acting beta agonist can be subject to therapeutic interchange in the Washington preferred drug list for the quick relief of asthma. After considering the evidence After considering the evidence of safety, efficacy, and special populations of using short-acting beta agonists for quick relief of asthma, I move that berbuterol is not considered safe and efficacious for the quick relief of asthma. After considering the evidence of safety, efficacy, and special populations of a buterol budesonide combination for quick relief of asthma, I move that a buterol budesonide is safe and efficacious and be added to the preferred drug list for the quick relief of asthma. All delivery systems and indications will be included for all drugs.
This is Greg Hudson. I second.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? With that, the motion carries. Thank you. Okay, so with an eye on the time, how are we doing committee? We're definitely long overdue for a break. And there are a couple more drug classes that need to be reviewed before we can do the archive, the bulk archive motion. Should we take like a 5-minute break, or do you want to keep powering through? Let's do like just a sanity bio break for 5 minutes. How about that? And
Yep,
then just
sounds
come
good.
back. Yeah. Okay. 5 minutes. We'll come back and we'll keep soldiering on. Thank you. Welcome back, committee. I think most of us are back. Nani, I think we need, what, 8 for quorum? Is that the deal before we get started?
We need 6.
6. 1, 2, 3, 4, 5, 6. Yay. Okay, ready to get started. Okay, and we bring back Andrea for overactive bladder agents.
One more time. Hopefully you're all won't get too tired of my voice.
Okay.
Let me share this with you. Very good. Okay. Great. So yes, my name is Andrea Vintra. I'm a research associate here at the Center for Evidence-Based Policy. This is the 4th out of 5 presentations for today for this Washington Drug Archiving Project. The first 4 drug classes were presented at the February P&T committee meeting. And then just as a reminder for those of you who were with me during any of my prior presentations, I'll have to repeat all of the topics, including the AIM general overview for this in the upcoming report, because there may be new audience members. So thank you for bearing with me. So this presentation is entitled Drugs to Treat Overactive Bladder. So the aim of the work is for the Drug Effectiveness Review Project, also known as DERP, to develop and present information to the Washington State Pharmacy and Therapeutics Committee on 9 drug classes that are candidates to be archived from active review by the committee. And the list of the drug classes that are included in the project are at the bottom of the slide. And you can see overactive bladder drugs is highlighted in green for this presentation. So we're going to review the topics in the darker green boxes on this slide for overactive bladder, starting on the left. I will first define the health condition of interest that this drug class intends to address and summarize the general epidemiology and common treatments for the condition. Then I'll review the information that's in the most recent DERP reports for this drug class, including the PICOSY key questions, a high-level summary of the key findings, and then general findings of any surveillance that was completed after the last systematic review. Then I'll move to any new actions by the FDA since the last report, including new approved drugs, any new box or serious warnings, and any new indications. And then I'll move on to report on any new pipeline drugs in this class, and then also the generic status of the FDA-approved drugs in this class. And then finally, I'll provide a high-level summary of relevant clinical practice guidelines for this condition of interest, including recommendations for how and where these agents are used along the treatment pathway. And then I'll be available for questions. Okay, so background on overactive bladder. So overactive bladder is defined by the International Continence Society as a syndrome of urinary urgency with often with urinary frequency and nocturia. And then nocturia is frequent nighttime waking in order to urinate. This is all in the absence of other conditions that could cause these symptoms, such as obstruction or cancers. A subset of patients with overactive bladder may complain of urge or stress urinary incontinence. So this urge incontinence is this involuntary leakage of urine, which is then accompanied by or immediately precedes the feeling of urgency. And then stress incontinence is defined as the inability to retain urine or leaking of urine when sneezing or coughing. This latter symptom occurs more often in females. In the clinical literature, overactive bladder is often included under the more nonspecific condition of lower urinary tract symptoms, or LUTS, when discussing these issues in males. But LUTS can also be used to describe issues that are experienced by females. So this is going to be helpful to know as we walk through what the clinical practice guidelines say for the condition at the end of this presentation, since for the most part the recommendations are presented for each sex separately because of the different organ system physiology between males and females. So overactive bladder is common and prevalence increases with age. So around 15 to 23% of US adults are diagnosed with overactive bladder, and the prevalence in males compared with females differs somewhat depending on the resources that we looked at, but it was consistently reported that females are more likely than males to report the symptom of urge incontinence. Risk factors for overactive bladder include smoking, obesity, arthritis, depression, heart disease, and irritable bowel syndrome. Additional risk factors specific for men include a history of prostate disease. And then additional risk factors for females include certain neurological conditions, such as multiple sclerosis, also diabetes, pregnancy, urinary tract infections, uterine prolapse, hysterectomy, and menopause. There was a study in 2012 that reported evidence showing prevalence of overactive bladder was highest in African American individuals and lowest in white males. So in general, for treatments of overactive bladder, first-line treatments include behavior modifications such as pelvic floor muscle exercise. It's very interesting to learn that, yes, Kegels are for men too. Bladder training also, fluid management, achieving and maintaining a healthy weight, and also having a healthy diet and exercise routine. Pharmaceutical agents are considered as second-line treatments. So for males, it's important to identify if the symptoms of overactive bladder are caused by prostate enlargement, and if that's the case, medications are first recommended to minimize or are commonly used to minimize blockage, are the first-line treatments, and then anti-muscarinic agents. Muscarinic agents are common treatments, and they help to reduce bladder contractions. And then beta-3 adrenergic agents or agonists are drugs that can promote bladder relaxation during the filling stage. Third-line treatments include peripheral tibial nerve stimulation, also sacral neuromodulation, and botulinum toxin injections. The stimulation method involves electrical stimulation of nerves that are responsible for bladder control, and then the botulinum toxins can help to relax the bladder muscles. So regarding reports prepared by DERP on this topic, so the last DERP systematic review for drugs for overactive bladder was presented in June of 2018. This is just about 6 years ago. And the sources for that report were searched through February of 2018. And there has been no surveillance for this drug class since that last review in 2018. The next 3 slides list the PICOs for the most recent systematic review for this drug class. So for population, they included adults with urge incontinence or overactive bladder. For comparators, only another listed intervention was included, so head-to-head trials only. For outcomes, they looked at change in incontinence and urgency episodes, also the number of pads that would be used, patient symptom assessments, and then various measures for adverse events. For study designs, they included randomized controlled trials, systematic reviews that were considered good quality and published in 2013 or later. And then for harms outcomes only, they allowed comparative cohort or case controlled studies that were eligible. So this table lists the interventions included in the last report. They're in alphabetical order by generic name. So all of these drugs are considered urinary antispasmodics. So when we look at that far right column, the majority are muscarinic antagonists, except for mirabegron in that 5th row there, which is a beta adrenergic receptor agonist. So then back to the top there, we have darafenacin, then fesoterodine fumarate, flavoxate hydrochloride, which was the first drug approved for overactive bladder in 1970. It's now only available as generic. And then we have mirabegron, oxybutynin chloride, and oxybutynin. And then next is sulfenacin, succinate in that 8th row, and then trospium chloride in that ninth row. And then at the bottom, we have tolterodine tartrate. So 7 of these drugs have extended release formulations. Oxybutinin chloride with the brand name Gelneek is a transdermal gel, and oxybutinin with the brand name Oxytrol is an extended release transdermal film product. So the most recently approved agent listed here is mirabegron, which was approved in July of 2012. The last report included 2 key questions. So they asked about the comparative effectiveness and harms between these agents for overactive bladder, and they also asked about the differences in the effectiveness and harms across patient subgroups. You can see those listed on this slide. With the 2018 report being the 6th update from the original report, the cumulative number of studies included were 44, all of which were head-to-head comparative studies. So 42 were randomized controlled trials, of which some of the older trials were included only via a systematic review, so not as independent publications. And there was also 1 cohort study that was included. So for the summary of key findings, we list here the number of the studies included for each identified drug comparison. So there was only 1 study identified for 6 of these comparisons, but there were 15 trials, the most by far, that compared tolterodine either as an intermediate or extended release formulation with the intermediate or extended release formulation of oxybutinin. So continuing on with key findings, for all of these mentions, while there were some statistically significant differences in the reported outcomes for some of these drug comparisons, nearly all were considered not clinically meaningful. I do want to point out that 4th sub-bullet point there that mentions there were fewer withdrawals due to adverse events with solifenacin and tolterodine compared with oxybutinin, which may be of interest. For new FDA-approved drugs and actions since the most recent report, we identified 1 new drug approved for overactive bladder. Vibegron with the brand name Gemtesa was approved in December 2020. This is a beta-3 adrenergic agonist. It's delivered via an oral tablet. We also found new indications for 2 of these agents. So both were approved for expansion to include the new indication of neurogenic detrusor overactivity. This is a type of bladder dysfunction where there's an increased or involuntary muscle contraction of bladder muscles. This is a common complication in patients with multiple sclerosis and injuries of the spinal cord. This indication was added to fesoterodine fumarate in June of 2021 for pediatric patients at least 6 years of age, and then also added to mirabegron in March of 2021 in children at least 3 years of age. In April of 2018, the indication for mirabegron was also expanded to allow for combination use with a muscarinic antagonist, specifically solifenacin succinate, which is also included in this report. And just to confirm that there was no change to its approval for it to be used as a standalone or monotherapy agent. So we have the FDA-approved indications for the agents of interest on this slide. All drugs are indicated for overactive bladder with symptoms of urinary incontinence, urgency, and frequency, as you can see from all those check marks in that middle column there. And then 3 drugs have an additional indication that's on the far right column, and this is for neurogenic detrusor overactivity in pediatric patients. And those agents include fesoterodine fumarate, or Toviaz is the brand name, also mirabegron, and then the extended release tablet formulation of oxybutinin chloride. Since the most recent report in 2018, there were no new boxed warnings or serious warnings for any of the included drugs for overactive bladder. We did identify 1 new pipeline drug in phase 3 trials for the indication of stress urinary incontinence. The drug is iltamiocel, This is a stem cell therapy that's delivered via injection. If approved, it'd be a potential option for females with stress urinary incontinence where prior surgery for this condition proved unsuccessful, and the approval outlook for that is in 2026. So on this slide, we show generic status for these agents. 7 of the included drugs appear to be available as generics. So darafenacin, flevoxate hydrochloride, oxybutynin chloride, trospium chloride, and tolterodine tartrate had formulations that were already available as generics with the last report in 2018. In that third row, there we can see festoridine fumarate is also now available as generic since the last report. And then row 5, mirabegron is not yet available as generic, but appears to be losing its patent exclusivity status this year. And it appears that there are multiple applications submitted to the FDA for generic manufacturing. And then row 7, we see that solifenacin succinate was recently approved for generic manufacturing. And then in the bottom row, we have vibegron, which will likely not be available as generic for some time with its loss of exclusivity date out about 10 years from now. So on the next 3 slides, we provide the very a general summary of clinical practice guideline recommendations for overactive bladder. This includes recommendations for how and where the agents of interest are to be used along the treatment pathway. For this section, we began with information from the up-to-date clinical decision support online resource, and then cross-referenced that information with key practice guidelines from professional medical associations, which are listed at the end of this slide deck. The guidelines for overactive bladder were differentiated by sex because of the difference in physiology of the organ system. So the first 2 slides here, we're summarizing the practice guidelines for females. Non-pharmacologic interventions are recommended as first-line treatments, and those include education on pelvic floor muscle exercises and bladder training. Also, healthy lifestyle behaviors can help with these symptoms. If there's vaginal atrophy, which is often associated with 1 or more urinary symptoms, there are recommendations to treat with topical estrogens as needed. And then if these treatments do not provide adequate relief of the symptoms, the next step would be to add systemic pharmacologic agents, so oral agents. So in addition to continuing with non-pharmacologic approaches just mentioned, together, yes. So in general, extended release formulations were preferred if available, and this is according to the American Urological Association. And then the guidelines recommend that the medications be continued as long as there are improvements and the patients do not experience any bothersome side effects. On this slide, we have more detail around the pharmacologic agents for female patients. So beta-3 adrenergic agonists are recommended first because of some evidence for increased risk for adverse events with including dementia with the anti-muscarinic agents. And they do acknowledge that the cost is greater, however, as these are newer agents. And for those who are prescribed antimuscarinic agents, trospium and darfenacin are preferred because there's more evidence, even though the volume of evidence is still considered weak and limited. However, that evidence did demonstrate that these agents are worse at penetrating the central nervous system, which is preferred, of course, compared with the other antimuscarinic agents. And so it's recommended, these guidelines recommended to start with the lowest dose and then reassess after 2 to 6 weeks and then adjust the doses as needed. And then if these symptoms continue while these individuals are still on these medications, the guidelines recommend to refer to a specialist where they may consider 3rd-line options, including tibial nerve stimulation, botulinum toxin, injections, sacral neuromodulation, and also laser therapy. So we'll switch over now to the guideline recommendations for the treatment of overactive bladder in males. As mentioned earlier, in males, this condition is often labeled as LUTS, the lower urinary tract symptoms, which is a more sort of nonspecific term. It's recommended to first evaluate whether symptoms are due to an enlarged prostate with bladder outlet obstruction. And this is the most common diagnosis when male patients present with these symptoms. So with overactive bladder, so similar to females, should that be diagnosed, the first line treatments are non-pharmacologic interventions, pelvic floor exercises, bladder training, healthy lifestyle behaviors, achieving a healthy weight. And then if these initial treatments don't provide adequate relief, the next step would be to add medications. So for isolated overactive bladder, the recommendations are identical to females. So where we're seeing beta-3 adrenergic agonists are recommended first over antimuscarinic agents. And then I've included what is generally recommended for enlarged prostate, including that bottom bullet point there, which states that, if the diagnosed condition is mixed, overactive bladder with obstruction, which is supposedly quite common, it's recommended to treat the obstruction first. So our final slide of content, we list the key clinical practice guidelines that were also referenced for the guidelines section for overactive bladder. They're in alphabetical order by author or professional organization, and the date of publication or updates for these guidelines range from 2014 to 2020. Thank you so much. And again, questions about the report from me, and then any clinical questions likely to Ryan.
Thank you, Andrea. I suppose just a question that I have is on the basis of these clinical guidelines for OAB in women, since vaginal estradiol is considered to be one of the first line approaches, is that something that we would include under DERP? I guess the same theme as my questions before, and whether we'd review that as part of the motion today.
This is Ryan, and the estradiol is actually a different drug class on the Washington PDL that has been previously archived. So again, kind of with the previous recommendation, these classes of drugs that we're defining with DERP and bringing to build the Washington P&T were, kind of identified because they were the more expensive and newer ones back in the mid 2000s. So that's why it doesn't include everything for the treatment of the disease state, just the newer drugs that fit that criteria.
Great, thank you.
This is Peter Barkett. I have a question about the place in therapy of beta-3 agonists compared to the antimuscarinics. Which organizations or guidelines recommend the beta-3 agonist before the antimuscarinics? I wasn't aware of that. And my understanding is they're equally efficacious, but different side effect profile. And I thought that the cognitive side effects was more of a theoretical risk than something that's actually been proven out. So I wanted to do a little bit more digging into that.
Yes, I mean, I will have to be doing a little bit more digging myself. I think I don't know, Ryan, if you have, I don't have them listed by which, this was again, starting from up to date. And so if there was anything that was specific to one of the guidelines that was listed on this last slide, that would have been sort of called out. So this was primarily in the up to date, and it was not otherwise stated in the other guidelines. But
and this is Ryan. So it looks like one of the sources for the guideline updates was the European Association of Urology. So I'm wondering if this may have been preferred in Europe versus through an American, guideline like the ACOG. So I can look into that and see if I can find a little bit more information on the beta over the muscarinic.
So Kavita here, I'm just the 2024 American Urological Association guidelines. It seems like, yes, they're not really distinguishing one over the other in our AOA guidelines. Sorry, frog and throat.
And that could be updated. I could update that. That is of interest. Right.
This is John McKay. I had a quick question for Ryan in terms of what anti-muscarinic agent is typically preferred currently.
Give me one sec. I'm pulling up our PDL. So for the short acting, our preferreds are the oxybutynin syrup tablets, the tolterodine tablets, the trospium tablets, and for the long acting, we have the darifacin ER, the oxybutynin ER, the solifacin tablets, the tolterodine ER tablets, and the trospium ER capsules. So quite a few are preferred on the Washington PDL.
Out of interest, Ryan, since you're already there, do we have any vaginal estradiol formulations that are preferred?
That's going to be under the estradiol. So let me scroll there. And I believe, those were archived a couple years ago, so they're not in this version. I could check the Washington PDL for that. I mean, the Uniform Medical Plan PDL, because that will be the more current one on how it's applied to the health plan.
While Ryan is looking that up, other questions from the committee?
Should the fact that Myrbetriq is going generic next year affect anything we do today, or would that be more of like a DUR board thing for next year?
So this is Ryan. So for the Washington P&T committee, you're just going to be reviewing the clinical and efficacy and safety aspects. So if a drug is going generic, that will be handled during our cost analysis process. And that's separate from the DUR board, which is Apple Health specific. So
Okay.
you may get some more of that specific to Apple Health at the DUR. But
Got it.
for this, your P&T hat that you're wearing right now, you'll just focus on the clinical safety and efficacy.
I think that does bring up a good point, Zoe, that, in general, we do see that the side effect profile is better with mirabegron. So I don't know if there's any kind of
Yeah, it's much better, but I think we
correlation.
can look at the motion and just see maybe when we get to the motion and decide if we want to do anything different.
Yeah. Are there any stakeholders before we get to the motion, Nanya?
Sorry, I was trying to unmute myself. Just looking, I don't see any hands raised, and there are no pre-registered stakeholders. So I'll go ahead and share the motion now.
Thank you.
So Kavita, just to answer your question, so I'm looking at the Uniform Medical Plan PDL, and we do have a few vaginal tabs for the estradiols. So it looks like there is the estradiol gel and another estradiol gel.
Okay, which are preferred.
Yes, they are preferred, and they are on tier 2.
Okay, thank you. Thank you for looking that up. Okay.
Ryan, this is John McKay again. Quick question. Does it take a failure of 2 anti-muscarinic agents to get a Myrbetriq approved, or what does it take to get it approved?
So that is a UMP PDL question. And also I believe L&I participates in this class too. So I believe that for a Uniform Medical Plan, it would require trial and failure of two of those preferred that I had mentioned earlier. So typically we see the oxybutynin being used, and then either the tolterodine or the trospium as kind of the second, and then from there the third could be the mirabegron.
This is Laura. So I have a question. So by saying that they're interchangeable within them, if you chose mirabegron because you had a patient that was elderly with dementia, so you didn't want to use an antimuscarinic, would you still have to use a antimuscarinic in that patient, or can you just use your beta 3 and not have to jump through those hoops?
You could send a PA to MODA and let them know that these other drugs are not appropriate because, they're on the beers list, or, there's other safety concerns that you've identified with the anticholinergics or antimuscarinics. So in that case, you could potentially get it approved without having to step through those. But for most patients, they would have to step through the preferreds in order to get to a non-preferred.
It's not appropriate to have the therapeutic interchange between these classes, though, right? Like that's something that seems like we really need to change on this resolution.
I kind of feel strongly about that too, just
Yeah.
because of that geriatric population.
Yeah. Like you couldn't have it be that you prescribed mirabetrol and instead of requesting a PA, the pharmacist just changed it for something else. Like that would not be acceptable. So we should not allow that.
Can we just put within its same class? Because it is a different class.
This is John again. I feel like there's a lot of clinical variability too, even within the antimuscarinic class in terms of tolerability, just with oxybutynin versus the more selective agents. So, I probably wouldn't want to interchange one of the more selective antimuscarinics with oxybutynin.
So I'm hearing two concerns here. One is we don't want interchangeability between the beta 3 agonist and antimuscarinics. And so we should have a statement to that effect. And then the second concern is the interchangeability just within the antimuscarinics. So why don't we tackle one at a time? Let's start with the beta 3 because that which was stated first. So should we say in here, give me some can be subject to therapeutic interchange within the same drug class. I'm seeing nodding, yeah, okay. Interchange, yeah, right there. Nanya, within the same drug class.
Can we just remove the whole interchange in this class and remove that whole sentence?
In general, I think that's a good idea, but I wonder, like, there's so many different ones. Like, if somebody failed oxybutynin, I might be like, okay, let's try trospium, and then the pharmacy doesn't have it. Like, I do kind of want them to be able to do like sulfenacin or tolterodine instead, like in that case. So I guess I feel kind of mixed about not allowing it at all. Especially if we're just trying to step through two and it doesn't really matter which two.
So John, along the concerns you were having, how would you phrase this so that it's best for the patients?
We didn't really go into terms of selectivity that in depth in terms of their tolerability too. So I would be fine with leaving it just for open within the class, but I do think oxybutynin is probably less tolerated than the other agents in terms of dry mouth and just its anticholinergic effects. And
so which of the extended release other agents are better? And if they're on the preferred drug list, then great. It sounds like
I think it would be trospium and derfenazine, right? And they're both preferred, I believe. We could exempt them in the language so that they stay preferred, or if they are no longer preferred at some point, then they wouldn't get changed to others. But I think, John, that would be probably the way to accommodate that request for the more neuroselective antimuscarinics would just be to exempt those two.
What do others think about that in terms of their experience clinically? Do they notice a different much within the class there?
I usually start with trospium for that reason, but I don't know if it always plays out the way I expect.
I'll be honest, I haven't seen it one way or the other, and I haven't seen our urologists call out one agent over the other. I could be missing something. Other experiences from clinical practice that would inform this. And I think, as you said, the main thing is that they are already preferred. And since they're already generic, I doubt they will ever become non-preferred.
I like how Peter worded it and have the trospium um, and the two agents that are, what's the other one that's less Peter just said it.
It's
I know the
darafenicin.
trospium, yeah. I have those two separate that we can't interchange for those because once again you're back to that geriatric population as well where you wouldn't want to use oxybutynin if possible.
So did I hear trospium and darifenicin? Okay.
I would be good with that approach.
Okay, so how do we want to word that? Any of you want to dictate that out to help Nanya? I think that part, Nanya, is good. I would, yeah, just do the spell correct there. Perfect. And then I
Maybe,
can be an additional statement. Go ahead,
yeah, I
Peter.
think just like at the beginning of the sentence where it says these drugs, and I just put comma with the exception of trospium and darafenicin, comma, can be subject to therapeutic interchange within the same drug class in the Washington Preferred Drug List.
Okay, great.
We need to say why as far as like decreased CNS.
We could, yeah, we could put in like
Yeah, or future
parentheses due
committees.
to greater neuroselectivity.
Yeah. Okay, so with the exception of trospium, trospium.
Sorry. Right there with the
Exception
exception of
of
this one.
the one below it.
Oh, thank you.
And the one that starts with D, darifenicin, the first one.
Oh. I missed it.
All fun drug names.
Yeah.
With the exception of trospium and darifenicin due to their neuroselectivity, comma, neuro, N-E-U-R-O.
You said neuroselectivity?
Yes.
Oops. I have a little. Did I capture that? Where did it? Do I need to correct that?
Yeah, so it's N-E-U.
Thank you. Thank you. Oh, is it any? Okay.
I put it in the chat. I don't know if you can copy from the chat or not.
There. Is that correct?
There just needs to be an E after the L.
Yeah, E after L in selectivity.
There we go.
Okay.
Beautiful.
Thank you.
And then a comma after that long word. And then I think there should be a period instead of a comma after drug lists before immediate release, just because I think it's a run-on sentence otherwise.
Mm-hmm.
So we could say like additionally, immediate release formulations cannot be interchanged for once daily formulations.
Additionally, ly. Perfect. Immediate release formulations.
Can I just make sure it's clear that like, so what we're saying is that if you prescribe trospium or darafenacin, they can't replace it with a different one. But if you prescribe oxybutynin, they still could replace it with trospium, which is something we would want them to do anyway. Or is it both? Is it bidirectional, I guess?
I'm reading the motion is that drugs except for trospium and darifacin are subject to therapeutic interchange within their classes, and that the trospium and darfenicin don't have any interchange within them. So if someone were to prescribe either of those drugs, there's no way to change to them
Perfect.
or from them.
Okay, that's fine.
Yeah, I think the last sentence here is kind of just there for good measure, given the number of generic long-acting drugs we do have already on the formulary as preferred agents. Am I thinking about that right, Ryan?
So this is Ryan, and yes, I mean we do have 5 currently on it. I think it's fine to keep it as is, just to reiterate that yes, we do want to make sure that we do have a once daily version available in case, who knows what happens in the future. Because this is a class that is being archived, and so this motion would remain in perpetuity, forever.
For clarity, is it on the far left-hand column? Could we separate out antimuscarinics in beta 3?
So this is Ryan. The way that we have it set up right now on the PDL is between long acting and short acting. I don't know. I mean, we could divide it even further into 4. So long acting and short acting for both the beta and the muscarinic. We don't necessarily need to do that for the column on the left. But if there is direction for us to split it out further, we could do that in the next update, which would be the October PDL update.
I guess my only concern was just on the where it says drugs reviewed to put the beta 3 agonists separate from the antimuscarinics, just because we've separated in here that within the classes they're not interchangeable.
And so to call out what those classes are.
Correct.
That's a good point. I agree with that. Just in the left-hand side.
Okay, so can you help Nonya?
Yeah.
Yeah.
On the leftmost column, Nonya, at the very top, if you could write antimuscarinic, so ANTI. And actually, I can also drop it in the chat. That might be faster. Muscarinic agents. And then it would be beta 3 agonists, which I'll also drop. And so we're going to make a separate section for the mirabegron and the vibegron. So the 1, 2, 3, fourth agent there, the mirabegron. We'll remove that for a different agent. Just that one, not the whole section.
Okay, remove this one.
Yeah, just that one. We will move it down to a separate section of its own.
So just want to clarify, this all stays together?
Yeah, and the last agent, the vibegron.
That would be by itself?
Along with the mirabegron.
Oh, thank you.
Perfect. And then the name for that second section is what I dropped in the chat, which is the beta 3 agonist. Am I saying that right? My pharmacy friends, please keep me accurate here.
Correct.
It's not covered. Sorry.
You're
Just trying to grab that. Okay, it doesn't like it. Let me write it out.
Right.
Like that?
But you put in adrenergic. Kevin's making
Oh,
a
thank you.
correction there. Thank you.
Sorry, I should spell it out and I failed.
Thank you.
Like that?
Yes. Does that look good, committee?
For formatting, let's have those be underlined and not bolded.
Yeah, that's what I'm doing next.
And then not bolded. Thank you.
I guess then the final question is, for the last sentence, a once daily formulation must be included as a preferred drug. Do we want to call out that that should be one of those neuroselective agents? Since this is for, as Ryan said, perpetuity, do we want to call out those two agents here?
I think we should. And I also just have a question about like if Mirabetriq is going generic next year, like will there be an opportunity to put that on the to make that preferred if we're never reviewing this again? Or is that something that can happen at DUR even though we're not reviewing this again?
So this is Ryan. So the point of archiving these reports is that, as you see, the DERP states are not voting for these classes to be updated anymore. And so there's been a lot of time since we've been able to get new evidence on them. So we are essentially archiving these, meaning that we don't need to bring a new report to the P&T in order to conduct a new cost analysis. So that
Got
way,
it.
because of this, next year, we could always do a new update without having to conform to the P&T schedule and get a new report. We could just go ahead and do that and then get it updated. So this would improve future generic entry for drugs like you had mentioned.
Great, thank
So
you.
by us saying that, this is Laura, but us saying that we're not going to substitute for trospium and darafenicin, are we automatically saying that they're preferred or not? They might still have to get prior auth for them.
So they're both preferred right now on the PDL, and I don't imagine that we would, but there doesn't, you know, Yeah, there isn't anything that would require us to always keep it preferred.
Okay. The reason I was asking is because darafenicin is just once daily anyway, so I don't know that we need to call out those two necessarily because we've already said we can't interchange them,
Okay. Great.
unless I'm looking at that wrong.
I think if, they're already generic, they won't go ungeneric. And so as long as we have them available, um, I think that then we don't need to make any adjustments to the last sentence. Other comments, edits, enhancements? And if not, we can proceed with this beautifully written motion.
This is Laura Vesti. I will make a motion that after considering the evidence of safety, efficacy in special populations for the treatment of overactive bladder, I move that darafenicin, fesoterodine, fumarate, fluvoxate, hydrochloride, mirabegron, oxybutynin chloride, sulfenicin, tolterodine, tartrate, trospium chloride, and vibegron are safe and efficacious. These drugs, with the exception of trospium and darafenicin, due to their newer selectivity, can be subject to the therapeutic interchange within the same drug class in the Washington Preferred Drug List. Additionally, immediate release formulations cannot be interchanged for a once daily formulation and vice versa. A once daily formulation must be included as a preferred drug on the Washington Preferred Drug List.
Peter Barkat, I'll second the motion.
Thank you. All in favor, please say aye.
Aye.
Aye. Any opposed or abstain? That the motion passes. Excellent. And I think we have one more review for long-acting opiates before we go for lunch. Is the committee okay with that? Yes. All right, Andrea, whenever you're ready, take it away.
Okay. Are we seeing that?
Yes, we do.
Perfect. Okay. Yes, hello. One last time. I'm sure you're all thrilled. This is the final presentation today for this Washington Drug Archiving Project. My name is Andrea Vintro, and I'm a research associate at the Center for Evidence-Based Policy. Just once again, I'm needing to repeat some of the information around the aim, general overview of the project that I presented in prior reports, because there may be new audience members. So thank you for that. And this presentation is entitled Long-Acting Opioid Analgesics. So the aim of the work is for the Drug Effectiveness Review Project, also known as DERP, to develop and present information to the Washington State Pharmacy and Therapeutics Committee on the 9 drug classes that you see below there that are candidates to be archived from active review by the committee. And the topic of long-acting opioids is highlighted in green for this presentation. So for this report, for the overview, I'm going to review those topics in the darker green boxes on the slide. So at first, I'll define the health condition there on the far left for the drug class that is intended to, this drug class is intended to address, summarize general epidemiology and common treatments for the condition. Then I'll review key information in the recent DERP reports. Including the PICOs and key questions in the last reports, a high-level summary of the key findings and general findings of any surveillance since the last systematic review. Then I'll move to new actions by the FDA since the last report, including any newly approved drugs, new boxed or serious warnings, and any new indications. And then I'll report on any current pipeline drugs and also the generic status of existing agents in this drug class. And then finally, I will present a high-level summary of relevant clinical practice guidelines for this condition, which includes information about how and where these drugs are used along the treatment pathway. And then they'll be available for questions. So this report focuses on the condition of chronic pain that is not related to cancer or cancer treatments. This is chronic pain that's typically defined as lasting at least 3 months. It's a common cause of major disability that can result in substantial healthcare costs and loss of productivity, and of course, poor quality of life. So here we list the common example terms that people use to describe this kind of pain, such as aching or throbbing sensations. The condition of high impact chronic pain is defined as pain that results in serious restrictions to daily activities. And then types of non-cancer chronic pain include arthritis, or joint pain, back or neck pain, also headaches, among the other types listed here. So in adults, chronic pain is associated with other medical conditions, including depression, Alzheimer's, and other dementias, also higher suicidal risks, worsening chronic disease, and substance misuse. It's also associated with poor quality of life, of course, and as mentioned earlier, there are societal concerns as well around reduced productivity and loss of wages. According to the CDC, the number of adults in the US with chronic pain has increased since 2016, with nearly 21% of all adults experiencing chronic pain in 2021. Also in 2021, there's approximately 52 million individuals in the US that experienced chronic pain, and then 7 to 8% of adults are experiencing the high impact chronic pain. There are disparities across populations for chronic pain, so a higher prevalence is seen in individuals who identify as non-Hispanic American Indian or Alaska Native adults, bisexual adults, and adults who are divorced or separated. So in children and adolescents, chronic pain is associated with depression and anxiety, also school absence, social isolation, and poor quality of life. It's also commonly attributed to headaches and GI disorders in youth. Factors that have been associated with the development of or risks for chronic pain in the scientific literature include some demographic factors, including being of advanced age, also experiencing a lower socioeconomic status. Lifestyle behaviors such as smoking, sedentary behavior, and poor diet. Also people with certain clinical conditions, including mental health conditions, surgical interventions, and being over or underweight, and also other factors such as a history of injury or abuse. So the management of chronic pain often requires a multimodal approach that can include a combination of pharmacologic and non-pharmacologic therapy. So in general, non-steroidal anti-inflammatory drugs or NSAIDs, such as ibuprofen, are considered first-line treatments for musculoskeletal pain. And this is often combined with non-pharmacologic approaches that include acupuncture, physical or exercise therapy, also massage, among some others listed here. And then it depends on also the type of chronic pain that's being experienced. So for chronic neuropathic pain, initial treatment typically includes the drugs that are listed here. So selected antidepressants like serotonin, norepi, reuptake inhibitors, or anti-epileptic drugs like gabapentin or pregabalin. And then if the pain is localized, these drugs will typically be given in a combination with topical therapies. Of note, there's some evidence that cannabis can improve pain and function in adults with neuropathic pain. And finally, only if these interventions prove to be sort of unsuccessful would opioids be considered now for chronic pain because of the concerns for a variety of adverse events, including abuse and addiction. When opioids are prescribed, it's usually at the lowest effective dose and also for the shortest amount of time. And usually this is in combination with other non-opioid and non-pharmacologic therapies. So 4 reports prepared by DERP on this topic. The last DERP systematic review for long-acting opioids was completed and presented in September of 2015. So this is over 8 years ago. And the evidence sources for that report were searched through February of 2015. DERP conducted 3 surveillance reports since that last report, back when they were called scans, with the most recent surveillance presented in 2017, and the surveillance was through mid-November of 2017. The next 3 slides list the PICOs for the DERP products for this drug class. So we start with the population, which included adults with chronic non-cancer pain, which was defined as continuous or recurring pain for at least 6 months. The comparators included another listed intervention, so any head-to-head trials, and also short-acting opioids. For outcomes, they included pain intensity and pain relief, functions such as cognitive function or physical or occupational, fatigue or returning to work, and also adverse events. For study designs, they included randomized controlled trials and comparative effectiveness systematic reviews. So this table lists the interventions included in the last report, and they're in alphabetical order by generic name. So we have buprenorphine, fentanyl, hydrocodone, bitartrate, hydromorphone, levorphanol, methadone, morphine sulfate plus naltrexone, oxycodone, oxycodone hydrochloride plus naloxone, oxymorphone, and tapentadol. That second column there provides the brand names with some different brand names for different formulations of the same drug. And you can see the formulations listed in the third column. Then next we have the mechanisms in column 4. All are opioid agonists except for buprenorphine, which is so at the top, which is a partial opioid agonist. And then 2 agents are opioid agonists combined with opioid antagonists. In that far right column, we have the FDA approval dates, with the earliest drug approved in the 1940s. This was methadone. And then the most recently approved novel agent listed here is tapentadol, which was approved in 2011. There were 6 key questions in the most recent DERP report. Key questions 1 through 4 asked about the comparative effectiveness and harms between the long-acting opioids and between them individually as a group, and between the long-acting and short-acting opioids in adults with chronic non-cancer pain. And then key question 5 and 6 asked about differences in effectiveness and harms of these agents across different subpopulations. So the most recent report in 2015 was as a 7th update of the original report. And cumulatively, that report included 25 studies. 18 were head-to-head trials of long-acting opioids, and 7 were trials comparing long-acting with short-acting opioids. For key findings in that report, we start with effectiveness findings. So in summary, tapentadol resulted in greater reduction in pain intensity in patients with knee osteoarthritis compared with oxycodone in 2 studies. And there was some greater improvement with back pain with tapentadol in 1 study. There was no difference in pain relief with hydromorphone versus oxycodone. And in general, there was no difference in effects between long-acting and short-acting opioids. However, they did conclude that the evidence was actually sort of insufficient to determine whether there were differences between the long and short-acting opioids, at least for the outcomes of interest for this report. So here we have the key findings for the harms outcomes in the last report in 2015. So the extended release formulations of tapentadol resulted in fewer withdrawals due to adverse events and fewer specific adverse events compared with oxycodone. They found that long-acting morphine resulted in fewer adverse events, withdrawals, compared with transdermal fentanyl for the most part. There was a large cohort study that found a lower mortality rate with methadone compared with long-acting morphine. And then there were no differences in safety or adverse event outcomes in studies that compared these drugs listed here. So we have hydromorphone osmotic release oral system versus oxycodone sustained release formulation, then also oxymorphone versus long-acting oxycodone, and then morphine extended release formulation versus long-acting oxycodone, as well as the morphine extended release formulation compared with the sustained release formulation. Also hydromorphone extended release versus oxycodone. And then finally, the fixed dose agent morphine plus naltrexone compared with the extended release morphine agent. They also reported insufficient evidence to fully assess differences in safety outcomes between the long-acting opioids themselves and between the long and short-acting opioids. Surveillance after the most recent DERP report was through November of 2017, where they found one new drug. However, this is a different formulation of buprenorphine that was already included in the prior report. So whether that was actually new may be disputed, but this is how it was presented in this surveillance. And then they do report that there were 5 new formulations identified, marketed as 5 new brands, and those are listed here. At the bottom of the slide, we see that they found 6 new studies during the surveillance period, 4 of which were systematic reviews, and 2 were new head-to-head trials. So during the surveillance period, they also found 5 new boxed or serious warnings. They were all issued in December of 2016. The first warning listed on the slide is for all of the included long-acting opioids except for levorphanol and methadone. It stated that if these drugs are used concomitantly with benzodiazepines or other central nervous system depressants, serious side effects, including profound sedation, respiratory depression or coma, and even death could result. And then additionally for buprenorphine, the warning for neonatal opioid withdrawal syndrome was added. For the fentanyl patch, there was increased, they warned about increased fentanyl absorption with the application of external heat. And then for hydrocodone bitartrate, there was a warning for serious interactions with alcohol that was added. And then for oxymorphone, the warning was for risks around addiction, abuse and misuse, life-threatening respiratory depression, accidental ingestion, neonatal opioid withdrawal syndrome, as well as interactions with alcohol. So now we'll switch to the new FDA actions since the most recent report, again, including anything that might have been in the surveillance, but up through the search for this archiving report. So for new drugs, we did not find any additional new drugs or formulations other than those identified during the surveillance, which included that 1 new drug and then 5 new formulations, and those are listed on the previous slide, on slide 13. There were no new indications for these drugs and for new boxed or serious warnings. So in addition to those serious and boxed warnings found during the surveillance, and again, those are listed on the previous slide, we did find 1 new additional box warning for all of the included drugs since the last surveillance. And this was added to drug inserts in September of 2018. And this warning requires a risk evaluation and mitigation strategy, a REMS program, to try to help ensure that benefits of prescribing these opioids outweigh risks of addiction, abuse, and misuse. So on this slide and the next, we have the FDA approved indications for the long-acting opioids of interest, including any new drugs that were identified. So in the top 2 rows, we have buprenorphine as both the extended release transdermal film and the newer formulation of Belbuca, which is the buccal film. So both of these agents are approved only for moderate to severe chronic pain for when alternative treatments are inadequate. Hydrocodone, bitartrate, and levorphanol in those 5th and 7th rows there also have this indication as their sole indication. In the bottom row, you can see that methadone as the Dolphine brand only. They also have this indication, and then both Dolafine and Methadose brands have 2 additional indications, namely detoxification treatment for opioid addiction and maintenance treatment for opioid addiction, in addition to other social and medical services. And finally, we have fentanyl and hydromorphone in the 4th and 6th rows. which are indicated for severe pain in opioid-tolerant patients when alternative treatments are inadequate. So all drugs on this slide are approved for moderate to severe chronic pain when alternative treatments are inadequate. You can see that as you scan down that second column with the check marks next to all of those agents. And these include morphine sulfate, the fixed dose product of morphine sulfate plus naltrexone, also oxycodone, and this is for adults only. And then also fixed dose oxycodone plus naloxone, oxymorphone, and tapentadol. So oxycodone is also approved for severe pain in opioid tolerant patients when alternative treatments are inadequate in patients 11 and older. And then tapentadol is also approved for serious neuropathic pain associated with diabetic peripheral neuropathy in adults, again, should alternative treatments be inadequate. So we found one new pipeline drug that is said to likely compete with other long-acting opioids if approved. This drug is dinalbufene sebacate. This was approved in Taiwan in 2017 and appears to show similar efficacy to morphine. However, respiratory depression is a concern. This is a kappa agonist partial mu antagonist analgesic. It's currently in phase 3 trials for post-surgery indications. And the FDA approval timeline was uncertain at the time of our research. So next we move on to the generic status of these drugs on this in the next slide. So for the most part, we found that all of these drugs, with the exception of the new formulation of buprenorphine hydrochloride, are available as generics. Some formulations of hydrocodone, bitartrate, and the drug hydromorphone became newly available as generic since the last report, and the estimated loss of exclusivity by the manufacturer of the buccal film of buprenorphine hydrochloride is the end of January 2027. So continuing on with generic availability, so we have at the top, morphine sulfate was available as a generic option with a prior report. And in the next row, we have row 3. Also in row 5, we see that the fixed combination drugs, morphine sulfate plus naltrexone and oxycodone plus naltrexone, they have been discontinued for the most part. And then in row 4, we go back up, we see that there's been at least one formulation of oxycodone that is available as generics, as a generic option. And then in the bottom row, we see tapentadol is not yet available as a generic, but may be soon with the estimated date of loss of exclusivity by the manufacturer in June of 2025. So on this and the next 3 slides, we provided a very general summary of the clinical practice guideline, recommendations for chronic non-cancer pain in adults, including how and when these agents are used along the treatment pathways. So for this section, we began with the information from up-to-date clinical decision support online resource, and then cross-referenced that information with key practice guidelines from professional medical associations, which are listed at the end of the slide deck. So overall, the guidelines recommend a very individualized approach to chronic pain, with the first step being to determine the type or cause of the pain. So nociceptive pain is associated with tissue injury or damage, including arthritis and joint pain. Neuropathic pain is when the pain comes from damaged or diseased nerve tissue. Diabetic neuropathy is an example. And then nociplastic pain is when pain receptors are activated despite any evidence of actual damage to the tissue or nerves. An example of this is fibromyalgia. So next, the guidelines recognize that problems with getting enough sleep is often a side effect of chronic pain, so it's important to address that first. And then non-pharmacologic interventions are recommended first for chronic pain, and those include exercise therapy and physical therapy. Tai Chi and yoga are examples. Also, psychoeducational interventions include CBT, patient education, mind-body therapies like mindfulness and stress reduction techniques, and then there are other physical interventions recommended like acupuncture and massage. And then the bottom bullet point there mentions that pharmacologic interventions are only recommended after these approaches, these listed here, have been tried and were deemed unsuccessful. So on this slide, we have the guideline recommendations for pharmacologic agents when non-drug interventions have been unsuccessful. So with chronic pain from musculoskeletal or tissue damage, so this is the nociceptive pain, they first recommend adding NSAIDs like ibuprofen or aspirin. Second-line agents include antidepressants or anti-seizure medications, including tricyclic antidepressants, and serotonin norepinephrine reuptake inhibitors, or SNRIs, which have these analgesic qualities. Gabapentin and pregabalin were examples of anti-seizure medications mentioned as effective for diabetic neuropathy, as an example. And then opioids were only considered as third-line treatments if they were unsuccessful at with any of the above treatments. And then if indicated, they should be prescribed at the lowest effective dose and for the shortest duration, and then also combined with other non-opioid and non-pharmacologic treatments. The long-acting opioids most often mentioned included tapentadol and buprenorphine, but they caution that these should be reserved only for those patients who are anticipated to and informed that they will most likely remain continuously on opioids for the long term. And I do want to mention that the guidelines do include tramadol as a third-line opioid treatment. This agent was not included in this report because it's considered of a more of a pro-drug versus an actual opioid, but in that its metabolite is where is most responsible for that opioid analgesic effect. However, most guidelines do list tramadol in the category of long-acting opioid. For neuropathic and nociplastic pain or centralized pain, antidepressants and anti-seizure medications are recommended first, and then a combination of these drugs, which they mentioned may be particularly helpful in conditions like fibromyalgia. So opioids are considered basically as a last option, and there are no other opioid drugs specifically called out for this type of chronic pain. However, tramadol, tapentadol, and buprenorphine were mentioned more frequently. So here are some key recommendations in the guidelines specifically about long-term use of opioids for chronic pain. So overall, long-term use is not recommended. If indicated, again, they recommend to use the lowest dose for the shortest period of time. Some guidelines also recommend immediate release opioids over extended release or long-acting opioids. And they caution that long-term use of opioids should be reserved for individuals with very low risk for substance abuse, and those who demonstrate persistent pain despite a variety of other treatments that were tried first, and who are also expected to remain on these drugs for a long period of time. And the VA guidelines really emphasize and pointed out to be cautious around the risks for abuse in younger population groups. And here's some general recommendations for the dosing of the opioids in the guidelines. And then also the VA recommends buprenorphine over full opioid agonist because buprenorphine is a partial agonist. And then methadone was recommended as a last option. And if it is provided, should be delivered by trained staff only. And there was some mention that there was some but limited evidence for ketamine and lidocaine infusions, but that these agents are likely options only for specific situations in certain patients. So yes, they're at their final slide. These are the relevant key clinical practice guidelines that were also referenced for the guidelines section above, and they're listed in alphabetical order by author, professional organization, and then the dates of publication for these guidelines or guideline updates range from 2017 to 2022. So thank you so much. And questions about the report for me or any clinical questions we can pass to Ryan.
Thank you, Andrea. You've been quite a trooper this morning.
Sorry for, oh,
yeah.
sorry.
Go ahead, please.
Sorry for in advance for being super annoying about this before lunch, but I do a lot of addiction medicine. I prescribed a lot of buprenorphine. And I'm not understanding a couple things. One is like, why are the categories long acting versus short acting opioids instead of full opioids versus partial opioids? Just because buprenorphine has so much less in common with any of these other medicines than something like short acting oxycodone does. And sublingual tablets of and films of buprenorphine are just as long acting as oxycontin. So I feel like there's a lot of stuff that's not correct clinically about the categorization, and that's sort of where we have to start, I think, when thinking through this.
So this is Ryan, and again, the way that these drug classes and reports are crafted is by the states, and when they were doing their selection, they want to emphasize that yes, there are these different clinical considerations between these different opioid options. And so I think as part of the P&T committee, your job is to interpret, how these different types of medications can be used in the context of pain. So not necessarily with the addiction medicine side, but
Right.
in the context of pain.
But even with pain, like the long acting versus short acting, like we know now that OxyContin isn't actually long acting, right? That was a whole part of the whole, lawsuits and everything. So is there any role that we can have in this categorization, or is that like forever
This is
done?
done. The state, we decide on the categories. You can make recommendations and we'll take it into consideration. The long-acting opioids, the name came about when, back when OxyContin was first, introduced to market. And then there was a difference between long and short acting. And there was a lot of questions about that the states had at the time. So, these are the drug classes that we provided, or that we created. We also use them in our opioid policy, whereas you can, when you're treating pain, you can't just go to one of these long-acting opioids for acute pain. You have to start with what we call our immediate release or short-acting medications. And we can debate where oxycodone or OxyContin actually, lands as far as is it long acting or not, define what long acting means. So I don't see us changing the drug categories. They've been this way for 20 years.
I think along those lines, though,
Okay.
Zoe makes a great point about we can at least address that in the form of the policies that we put forth, right, in the motions, where we are able to call out the vast difference between buprenorphine and the other agents. But really good point, Zoe. Well taken.
And the buprenorphine like tablets and films, are those in a different category?
Is it possible to bring up the motion? This is Laura.
The buprenorphine products that are not approved for pain, so you'll see generic buprenorphine, naloxone, the Suboxones, the Subutex, all of those are not considered part of this drug class.
Okay, thank you.
It's the patches. So and they're addressed in a drug class, like on the Apple Health PDL, they're actually in a substance use disorder treatment category, as a partial agonist. They're not considered long or short acting. They're different. But the transdermal film, because the mechanism of delivery is a patch, which is, I think, at least a day's long. I don't know the actual length the patch is good for. It's included in the long-acting opioid category because we want to be able to compare buprenorphine, transdermal, the effectiveness and safety of it compared to some of the other products that were reviewed.
So just to confirm, Kavitha here, the buprenorphine, we cannot, when we say just buprenorphine here, the top one, does that include both the sublingual and the buccal formulation?
No, it is just
It's
the
just
transdermal
buccal.
film, like it mentions here.
I think
And
the
then,
buprenorphine is just the buccal, and then the buprenorphine transdermal film is the Butrans patch. So Belbuca and Butrans separately, I think.
Yeah, so this is Ryan. So the reason that it's bold is that in the report that you just received, they did mention that there was one new drug, the Belbuca, that was first approved in 2015, which just shows you, how old the last report was on this class. So that bolded drug that you see there is a drug that was approved almost 10 years ago, but we haven't been able to add to date.
So at this time, can you share with us which formulations of buprenorphine are preferred?
On the Washington
what,
Code PDO or the UMP PDO?
I think the Washington PDL, and then if it's available on UMP as well.
So for
As
the
well as the tier, yeah.
Yeah, so the UMP PDL is the buccal film, the patch, the sublingual tablets, so that's the Subutex, and the Suboxone generic film and the Suboxone generic sublingual tabs. Those are all tier 1 except for the buccal film, which is a tier 2 drug.
Okay. And for the Washington PDL?
So it'll be the same. So
It's the same,
patch
okay.
retrans should be the preferred, and then
well,
because Belbuca hasn't been reviewed, it can't be preferred.
so Ryan, can we update this to be buprenorphine buccal, that it is not referring to monotherapy buprenorphine, which I believe
Yes.
is the generic for Subutex. It's very important to when what Ryan just mentioned for UMP, the long-acting opioid class does not include buprenorphine products only approved for substance use disorder treatment.
Mm-hmm.
They're buprenorphine, but they are not part of this class.
Mm-hmm. Mm-hmm.
That's fair.
So when you are making your decision, ignore them right now. They're not being impacted by this decision that you're making today.
Mm-hmm.
Makes sense.
So coverage of those drugs, for Medicaid, we have them, like I said, in a completely different class.
Mm-hmm.
For Ryan, they're in the lowest tier. But again, they're not used for pain, so they're not impacted by this motion.
So, Sonia, on the bold buprenorphine at the top of that list, can you just add buccal film, Buccal? And I can spell it. Great, thank you.
Brian, this is John McKay. I was just wondering if you can give us kind of a high level of what is preferred for all the opiates, not to kind of get off the buprenorphine, but just what is preferred.
Marissa, do you have the PDL?
I can go over the Washington PDL and Marissa can go over the Apple Health PDL. For the Washington,
This is Marissa. I don't have the AHPDL open, but I can open it while you discuss. Might take a little bit.
okay, so for the Washington PDL, it's the fentanyl patches, the hydromorphone ER tablets, the morphine sulfate capsules and controlled release tablets, the morphine sulfate beads capsules, the oxycodone 12-hour tablets, the oxymorphone ER tablets, and that's it for the Washington PDL.
As I'm reviewing this motion, I think right off the bat, it seems like, the statement says that I move that buprenorphine and then all of the other medications are efficacious and have similar adverse effects. And so I think right off the bat, we need to call out buprenorphine as separate, not
Absolutely.
comparable in their adverse effects.
Yeah.
What is your, so this is Donna, what it was I guess, the reasoning behind that?
So buprenorphine is a medicine that you can't overdose and die from. And so it's a very, very different medicine than the other ones. Like, I think in a non-palliative situation, I would struggle to even say that a lot of these are safe. Whereas buprenorphine absolutely is safe. And so I think it's just, I get that we're working in the restrictions that we have, but I agree that we have to reword this in some way or else we can't approve it.
I think this is a really tough one, and I've talked with Zoe about this before. About there's this theoretically buprenorphine should be safer. It makes sense that it would be, but we don't have hard data and guidelines to back that up. It makes sense. The other P&T committee that I'm on, we set criteria for it for that reason. But if you look at the evidence, like, you know, we're basing all of this on the pharmacokinetics and everything, and not on clinical outcomes data. And so it's a really tough one to like. I think this is a little bit different than smart therapy, where we have the studies and it's been worked into the guidelines. And I'm still kind of thinking through this and how I would treat this in the motion. I'm not sure I don't know that I've totally like settled on how I think it should be addressed, but it definitely is a trend in pain medicine and management to use more buprenorphine, and a lot of that is based on the pharmacokinetics and everything, and kind of believing that it's going to be safer, but without the clinical outcomes to prove it.
This is John McKay again, and this might be a question for Ryan or Donna, but do we have any kind of clinical evidence or data to support the relative safety, like within the opiate agonist group? I mean, a couple of those jump out to me as being less safe than others, maybe like methadone or fentanyl patches, and just in terms of maybe if policy can address those safety concerns, or if we need to address those.
And this is Donna. I mean, I think the key to this this motion is that they're efficacious when used appropriately, and it's up to the providers to use them appropriately. You know, methadone is a great drug at some point in time for treating, chronic pain. It's also used, for MOUD, but when it's used appropriately and at the correct dose, can people, get too much methadone on board and have adverse events? Absolutely. But there are studies that have shown, that, there was a long argument. We had methadone as preferred for a very, very, very long time. And at that time, there were a lot of methadone related deaths due to illicit use of methadone, not necessarily methadone being prescribed appropriately. So there is a study. I think it was Dr. Chow at OHSU, specific to methadone, and it was a VA study. I'd have to go back and pull the references, but it basically showed no difference in like overdoses and deaths when using methadone or other opioids. And I think that's a lot of the basis of this particular motion. And it's a key, all opioids are dangerous when you take too much. It doesn't matter if it's an abuse deterrent, formulation. It doesn't matter if it's immediate release, long acting. If you take too much, you can overdose and die. So that is why if you say, notice somebody needs to be on mute. I'm getting a lot of feedback there. I'm sorry. We don't come out and say they're safe. The committee at the time was not wanting to say these are safe and efficacious like they often do in other motions. They're saying they're efficacious when used appropriately. And they do have similar adverse effects. If you take too, they cause constipation. If you take too much, you can have depressed, respirations, drowsy, sleepy. Those adverse events are side effects also, and they're similar. And that's what the committee reflected in this motion.
And John, just to kind of address your question, so there are policy considerations. So we do have clinical policies that are not part of the Washington P&T process. So we do have the extra policies in place that go beyond this. So this is not just having, kind of open access. This is just helping us understand which of these drugs, is eligible to be preferred. And then from there, we do have our clinical policies for both labor and industries and Uniform Medical Plan and Apple Health that do restrict it to, appropriate use.
Yeah, I would definitely concur with you, Donna, that there are like class effects and they all can result in overdose and death. But I do think there are additional like kinetic considerations and that prescribers should be probably receive some specialty training in dosing methadone and sometimes fentanyl patches, or at least be
I agree.
have extra additional training in their use when using them appropriately.
Right. No, I mean, this is Donna. I agree with you. We do have, fentanyl patches are on prior authorization as well as methadone. So you can't just prescribe it. There's I think for methadone, you have to have tried every generic opioid in order to be considered for methadone, for pain. And let me qualify that. And with fentanyl, it's very strict to the indication, and I think it's only indicated in the treatment of cancer-related pain. And so, that policy is pretty strict. So, like as Ryan was saying, we have the opioids are probably, I'm going to say the most, I'm going to say policied drugs we have. We have, dose limits for acute. Like kids can only get 18 doses, per prescription for an acute, an acute prescription. We have then edits that say you can get your acute prescriptions filled, up to, a 42-day supply in a 90-day period. At that point in time, you're triggering that stepping into chronic opioid use. So we have an edit there where then the prescriber has to fill out an attestation saying that this patient requires chronic use and that they're following best practices, and it's all outlined in the attestation. And then we have a dose limit also. So you can't go beyond 120 milligrams of morphine equivalents. And once you get to 120, to go above it, again, there's another attestation where the prescriber, has to pretty much, say that it's a justifiable requirement. If you have somebody that's on, has chronic pain and they're on 120 milligrams of morphine and they break a leg or they have surgery, they might need a higher dose than 120 milligrams for a short amount of time. And so we do require them to fill out that second application attestation. And then we have a hard stop at 200 milligrams. And then we require like a full clinical review and a justification of why they need more than 200 milligrams. So there's a lot of policy around these drugs to make sure that they're being used appropriately.
I would say as far as the motion goes, I think the background information about all the policies in place for protection it's fantastic to know about. I think my main concern about the wording is that we're saying they have similar adverse effects, in that I hear what you're saying, that they are all working on opiate receptors, but if you look at the data that is available, the rate of accidental overuse or in general overuse deaths related to buprenorphine are like, whichever studies you find, they're all like
Extremely low.
2%, 2.5% of the overall opioid use deaths. And so I feel like the adverse effects are not in that regard similar across all long-acting opiates. And hence the comment about separating the buprenorphine agents into their own sentence.
Like, could we put like part, like similar to how we have broken out the left side in other ones, can we break it out into partial opioid agonists and full opioid agonists? I think
We're
then
not,
we
I feel
could
like
say,
this is Donna. Yeah, we're not, it won't be considered a separate class. I'm not sure if that's where you're trying to go. If you want to be able to say something different about buprenorphine, you can say whatever you would like in the motion. But for our cost analysis, they will be all lumped together in as a single class.
I think the spirit here, if I'm hearing correctly, is that so we want to reword this a little bit to say one, buprenorphine, the adverse effect profile of buprenorphine either is separate, and maybe we don't even need to call that out, but have something in there that says that a formulation of buprenorphine is preferred on the PDL is where I'm leaning towards.
I agree with that. Yeah.
How about the rest of the?
And I think I would feel fine with saying buprenorphine is safe and efficacious, even if we can't say that about the rest of them. I wouldn't die on that hill, but I think, it is really, really different than the other ones. And that's what I think everyone needs to understand.
Okay, so how do we want to word it?
Sorry, I was just reading the post that Peter put in the chat. I guess first comments from the rest of the committee. Do you agree with separating out buprenorphine? And we're running low on glucose now.
This is Laura. I don't see any problem with separating it out. I kind of see Donna's point though with this is that we're saying they're efficacious. We're not saying they're equally safe. The similar adverse effects is slightly different. But we're not interchanging them either. So we're not really blocking anything by adding that information. I think it's good to add it because the adverse effect profile is slightly different, but I don't know that we need to have two separate classes or anything.
We just add a sentence after the adverse effects to something because the type of adverse effects are the same. We're saying the risk of is potentially less. So maybe just saying something like the statement is pasted in the chat, like it potentially has lower risk due to its partial agonist.
Because I don't know the morphine and naltrexone and oxycodone naloxone combinations. I don't know how they fall into those categories either.
It's a fair point. Yeah.
Those are all like abuse deterrents mostly. I think those are most.
Buprenorphine is like, I get that we're lacking some data for chronic pain or for these exact formulations, but like it's truly a miracle drug. Like you really, really can't overdose on it unless you're using it incorrectly or like using benzos and stuff with it. Like I'm not a scientist, but I do this every single day. So I do appreciate that we need more data, but it just seems like there's so much conflict about like which things it's like all about what the FDA says and which things it's like only about what the guidelines say and which things it's only about what papers we can find. But whatever. Anyway, I think I would love to have a sentence that says that buprenorphine, like a buprenorphine formulation needs to be preferred. And it would be great to call out in some way that buprenorphine is safer than the other ones, but I wouldn't die on that hill as much as I think the more important thing is actually just to make it preferred.
So if we leave the whole, well, number one, I think, yes, I do have hesitation in leaving buprenorphine in the list and saying similar adverse effects. As Zoe said, I'm okay if we just want to leave that part alone. But in that final sentence, I do think we need to say there should be at least one buprenorphine-based agent that is preferred on the PDL. How's the committee feel about that?
So this is Peter. I mean so one other, not to add more nuance and complexity to this, but is the morphine equivalency dosing. Typically, like you wouldn't go straight to buprenorphine because because of the way that the dosage formulations are, like you would actually be jumping to a pretty high dose. And so ultimately, I think the HCA should consider having buprenorphine on the preferred or a buprenorphine product, but I'm comfortable leaving that to them because I don't think people should typically go straight to buprenorphine. I would be fine with them going through another opioid.
I disagree. I
Is
think
that
it's much safer to go to buprenorphine first because then they have no risk of all of the risks of a initial opioid. I do it all the time. And I get that
That's a
there's like
very
a
high morphine
off-label thing.
equivalency.
Yeah, but
Um,
it can cause
even
respiratory depression.
even if you cut the Belbuca films into quarters, that's still higher than I would in terms of the MED. It's still higher than I would typically
I
dose
know,
patients.
I know that that's what the science would suggest, but I use 1 milligram of the sublingual tablets twice a day all the time for chronic pain in people who are not opioid naive because they've been on and off of it, on and off of it, sometimes getting it on the street, sometimes getting it from a doctor. Like this is the real situation in the world. So I don't know. We don't have to talk about all this now. Sorry, I know it's
Yeah.
lunchtime, but it is a miracle drug. It is okay to start with it. It is going to save lives if people start with it more. And so I think whatever we can do, like we have a very small role in this committee in this, right? All the policy stuff is more important. But if we can say that buprenorphine has to be preferred, I think that would actually save lives. And so that's why I think like it would be great if we can do that. I think it would also be great if we could write a whole tome about how people should use it, but I guess that's not our role.
But for what we're reviewing for this motion, that's not data that we've seen. Just a thought, could we, as Kavita mentioned, add buprenorphine as a preferred agent in addition to another long-acting opioid? And then just remove the comment. Can we just leave it as are efficacious when used appropriately and just remove
and
that
stop it
have
there?
similar adverse effects?
Yeah, that sounds good.
I think that's reasonable. So yeah, at the end of perfect. Just when used appropriately and
It's my
period
mouse.
then.
My mouse has a mind of its own right now.
Mouse is running away to lunch.
Yes.
Okay. And then just, yeah, period there. And there should be at least one buprenorphine agent. That is preferred on the PDL, but I think, Laura, you were wordsmithing it more succinctly.
No, I think what you have is fine. There should be at least one more. And do we say and then and more than one oral preferred? Oh, I think I had said in addition to more than one oral
Okay, that
preferred
is
med
preferred. Oh, I see. So
in a different opioid class, maybe. And yeah. At least one.
so after preferred,
This is Donna. Can I make a suggestion? I would say
Yes.
there should be at least one buprenorphine agent and more than one oral preferred long-acting opioid in this class.
Oh, sorry. Say that again, Anna. Donna, sorry. And one.
And more than one.
I think if you just cut out the preferred in Washington PDL and put that in the end, you have it.
Yeah.
Right?
Right.
Right
So,
here.
yep. So
Leave
cut
those.
out preferred in Washington PDL. So cut. And then paste that at the end of the sentence. And then we'll clean up the rest of the sentence.
Like this?
Yep. And then cut out that is more, right? More than one. Yeah. Then cut out that is more than one right there.
perfect.
That's better.
Good, that looks satisfactory. Committee edits? And Zoe, what do you think?
Yeah, I think that's fine.
Okay, so we're ready for the motion whenever we're ready.
This is Kevin Flynn. After considering the updated evidence of harms, efficacy, and special populations for the treatment of non-cancer pain, I move that buprenorphine buccal film, buprenorphine transdermal film, fentanyl transdermal film, hydrocodone, bitrate, hydromorphone, levorphanol, methadone, morphine sulfate, naltrexone, oxycodone naloxone, oxymorphone, and Tepidol are efficacious when used appropriately. There should be at least one buprenorphine agent and more than one oral preferred drug in the long-acting opioid class preferred in the Washington PDL.
I can second it.
Thank you both. All in favor, please say aye.
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 Any opposed or abstain? That the motion carries. Well done, committee.
all.
Good showing power.
One more before we go.
Oh, sorry. One more for the archiving.
Yes.
Thank you, Nanya. Celebrated too soon.
And let me increase the font on this. Oh, can you guys see it? I'm sorry.
No, we're still seeing the long
Ah,
activity.
oh my goodness. I forgot I shared only. Let me do that again. I was like, oh, okay. Everyone is quiet. Sorry about that.
Please.
Here we go.
All right. Okay. Any commentary, edits, or enhancements by the committee?
And if we can have all committee members, thank you.
And hearing none, if we can have a proposal for the motion.
Hi, this is Greg. I'll do the motion. After considering the archive reports presented today, I move to archive the following drug classes from further regular review by the P&T committee: antiemetics, asthma COPD controllers, asthma quick relief, long-acting opiates or opioids, overactive bladder. As of today, the drug classes will remain on the PDL, and the committee's last motion will remain in effect until changed by the committee. The agencies may conduct updated cost analysis of these drugs without additional committee approval, so long as any resulting changes in the preferred status of the drug remains consistent with the committee's last motion for the drug class. The committee may review the archive status of a drug class upon its own initiative or by request of the participating agencies at any time.
This
Christy
is
Weiler.
Laura Bestie. I'll second the motion.
All in favor, please say aye.
Aye.
Aye. Any opposed or abstain? All right, with that, the motion carries.
Okay.
And I believe with that, the P&T committee adjourns. Is that right, Nadia?
Let me take a look at the agenda, but that sounds right. Yes.
And a
Yes.
very well-deserved lunch break for 30 minutes.
Okay.
All right, see you at 2:30.
Thank you.
Hello, committee. Welcome back from lunch. We're trickling in. Right, great. So I think we have quorum. We have 6 of us. And so with this, we convene the Drug Utilization Board. And I think Ryan Takatomo and Marissa are going to start us off for the second half.
This is Marissa. Yes. So let me just make sure I have everything teed up. Okay. So for this meeting and kind of meetings moving forward, upcoming DUR board meetings, we are trying to do some utilization activities or present to you all some DUR utilization. So letting you see kind of what utilization is looking like for our Apple Health PDL and the products that are on it. So this is really our first introduction today that we've done in, I think, a long time or ever, as far as utilization that we're going to be presenting you. Ryan T will pretty much, I'm going to hand it off to him. He's going to do a really great job presenting it to you all, but it's going to be a very high level type of presentation. And then moving forward, our plan is to get a little bit more specific in future DUR board meetings as far as maybe certain classes, certain products, things like that. So without further ado, I will go ahead and hand this off to Ryan. Let me go ahead and just share the slides. As I will be driving for him. And let me get it all teed up. Hopefully it's gonna present well. Okay. You should be able to see the slides. Ryan, let me know if they're not working. And you are good to go.
All right, hi, this is Ryan Takatomo. Good afternoon, committee. And as Marissa kind of talked about, we'll be starting off with the drug utilization review activity. This afternoon, we'll be going over the top 25 drug classes and drugs by cost. Next slide. So just a quick overview. We'll start off with just looking at annual utilization from 2021 to 2023. Then we'll be moving down to the top 25 classes, and then at the end, the top 25 drugs. Next slide. So a little background for the annual utilization, some methodology. This data that we're presenting comes from our pharmacy point of sale claims. The date ranges from January 2021 to the end of December 2023. And the data includes fee-for-service and all our managed care organization claims. Next slide. So on this slide, the top graph shows our actual paid amount and net paid amounts, and the bottom graph is adjusted to a per member per month basis. From just a cost overview, we have about up to $2 billion of expenses annually With rebates, it drops it down to about $1 billion a year. Next to each of the year numbers, you see a YOY, that's the year-over-year percent change. And so focusing on the net pay, we've seen that it's been growing by about 9 to 10% every year. And then the bottom graphic is again the per member per month adjustment, and we can see steady growth there as well, with more growth kind of in the more recent year. Next slide, please. Yeah, and before I continue, just want to let the community know if there's any questions, comments, or feedback, please feel free to raise your hand or jump in and interrupt. Okay, so on this slide, we're looking at the number of claims, the number of clients, and the annual number of member months. What member months is that for a particular month, a member will be counted if they are enrolled in Apple Health Medicaid. So in 2021, there were 25 million total member months. And pretty much for all three metrics, we can see that there is growth over time, except in 2023 when there was a slight decrease in the number of claims and the number of member months. Next slide, please. Okay, so that covers the annual utilization. Now we'll go into the top 25 classes. So the way we defined what a class is for this presentation is using the Apple Health Preferred Drug class name. For example, antidepressants, tricyclic agents. The class for this presentation is the piece before the colon, so that would be antidepressants. And then there are 64 classes as of 2023. And then just for definitions, the subclass is what we're calling the piece after the colon, which would be tricyclic agents. And at the end of 2023, there were 494 subclasses. And then note, like some classes such as a cytokine and CAMs don't have a subclass. Okay, and any cost we'll be discussing is based off of the cost inclusive of rebates, also referred to as net paid. Next slide. Right, so this just shows the top 25 classes sorted by the net paid amount. We can see that some of our most expensive classes are close to or even over $100 million in expenses in a single year, while the least expensive of the top 25 is 10 million. So we see quite a big range in cost for these most expensive classes. And then for reference, we also have the per member per month as well. Okay, next slide. All right, on this slide, we'll be focusing on the classes that had the greatest increases in PMPM between 2021 and 2023. The way to read this chart is that each color represents a class and they're stacked in order by their PMPM. So for example, in 2023, moving down from most expensive and getting less expensive, we have cytokine and CAM, then diabetes, then oncology, then asthma, COPD, and then antipsychotics, just as an example. When you see movement, it represents that a class has become more expensive than another class. So if we focus on anti-diabetics, which is the yellow one, we can see it moved from kind of the middle of the pack class to our second most expensive class in 2023. Next slide, please. Okay. And then here on this, we're looking again at the same classes that have had the greatest increases in PMPM, and this is looking at their actual changes. So, for example, just the anti-diabetics between 2021 and 2023, the PMPM has increased by $1.16 per member per month. And I'll just kind of name off like the top 5 biggest increases. They were the cytokine cam antagonists, the anti-diabetics, the asthma and COPD agents, and the atopic dermatitis agents, and then the endocrine and metabolic agents. Next slide. So this kind of changes the data a little bit. It's looking at the same classes, however, this time we're looking at what was the percent change in PMPM. So for example, the anti-diabetics, if it was $1 in 2021, it increased by 76% in 2023. So essentially going from $1 to $1.76 per member per month. And that's kind of how you would read this graph. The top kind of classes that had the greatest percent increase between the 2 timeframes include the atopic dermatitis agents, the anti-diabetics, the neuromuscular agents, the hematological agents, and the asthma and COPD agents. Next slide, please. Okay, and then so now we'll be looking at focusing on the classes with the greatest PMPM decreases between 2021 and 2023. So similar to the previous chart, the colors kind of represent the order where the class with the highest PMPM is on the top, and then it goes down. So there wasn't many changes between these class orders except between the GI or the gastrointestinal agents and the antidepressants where they kind of switched. And kind of the classes that had the greatest PMPM decreases include the antivirals, the GI agents, the antidepressants, the analgesics, and then the dermatologics. Okay, next slide, please. Okay, on this slide, we're looking at kind of the absolute change in PMPM between the 2 years. Again, these are all the classes that had a decrease in their PMPM. Next slide. And then this looks at it from a percent change. And so contraceptives had the greatest percent decrease in the PMPM, then dermatologics, and then antidepressants, and so forth. Okay, next slide. So in summary, just talking about the top 25 classes by cost, 15 of the classes had an increase in PMPM, and 10 classes had a decrease in their PMPM. Next slide. Okay. On this graph, we'll be looking, it's kind of sorted by number of clients. So we're now going to be focusing on utilization. So we can see one thing that kind of stands out is just the number of clients who are using these classes ranges from over 1 million Apple Health clients using antibiotics to a little over 300 clients using respiratory agents. And I think what's interesting is when you look at the net paid per claim, obviously the antibiotics with their sheer number, it's less costly per claim, while when you get toward the bottom, when there's significantly less number of clients using these products, the cost for these therapies are very expensive. Next slide, please. All right, so here we'll just be looking at the percent change in clients between the years, and I only included the classes that had the biggest differences or the greatest percent difference. So looking at the ones with an increase in clients utilizing these classes, we have atopic dermatitis agents at the top, increasing by 73, almost 74% between 2021 and 2023. And then there's only one class that had a decrease in clients utilizing that class, and that was the contraceptives class. Next slide, please. Okay, and then just in summary, so there were of the top 25 classes by cost, 24 of them had an increase in client utilization. Again, the contraceptives class was the only class with a decrease in client utilization. And then the number of clients utilizing a particular class ranges from 328 to as much as 527,000. Next slide, please. All right, now I'll be shifting to the top 25 drugs by cost. So a little background. Drugs were identified using their what we call label name. So examples of what a label name would be include fluoxetine, Prozac, Humira, Humira-Pen, and adalimumab, ADEBM. And again, these top 25 drugs were included based on their cost inclusive of rebates or their net paid amount. Next slide. Okay, so here is the table with the top 25 drugs by cost. Every single one of these drugs came from one of the top 25 classes, and you can see, and in each label name, I to the left list the class they come from, and I've also color coded them. But we can see that there's a lot of representation from the cytokine and CAM class. You can see quite a few number or products from the HIV class, and then the asthma and COPD class. And then kind of the top most expensive drugs that we're paying for today include Stelara, Trikafta, Biktarvy, Dupixent, and Humira-Pen. I think it's interesting when you look at the cytokine and CAMs that when you look at the net paid per client, Humira sits around $6,000 while Stelara at the top is 73, almost $74,000. So a big difference. And this is kind of one of the reasons why we prefer that client step through our preferred product before moving on to a non-preferred agent. Next slide, please. Okay, yeah, on this on this graph, we again kind of show the drugs, and we're focusing on the ones that had the greatest PMPM increases between 2021 and 2023. But there are definitely some products that remain consistent as being the most expensive. Again, those are Stelara, Trikafta, Biktarvy, Dupixent, and Victoza being some of our most expensive products that we're paying for today. Next slide. And this graph, we're just looking at what the absolute change in PMPM between the 2 years were for the same drugs on the previous slide. We can see that Stellar kind of stands out with a 68% PMPM difference within the span of 2 years. And next slide. And then here we're kind of changing up and looking at which products had the greatest percent PMPM increase. So for this one, the biggest growing products, I guess, were the Skyrizi pen, the Sublocade, Victoza, Jardiance, and Dupixent. Next slide. Okay. So on this slide, we're going to be focusing on the top 25 drugs that had a decrease in their PMPM between 2021 and 2023. You can see that there's quite a bit of movement between the drugs. For example, the methylphenidate kind of drops significantly in that difference in PMPM, while some drugs kind of go up and down, but in their rank, but all of these drugs do have a decrease in their PMPM between 2021 and 2023. Okay, next slide. All right. Again, this is just kind of showing the absolute changes in PMPM between the 2 years. And the ones with the greatest decreases include methylphenidate, hydrochloride ER, Mavret, Genvoya, Cosentyx, Sensoretti pen, and Descovy. Next slide. Okay, on this slide, it's just looking at it from a percentage decrease between the 2 years. So it changes the ordering a bit, but gives you a different perspective of what might be going on. But the biggest percent decrease from the same group of drugs include the methylphenidate product, the Genvoya, Maverin, and the Cosentyx Sensoretti pen. Okay, next slide. Okay, so in summary for the top 25 drugs by cost, 18 of them had increases in PMPM between 2021 and 2023, and 7 drugs had a decrease in their PMPM in this time frame. Next slide. Okay, now we're looking at the same top 25 drugs, but this is sorted by the number of clients utilizing these products. And I think similar to the classes, I think it's interesting how the number of clients is so different. We have 63 clients using Uptravi all the way up to 157,000 clients using the albuterol sulfate HFA inhalers. And again, I've color-coded the products to represent the Apple Health classes which they come from. All right, next slide. Okay, so on this slide, we're just focusing on the drugs with the greatest percent change, whether it's an increase or decrease by the number of clients between 2021 and 2023. You can definitely see some products having a lot of growth, such as the Skyrizi pen, the Sublocade, the Rinvoq, yeah, and Dupixent, Biktarvy, all those drugs are having a lot more utilization over the past 2 years. And then at the bottom, we only see two drugs having a big percent change in their client count, and those are the Mavyret and the Genvoya products. We can speculate that patients could be moving from one class or one product to another, but I'll kind of be saving that discussion for a future P&T meeting when we start to look at particular classes and all the drugs within that class. Next slide. Okay, so in summary, for utilization, of the top 25 drugs, 22 of them had an increase in client utilization, and only 3 drugs had a decrease in their use. And the number of clients utilizing a particular drug ranges from 63 to over 157,000. Next slide. Okay, so just some takeaways. HCA uses utilization data to manage the pharmacy benefit. It helps us kind of identify different trends in prescribing patterns. We use the data to develop management strategies for some of these classes with the supplemental rebates. And then we also use the data to kind of guide some of our clinical policy criteria. And just want to leave it that this is kind of the first presentation, at least that I've done, but we plan to continue bringing more of these presentations to these meetings and provide additional detail for them. So for example, we might be looking at all the different cytokine and CAMs and how they might relate to one another. So I'll leave it at that and open it up to the committee for any comments, questions, or feedback. Thank you.
Thank
All
you.
right. Go ahead.
Please go ahead, John.
Ryan, I just want to say that was outstanding. I really appreciate that. I'm getting a high level overview of the utilization. That was great. But I was wondering in terms of the fee for service versus the MCO, can you kind of give us like a ratio of drug spend costs? And I guess why I ask is just like the rebate utilization or the rebates are kind of dramatically different, like for 340B and pass through on the fee for service side. So I'm just kind of wondering like what the drug spend is on fee for service versus the MCOs.
I'm not prepared to answer that question now, unfortunately, but I can take that feedback. And I think as we continue to bring these presentations, we can separate the data and split it out by each of the different MCOs and fee for service. So that's all I'm able to say. Unfortunately, I'm not able to answer that question right now. In addition, I also want to say that when it comes to like the cost of these products, that we at HCA do have to be careful with how we present them, just because we are limited by law that states that we cannot give like the cost of a particular drug out. So that might cause some discussion, but I think in a lot of cases, when you look at, for example, cost per client, if one drug is significantly more than in the other, you can still reach the same conclusion that that drug is a lot more expensive, even though you might not have the exact price of the drug.
Yeah, thank you. I appreciate that. I think I just noticed that sometimes the 340B price, when it's passed through to the fee for service, can be a dramatically different price than like an MCO reimbursement. So you can end up with two dramatically different costs based on who's paying.
And that is true, John, with 340B.
For the sake of everyone on the committee, including myself, can we clarify 340B pricing if we can just define that? Or is it more complicated than a one sentence definition?
It's not a one sentence definition,
Fair
but
enough.
there are certain entities, this is Donna, by the way, there are certain entities that are federally recognized as like being treating a disproportionate share of uninsured individuals. And so they have been granted this special, what we call, it's called 340B because that's the paragraph within the federal regulation that contains this rule, but it actually requires these entities to purchase drugs. When they purchase drugs, that they get a special discount from the manufacturer, which is better than the Medicaid best price. And so they, because those 340B entities are getting this big discount from manufacturers, the Medicaid program is unable to collect rebate on drugs that were purchased at a 340B rate. So an entity could purchase, Mavorite at the 340B price, but then it could also purchase Mavorite at the, traditional cost that you would buy from your wholesaler. If they use their 340B stock, Medicaid can't get rebate on it. And if it's Mavorite and it's a 340B entity submitting a claim to fee-for-service Medicaid, then the 340B entity has to submit to us their actual acquisition cost, so that 340B price, and that's what they get paid. That rule does not apply when they're billing to one of the Medicaid managed care plans. They can, get reimbursed their, commercial rate or whatever contracted rate they have with that pharmacy benefit manager who's running the claims for that Medicaid managed care plan. In either instance, Medicaid cannot collect rebate on that claim.
Thank you for that explanation, Donna.
We should clarify that it only applies to outpatient drug costs. It has nothing to do with inpatient. For the that your highest cost ones, there's a lot of biosimilars that are coming out in there, but especially in the cytokine and CAM class. I'm thinking particularly Humira. Do you anticipate that will help drive down cost? Or, I mean, just looking at it, it looks like you get fairly significant rebates off that drug. So would that change what is preferred? Are we in the end going to stick with the brand for the most part?
So this is Donna. The biosimilars are challenging for Medicaid because the way that they're approved, they're classified as a brand, a single source product, and so they are no different from the Medicaid rebates themselves are they vary depending on if it's a brand name drug, if it's a generic drug, if it's a drug solely indicated for the treatment of children, and whether or not it's a hemophilia factor. I know the traditional brand name drugs is 23.1%, and that would include, your biologics. A generic is only 13.1%, and that's of the average manufacturer's price. So when a biosimilar comes out, the regulatory pathway, CMS considers it to be a brand, so it gets that 23.1% rebate. However, if the biosimilar is priced at a point where similar to the originator biologic, So like Humira has been on the market for a very long time, and they've had significant price increases over the years. There's a rule that requires the manufacturer, if their price increases exceed the consumer price index, the increase in consumer price index year over year, they have to add that to the rebate. So the price on a brand name drug, the net price after rebate becomes very small if it's been on the market for a long time and the price has increased significantly over that time, because of that rebate keeps just growing and growing and growing. So then when you get the biosimilar coming out, it's a brand, its upfront price is the same as Humira, but it hasn't had those price increases because it's new. So we only get the 23% rebate, where with Humira, we might be getting, 65 or 70% off the drug, net of rebate. So it's complicated. They're cheaper up front. They're cheaper for providers to purchase, but it's not necessarily the cheapest drug for Medicaid, because of the way rebates work.
Thank you. And that's also why like a lot of them do their own authorized generics, right? To help
Yeah,
force
the
that
same
cost.
thing happens. Yeah, the same thing happens with generics, especially if there's not just an authorized generic, but if there's only a single manufacturer that comes to market and they get that market exclusivity for, it might be 6 months, it could be longer, depending on if there was a lawsuit and what that resulted in. And so, the same for generic. Sometimes the brand is cheaper from the generic until we have enough competition on the generic side for that price to really come down.
This is Peter Barquette. I wonder, Ryan or Donna, if you're able to speak to the pharmacy PMPM relative to other health plans. I imagine it's quite a bit lower because of some of the favorable pricing, but I'm curious, what is the industry standard for other health plans?
Ryan, did this include net of rebate dollars? I forget.
Yes. Oh, that's right.
Okay.
Yes, it did.
It's really hard. That's a really difficult question to answer, because our rebates are so different from a commercial health plan. We have statutorily defined rebates. I get a rebate on a drug regardless if it's preferred or not preferred, with our federal rebate system. It's our supplemental rebates, which are in addition to that federal rebate piece, is where the preferred status would come in, which is more like a commercial health plan. If it's a brand name drug, if it's going to get a rebate, the plan typically has to put it in a preferred position with limited or no restrictions. So it couldn't be on prior authorization, or you couldn't require step therapy, that kind of situation. And every health plan is different. I don't have like what our uniform medical plan PMPM numbers are off the top of my head. But the drugs, probably, when you look at the top 25 drugs and drug classes, I think the classes are very similar. The specific PMPMs are probably going to be very different, though.
A good example is if you think about our UMP population, we have our Medicare population as well. So we do see a lot more oncology there than we would here, like today, looking at these top 25 costs. Similarly, we're seeing a lot more HIV here in the Apple Health population than we do in UMP. So there are, some differences, but for the Stellaras, Dupixents, Victozas, those classes are all up there at the top for UMP, but unfortunately we didn't prepare any information on UMP today.
Oh no, this is John again. So just when you look at the drivers of future costs on a per member per month, it looks like it's primarily driven by specialty pharmacy. How do you contain that kind of growth, like when they're so specialized and disease states?
My cynicism, John, there is no controlling that. There really isn't. We're just like every other payer. We're at the mercy of the manufacturer setting, really high prices. And, the rebate system itself has created kind of this mess that we're in, because as manufacturers are pressured by pharmacy benefit managers to give them rebates to reduce their client, the PBM's clients prices, the manufacturers have to keep raising their price in order to keep their revenue streams, and so it's really a vicious cycle. So we put them, that's why we have, all of our clinical policies on prior authorization. And, we take that into account when we are, the cost into account on deciding what gets put on prior authorization. That's why Victoza, our preferred GLP-1, it's relatively inexpensive compared to some of the other GLP-1s that we have, where there would be maybe $2 or $3, double the cost per member per month, for the convenience of a weekly dose. And so we do put policies in place and try to steer our members to the less, the most cost-effective drug in that class, but also maintaining access, for those people that, have a that really can't take the preferred drug and need to have that non-preferred prescription filled.
This is such a great discussion and a lot of what all the systems at large and the country at large is grappling with as far as the rising drug costs. Ryan, this is an excellent presentation. I think it's just so clarifying when we see some of these numbers in the context of the decisions that we make. I completely respect keeping the clinical decision making separate from cost discussions, but I mean, to an extent, the awareness of these drug costs and the comparisons are really valuable in us thinking about our policies more effectively. Committee, other comments, questions for Ryan? And if not, Marissa, did you have anything else to add?
This is Marissa. No, I don't have anything to add besides the fact that moving forward for the upcoming DUR board meetings, we do plan on, presenting more of these utilization data analyses to you all, kind of as we kind of tweak it and get a little bit better at them. So we, this is really just an introduction as far as introducing you all to kind of what that data looks like, how we are presenting it, but we can get a little bit more specific moving forward as far as, drilling down to specific drug classes, drilling down to specific drugs, drilling down to specific MCOs. So that's just more to come. We do have one planned, I believe, in August. We are still working on that. But yeah, we do welcome any feedback that you all might have as far as what you were presented today. So just feel free to let us know, things that you might be interested in improving the presentation, or like I said, just things that you might be interested in seeing overall.
Thank you, Marissa. Yes, we've been craving this drug utilization data, so this is a great start, and yeah, we're looking forward to more. Peter, you had something to say?
Yeah, thanks. Yeah, I have one other question. As a percentage of the medical loss ratio, what is the pharmacy spend doing over time? Is it trending higher as a percentage of overall spend relative to other buckets like professional services or hospitalizations or elective surgeries, or has it stayed pretty steady?
Hi, Peter. This is Donna again. That's a great question, and I hate to try to guess. I think it's holding its own. and it's probably growing. It makes it challenging. What we're presenting to you today is just drugs that are dispensed, at a community pharmacy or possibly mail order pharmacy, but, is an outpatient benefit versus drugs that are, administered under the physician, physician administered drugs. So I think the data that we get from our actuaries includes both. And that's something that we can maybe start looking at is some of the data that we actually do get from the actuaries looking at I don't know if they're really looking at the medical loss ratio per se, but they are, when we're setting our capitated rates, we could be looking at, how much of that capitated rate that we pay to the plan is attributed to drug cost.
Thanks. No, this is fascinating. It's often difficult to get this level of insight.
Thank you. Any other final comments, committee, before we move on to Nina Magellan? Okay. Hi, Nina. We're ready for you. Welcome to your firm.
Yes. All
This
right.
is Elizabeth.
So
Nina,
I am.
let me go ahead and get your slides pulled up.
Okay.
And
Thank you.
DUR board, just doing a time check, it does look like we only have about 45 minutes left in our meeting.
Yes.
I think the best plan is just to kind of see what we can get through moving forward. It might only be like one or two classes or, two agenda items. We'll do a time check kind of, I'll be mindful of the time after every motion and then kind of determine from there, like if we should proceed or not. So I'll just go ahead and have Nina present. I don't know if some of the DUR board, if everyone was there at the last meeting or not, but Nina Nguyen is our new Magellan account manager. She's slowly transitioning. It's from Umang to her. So this is her first meeting presenting for us here at our DUR board. So I just wanted to welcome her and then formally introduce her to you all if you all haven't met her yet. But Nina, I'll go ahead and let you take it away. I think I should be able to present here in a minute. And your slides should be showing, so whenever you're ready, I think you're good to go.
Okay, thank you for the introduction, Marissa. We'll go ahead and start my presentation. So on the next slide, you'll see the agenda topics for the classes that will be reviewed. We will be going over the disease states, any recent updates in the past 13 months, including indications, dosage, formulation, and guidelines. On the top in blue is the prime therapeutic market baskets, and the words on the below in black is the Apple Health drug classes. So for the first Apple Health drug class we will be going over is anti-diabetic cellular therapy, which falls under the prime therapeutic market basket disease modifiers type 1 diabetes. So the first disease state we will be going over is type 1 diabetes. It is estimated that over 37 million Americans have diabetes. Diabetes is responsible for increased morbidity and mortality, and achieving adequate glycemic control is crucial to minimize chronic microvascular and macrovascular complications. Misclassification of type 1 diabetes in adults is common, and over 40% of those diagnosed with type 1 diabetes after the age of 30 years were initially thought to be type 2 diabetes. Distinguishing features of type 1 diabetes include younger age at diagnosis, so less than 35 years old, a lower BMI of less than 25 kilogram per meter square, unintended weight loss, ketoacidosis, and glucose greater than 360 milligram per deciliter. A family history of type 1 diabetes or a history of autoimmune disease may also be present. The 2023 American Diabetes Association advises that most adults and children with type 1 diabetes be treated with multiple daily insulin injections of prandial and basal insulin or continuous subcutaneous insulin infusions. Rapid-acting insulin analogs are typically used to reduce hypoglycemic risk. Continuous glucose monitoring, CGMs, should also be considered in most patients. Automated insulin delivery systems are recommended to improve glycemic control and reduce hypoglycemia. The rapid-acting insulin, insulin aspart, insulin glulisine, insulin lispro, insulin lispro AABC, and insulin lispro protamine lispro combinations are approved for use with insulin pumps. Okay, here we have Lantidra denisocel. So in June 2023, FDA approved denisocel, the first pancreatic islet cellular therapy made for deceased donor cells for the treatment of adults with type 1 diabetes who are unable to approach target hemoglobin A1C because of current repeated episodes of severe hypoglycemia despite intensive diabetes management and education. There is a warning for risk from concomitant immunosuppression, which includes increased risk of severe infections, including opportunistic infections, malignancy, and severe anemia. There are also procedural complications such as liver laceration, hemorrhage, and intra-abdominal bleeding with portal administration. The dose is individualized based on tissue volume. The recommended minimum dose is 5,000 equivalent islet number EIN per kilogram for initial infusion and 4,500 EIN per kilogram for subsequent infusion in the same recipient. The maximum dose per infusion is dictated by the estimated tissue volume, which should not exceed 10 ml per infusion, and the total EIN present in the infusion bag, which is up to a maximum of 1 × 10⁶ EIN per bag. The second or third infusion may be performed within 1 year of the previous infusion or within 1 year of losing independence from exogenous insulin. Pre-infusion induction immunosuppression is required. It is available as a cellular suspension administered as an IV infusion into the hepatic portal vein. Each infusion uses 1 lot of Lantidra, which consists of islets manufactured from the pancreas of a single deceased donor. The dosage strength is represented by the total EIN in a single preparation and varies between product batches. And that is it for disease modifiers. I'll go ahead and pass it back to the committee.
Thank you, Nina. Questions for Nina from the committee?
As Peter Burkett, I have a question. So patients would get, before Lantidra, they would get immunosuppression, and then presumably they would stay on immunosuppression indefinitely, or if they got to a treatment failure, would they come off of immunosuppression? Would that be safe?
Hey, Dr. Barquette, it's Umang. I believe there is a phase where the patient is taken off, but if you give me a few minutes, I can double check that for you.
Thanks. Yeah, I guess a simpler way of stating the question is, are patients committed to lifelong immunosuppression after the treatment?
It does, actually, I stand corrected, it does require lifelong immunosuppression.
Okay.
Other questions? Any stakeholders, Nanya? Or Marissa?
This is Marissa. I will ask Nonya if there's any stakeholders, but for my end, I will just go through our PDL just so you all are aware. It's pretty straightforward for this class. For this one, we just have the one product that Nina had mentioned, which is the Lantidra, and that is preferred with PA on our AHPDL. So I can answer any questions about the AHPDL, and then Nonya, I'll kick it off to you if there's any stakeholders that we need to take into account.
No problem.
Okay, any questions? And I don't see any stakeholders listed here.
And there are no stakeholders' hands raised.
Okay. Thank you for loading the motion. Or I guess could be there. My question for like a new agent and like there's only one option in this drug class. When we make a motion like this, would a policy be reviewed at the same time? Because you know a lot of the things in here don't really apply to this agent. There's no non-preferred, there's no alternatives.
This is Marissa. No, so we don't have a policy that would be reviewed. Just because one, we don't have one created at this time. We do try our best to align if there are policies that do fall within like a drug class you are reviewing. We do try to make it align with like when that drug class is being reviewed. But in this current state, no, you don't have a policy. You're just kind of doing the same motion that you usually do when you do these reviews. If we do have a motion, we will bring it to the DUR board meeting in the future.
Got it. So this motion is primarily whether this agent enters the Apple PDL or not.
Yes.
Got it.
It is currently on there. Yeah, it's just a formality as far as reviewing it. This product has never been reviewed ever, to my recollection, on our AHPDL before because it is a brand new product. So we do want to just make sure we bring it all to you first, you know, so that then it's gone through our normal DUR board process. And then of course, moving forward, it'll keep coming back kind of as often as we would like it to. If there's any policies, anything that might change, we will definitely bring it back.
Okay. Okay, with that committee, any questions? Yeah.
Sorry, so if there was other drugs in this class, which I'd imagine eventually there will be, then it would come back.
This is Marissa. Yes, it would come back. Yep.
So just to clarify, so without a policy and just needing a PA, this can be submitted and are there certain criteria they're having to meet then? Because normally our policies, like that we've reviewed in the past, is specified. It seems like a very specialized medication that would require several things to qualify for the medication. How is that evaluated then without a policy?
Yeah, this is Marissa. So typically when we have new drugs that come to market and that get placed on our PDL and we don't have a policy for them, we do review them generally. We do review them by their FDA labeling for medical necessity per their labeling. We can, as we do those reviews, because sometimes labels can be very broad, we can ask providers for specific, you know, clinical information that we might be interested in. So for example, in this case, you know, we could request A1C labs, we could request, you know, looking back at clinical trials, maybe kind of monitoring those things and asking for those specifics. But generally, that is our rule of thumb of just reviewing it per the labeling. And then on special circumstances, we can request additional information and then take that into consideration as we do the reviews.
Great question. Any other questions before we proceed with the motion? And if not, I think the verbiage here is pretty much our standard boilerplate language for the agents.
This is Laura Bestie. I make a motion that I move that all products in the antidiabetics cellular therapy class are considered safe and efficacious. Whoops, I can't read it. Wait, my pin's smaller. Safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Zoe Taylor. I can second.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Great. With that, the motion carries. And our next set is cardiovascular agents. Back to you, Nina.
Thank you. So next we have cardiovascular agents, miscellaneous. Between 2013 and 2019, the American College of Cardiology and the American Heart Association, in combination with National Heart, Lung, and Blood Institute, released 4 new consensus guidelines regarding cholesterol management, cardiovascular risk assessment, obesity, and lifestyle. Obesity is associated with increased risk in cardiovascular disease mortality. In 2018, ACC and AHA emphasizes lifestyle modification, including a reduced calorie diet and aerobic physical activity, as a critical component of atherosclerotic cardiovascular disease risk reduction, both prior to and in conjunction with cholesterol-lowering drug therapies. In June 2021, AHA published a scientific statement on physical activity as a crucial component in the first-line treatment for increased blood pressure and cholesterol. The statement detailed mild to moderate risk patient groups appropriate for lifestyle-only treatment of increased cholesterol, as well as a description of the recommendations, usual effects, and consideration for lifestyle management with physical activity. In 2023, AHA also published a scientific statement which reports that resistant training has a favorable but modest effect on total cholesterol, triglycerides, and high-density lipoprotein cholesterol. Evidence for the effect of resistant training on low-density lipoprotein cholesterol is more variable. So here we have Ladoco, which is colchicine. So in June 2023, FDA approved colchicine 0.5 milligram tablets to reduce the risk of MI, stroke, coronary revascularization, and CV death in adults with established atherosclerotic disease or with multiple risk factors for CV disease. This medication has multiple warnings, including blood dyscrasias such as myelosuppression, leukopenia, granulocytopenia, thrombocytopenia, and pancytopenia, and aplastic anemia. It can also cause neuromuscular toxicity such as myotoxicity, including rhabdomyolysis, especially in combination with other drugs known to cause this effect. Consider temporary interruption or discontinuation of this medication if that occurs. There are contraindications for patients with pre-existing blood dyscrasias, renal failure, and severe hepatic impairment. The recommended dose is 0.5 milligram once daily, and it is available as a 0.5 milligram tablet. And that is it for cardiovascular. I'll pass it back to the committee.
Thank you, Nina. So to be clear, I think the only one we're looking at is colchicine then for this section. Yeah. Okay. There it is.
This is Marissa. Yes. Looking at the drug class, it looks like that's the only product that's there. So it is preferred on our PDL.
Great. Under this class, would the well, I'm guessing not, like the other newer agents like the bempedoic acids and all those come under play, but or those would be more specific for lipids.
This is Marissa. If it's not in this class, it most likely lives in another class. The name of the class, however, escapes me. And unfortunately, what you all have as far as like the AHPDL Excel document is only really a snapshot of the classes that are being reviewed. So I'm not sure exactly where that falls. I know it's on our PDL for sure. I just don't know what class it is. But we do try to separate them by their mechanism of action. This product is, just for reference, it is so much different than the other cardiovascular agents that we have on our PDL. Even though it is colchicine, the indication of it is not for gout. It's for another indication, which makes it a little bit more special, hence why it has its own class. So that's kind of why it's separated from everything else.
Thank you,
Hi, this
Marissa.
is Laura. I had a question for you. Is the release mechanism of this colchicine product different than I'm not that familiar with it, so kind of curious than just plain colchicine that we use for gout.
This is Marissa. And Nina and Umang, I don't know if you all have insight into it, but from what I can recollect when I was looking at, it's been a while since I looked at this class, but when I did see it, it didn't strike me as any different than, regular generic colchicine that's been out on the market. So to my knowledge, it's the same, just a little different brand name. But I don't know, Nina or Umang, if you all know any nuance differences between it or if it's different. I didn't see any, so I'm not aware of any.
I did not see any as well, Marissa.
In the Lodoco trial, they just used this dosing of colchicine. I don't know if it's because it was not out of US, because I thought that the only one we had access to was the 0.6 milligram tab. But yeah, there was no like delayed release or anything like that in that study. Okay.
It seems sneaky, like it's purposeful.
They're trying to
to,
keep you from
yeah.
Yeah.
All
Which is how
marketing.
which the 0.6 came about because we used to have 1 milligram tablets, and then the drug was so old it was approved, and when they went and got approval, they didn't want you to split 1 milligram tabs, so they did providers were already using 0.5 milligram, and they chose 0.6 on purpose because it doesn't make a significant difference, right?
Fascinating. Oh, golly. But not surprising. Thank you.
It's all gamesmanship for these old drugs, like alcohol got approved for cardiac ablation off data that was ancient for cardiac too, because the drug is, pre 1932, so it's so.
Looks like this one's 0.5 milligrams versus 0.6.
Exactly. Yeah.
Are there questions and any stakeholders, Nadia? I didn't see any listed.
And there are none that raised their hands at this time. Thank you.
Thank you. There's the motion.
This is. Oh, go ahead.
Go for it. You start first.
This is John McKay. I move that all products in the cardiovascular agents miscellaneous class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products within the same indication before non-preferred drug will be authorized, unless contraindicated not clinically appropriate, or only one product is preferred.
This is Kevin for my second.
All in favor, please say aye.
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 Any opposed or abstain? Thank you. With that, the motion carries. And back to you, Nina.
This is Marissa. So Nina, I believe we have allotted about 25 minutes for your next kind of section, and we have 20 minutes left. Do you think we'll be able to get through it in 20 minutes, or do you think you'll need the full 25? Not to put any pressure on you or anything.
I think we can get through it.
Okay, I will go ahead and set up the next section for you then.
Okay, thank you. Okay, so next we have stem cell mobilizer. Okay, so the disease state multiple myeloma is a malignant neoplasm of plasma cells that accumulate in the bone marrow, leading to bone destruction and marrow failure. In addition, patients with symptomatic multiple myelomas must have greater or equal to one myeloma-defying event, which may include hypercalcemia, renal insufficiency, anemia, or lytic bone lesions. Multiple myelomas account for approximately 1.8% of all malignancies and 18% of all hematologic malignancies in the US. The median age of diagnosis is 69 years. Multiple myeloma is sensitive to a variety of agents, but the disease is not considered curable with currently available drug therapies. The clinical course of multiple myeloma usually involves initial responses to chemotherapy, but these responses may be transient. Thus, retreatment with multiple rounds of therapy with different agents may be required to treat relapse. The 5-year relative survival rate is 57.9%, and overall survival now is estimated to be 8 to 10 years among patients with standard risk disease, but it is significantly lower in patients that exhibit high-risk features. Here I included the overview of the 2022 NCCN guidelines. Since they are well over 1 year old, I've just included it here for completeness sakes and for your review during your leisure. So the medication we're going over today for this class is Effexta multisaffordide. So in September 2023, FDA approved Effexta, a hematopoietic stem cell mobilizer indicated in combination with filgrastim to mobilize hematopoietic stem cells to the peripheral blood for collection and subsequent autologous transplantation in patients with multiple myeloma. There is an anaphylactic shock and hypersensitivity reaction warning, so all patients should be pre-medicated with the combination of an H1 antihistamine, an H2 blocker, and a leukotriene inhibitor prior to each dose. Effexta should be administered in a setting where personnel and therapies are available for immediate treatment. It can also cause injection site reactions, so the addition of an analgesic premedication, such as acetaminophen, is recommended. It can also cause tumor cell mobilization in patients with leukemia, therefore should be avoided in those patients. It can also cause leukocytosis, so we make sure to monitor the white blood cell count during use. Effexta is initiated after filgrastim has been administered daily for 4 days. The recommended dose is 1.25 milligram per kilogram of actual body weight subcutaneously 10 to 14 hours prior to initiation of apheresis. A second dose can be administered 10 to 14 hours prior to a third apheresis. And it is available as a 62 milligram lyophilized powder in a single dose vial for reconstitution. And that is it for stem cell mobilizer. I'll pass it back to the committee.
Hey Nina, this is Marissa. It does look like we have the stem cell mobilizers and the TPO stimulating proteins on one motion. So would you mind just going through this section so then we can do the motion for both of them at once?
Yes. I'll
Okay,
go ahead
thanks.
and go. Okay, so next is thrombopoiesis stimulating proteins. So immune thrombocytopenia is an immune-mediated disorder in which platelets are opsonized by autoreactive antibodies and prematurely destroyed by the reticuloendothelial system. In children, ITP is usually an acute, self-limiting disease that often occurs weeks after viral infection or immunization. Spontaneous remission in children typically occurs within less than or equal to 2 months in 80% of usual cases. Although treatment does not impact the likelihood for chronic ITP, it can shorten the duration of thrombocytopenia in some patients. In adults, ITP has an insidious onset with no preceding viral or other illness and typically has a chronic course. A complete blood count shows isolated thrombocytopenia. If anemia and/or neutropenia are found, it indicates the potential for other conditions. Signs and symptoms of ITP are highly variable and range from asymptomatic with mild bruising or mucosal bleeding to frank hemorrhage from any site. Severity of ITP in adults is dependent on the presence of active bleeding, as well as platelet count, patient age, patient lifestyle, related to risk of bleeding, and presence of additional risk factors for bleeding, such as uremia or chronic liver disease. Secondary causes of ITP include drug-induced autoimmune disease, such as systemic lupus erythematosus, and viral infections such as HIV and Hep C virus. Here I included the overview of the 2019 ASH guidelines. Since they are well over 1 year, I've included for completeness sake. Okay, the next disease state is aplastic anemia, which is caused by bone marrow failure. Most cases of aplastic anemia have an acquired cause. This can include idiopathic factors, infection, exposure to ionizing radiation, toxic chemical, pregnancy, and other conditions. Initial presentation is often related to anemia or bleeding. However, fever or infections may occur. Symptoms include dyspnea, fatigue, swelling of the feet, gingival bleeding, petechial rashes, infection, headache, and pallor color. The major causes of morbidity and mortality from aplastic anemia include infection and bleeding. Severe or very severe aplastic anemia should be treated promptly. Non-pharmacologic treatment include blood transfusions and hematopoietic cell transplant. Pharmacotherapy includes immunosuppressant agents such as cyclosporin, methylprednisolone, equine, or rapid antithrombocyte globulin, cyclophosphamide, and alemtuzumab. All off-label use except for the antithymocyte globulin, which is indicated for the treatment of moderate to severe aplastic anemia in patients unsuitable for bone marrow transplant. Approximately 25 to 30% of patients fail to respond to immunosuppressant therapy. Another pharmacotherapy agent used is the hematopoietic growth factors, eltrombopag and sargramostin, which is off-label, filgrastim, also off-label, and the anti-neoplastic agent fludarabine, which is also off-label. Monotherapy with hematopoietic factors, growth factors such as recombinant human erythropoietin, granulocyte colony stimulating factors, is not recommended for newly diagnosed patients. Chelating agents such as deferoxamine and deferoxarox may be required in patients chronically transfused due to elevated serum ferritin levels. Okay, here we have Alves, which is eltrombopag. So in November 2023, FDA has approved a new formulation of eltrombopag, Alvaz, a thrombopoietin receptor agonist indicated for 1. The treatment of thrombocytopenia in patients greater or equal to 6 years old with persistent or chronic immune thrombocytopenia who have had an insufficient response to corticosteroids, immunoglobulins, or splenectomy. This should be used only in patients with ITP whose degree of thrombocytopenia and clinical condition increase the risk of bleeding. It is also indicated for treatment of thrombocytopenia in adults with chronic hepatitis C to allow the initiation and maintenance of interferon-based therapy. It should be only used in patients with chronic hepatitis C whose degree of thrombocytopenia prevents the initiation of the interferon-based therapy or limit the ability to maintain the INF-based therapy. Treatment, and it also is indicated for the treatment of adults with severe aplastic anemia who have had an insufficient response to immunosuppressive therapy. There is a black box warning for risk of hepatic decompensation in the patients with chronic hepatitis C and risk of hepatotoxicity. Safety and efficacy has not been established in combination with direct-acting antiviral agents used without interferon treatment of chronic hepatitis C infection, and is not indicated for treatment of patients with myelodysplastic syndrome as it increases the risk of death and progression of MDS to acute myeloid leukemia. For dosing, for persistent or chronic ITP, it is recommended to initiate the dose at 36 milligram daily. Dose reductions are needed for patients with hepatic impairment and some patients of Southeast Asian ancestry. Adjust the dose to maintain platelet count greater than or equal to 50 times 10 to the 9th per liter, not to exceed 54 milligram per day. For chronic hepatitis C associated thrombocytopenia, it is recommended to initiate dose at 18 milligrams daily for all patients. Adjust the dose to achieve a target platelet count required to initiate antiviral therapy and not to exceed a dose of 72 milligram per day. For refractory severe aplastic anemia, it is recommended to initiate at the dose of 36 milligram daily. Again, reduce initial dose in patients with hepatic impairment or patients of East and Southeast Asian ancestry, and then adjust the dose to maintain platelet count greater than 50 times 10 to the 9th liter, not to exceed 108 milligram per day. It is available as 9 milligrams, 18 milligrams, 36 milligram, and 54 milligram oral tablets. And that is all I have for the last two drug classes.
Well done, Nina.
Thank you.
Questions for Nina from the committee as Marissa pulls it up.
All right, this is Marissa. So I did pull up the AHPDL for you all. It's pretty straightforward. These classes are not very big. So for the stem cell mobilizers, we do have Afexta as preferred. The other products are listed here, but I believe since they're probably medical and probably carve-outs, they don't have specific statuses here, but we do include them on our PDL just for completeness sake and communication sake for our MCOs and our stakeholders. And then for the TPO stimulating proteins, our preferred products are the Alvase that Nina had mentioned, and then we have Promacta tablets preferred. And I can take any questions from the board.
Any questions from the committee? While we wait there, Nanya, I don't see any stakeholders listed on the agenda. Do we have any with their hands raised?
No, I don't have any with their hands raised.
Thank you.
So this is Marissa. I kind of alluded to it in the middle of Nina's presentation, but we will just be doing one motion for both the stem cell mobilizers and the TPO stimulating proteins onto one slide. So it's similar to what you all have done before, but just wanted to be transparent about that.
Great. Yeah, and if we could look at the next slide so we could review the motion, great. Thank you. Any questions from the committee or edits or comments? The motion?
I can make the motion. Peter Barquette, I move that all products in the drug classes listed on slide 4 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of the HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Christy Weyland, I'll second.
All in favor, please say aye.
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 Any opposed or abstain? Great, with that, the motion carries. And over to you, Marissa.
Yeah, I think we have 5 minutes left, which I don't think is going to be anywhere close to the amount of time that we'll need for the AHPDL classes. So we are good to go as far as the DUR board meeting, things that we need. As far as the other classes that were scheduled for this meeting, I will look into the upcoming schedule to see if I can accommodate scheduling them for other DUR board meetings or future DUR board meetings this year. So you might see these come up. The ones that we didn't get to, you might see them come up again at the future meetings. The dates, I don't know why. I don't know the exact dates. I'll have to shuffle things around, but just wanted to put that out there for you all. I have everything I need. So Nonya, I will go ahead and pass it back to you. Thank you, DUR board.
Yeah, thank you, Marissa. I think we have everything we need so far. So, Kavita, you can join the meeting whenever you're ready.
Excellent. Well, thank you for a fantastic job today, DUR board. I know we had a especially long first half of the day. So with that, we adjourn the DUR board and have a lovely evening.
Thank you.
Bye.
Thank you.
Bye.
Bye.
You're a little one.
I know.
Oops.